Hello students. So let's start with the general anatomy. So when I talk about general anatomy part, the important things which should be known to you is the list of muscles in our body which is having the nerve supply that is more than one, dual nerve supply. Okay. Okay. So dual nerve supply is very important, and it is very important that you should have the knowledge about the two nerve supply, that is the dual nerve supply. Let's now concentrate on the session. So general anatomy. So now let's talk about the hybrid or composite muscle. So the concept of hybrid or composite muscle is that you should be knowing about that each muscle in this category is having nerve supply more than one. Okay. So there is more than one nerve supply, that is important. And let's have the discussion of the important muscles. So the first muscle in this category is trapezius muscle. Where is trapezius muscle located? At the back, as you can see in the back, in the neck region, as you can see in the back of the neck. And this is a very important muscles in the upper limb. And we have to know that it is having more than one nerve supply. So trapezius is the muscle which is having the innervation via two nerves, which are the spinal accessory nerve and also via the cervical nerve C3 and C4. Okay. Now digastric muscle, if I talk about digastric muscle, it is the anterior belly and it is the posterior belly. So digastric muscle is an important muscle in the neck region which is having two bellies, anterior and posterior bellies. Dr. Magnus is also in this list. So anterior belly and the posterior belly. So when I talk about the anterior belly of digastric muscle, it is getting innervation from the source of trigeminal nerve. Yes, students are already giving the answers very good. And posterior belly is supplied by facial nerve, which is the nerve of second pharyngeal arch. Now, as I talk about the brachialis muscle. So what is brachialis muscle? It's an important muscle of the category BBC. Biceps brachii, brachialis, and coracobrachialis muscle. So these are the muscles. So these are the muscles of the anterior arm. And in this list, brachialis is the muscle which is having major supply by the nerve of the anterior arm, that is musculocutaneous nerve. Musculocutaneous nerve. Very good, student. Very good. It's absolutely right. And the other is twig from the radial nerve. Now, what is the FDP muscle? The FDP muscle is the flexor digitorum profundus muscle. It's a muscle of the forearm that is lying in the deeper aspect in the forearm. It is the muscle again divided into medial and lateral part, and it is getting innervation. The lateral part of FDP is getting innervation from medial nerve, and the medial part of FDP is getting innervation from the ulnar nerve. So lateral part, yes, absolutely right, via the source of medial nerve, and the medial part by the source of ulnar nerve. Absolutely correct. Now coming to FPB. FPB means it's a muscle of thenar region. What is this? This is the pollicis and this is the little finger. Okay, this is digiti minimi and this is pollicis. So this area is called as thenar eminences. This area is called as thenar eminences, which is made of three muscles. In this three muscle, two muscles are hybrid muscle. One is flexor pollicis brevis. Here P stands for pollicis. Flexor pollicis brevis. So in the flexor pollicis brevis, the nerve supply is via both medial nerve and ulnar nerve. Yes, what is the full form of FPB? Flexor pollicis brevis. Flexor pollicis brevis. I would like to tell the students, be at most attentive to the class because it's a rapid revision. So we are going to cover the entire anatomy in this fast track session. Okay. Now coming to the other one, completing the list, we have got the opponens pollicis. Opponens pollicis is the other muscle of the thenar region, which is again having two nerve supply, that is the median nerve, and the other is ulnar nerve. Now coming to the next one, that is pectineus muscle. If I talk about the pectineus muscle, it is another important muscle of the lower limb which is having two nerve supply, one via the trunk of femoral nerve and the other via anterior division of obturator nerve. Okay, one via branch from the trunk of femoral nerve. That is a branch from trunk of femoral nerve, and the other is anterior division of obturator nerve. Adductor magnus muscle, the bulkiest muscle of the adductor region. What is adductor region? It is also called as the medial compartment of thigh. The medial compartment of thigh, which is called as the adductor region, it is also having two nerve supply. So my dear students are counting the pages and telling 350 slides. Don't worry about 350 slides. It's all about the images. So only it is 350. Okay. Don't worry about that. When I am talking about adductor magnus, it is having two parts. One is adductor part and the other part is hamstring part. The adductor part is supplied by obturator nerve and hamstring part by tibial component of sciatic nerve. Now coming to the next, that is the biceps femoris. The biceps femoris and another important muscle in the lower limb, which is having two heads, long head and short head. The long head is getting innervation from tibial part of sciatic nerve, as it is a part of hamstring muscle, and the short head is from the common peroneal part of sciatic nerve. The iliopsoas, the iliacus and psoas major muscle, can directly get innervation from the branches of lumbar plexus. So it gets direct branch from lumbar plexus and also get innervations from femoral nerve. So these are the list of the muscles which is receiving innervation from the two nerves, and they are the list of hybrid or composite muscle. Okay dear, now coming to types of joints. Now if I talk about the type of joints, it is very important for you to understand that we have got various joints. Okay. So we have got various joints, and it's very important that you should be aware about all the joints. Okay, you should be aware about all the joints of the body and important variety of these joints. It's also important that you should be knowing that it is belonging to which variety. So if I talk about the joints, the classification can be structural and functional classification. So when I am talking about structural classification, it is further divided into fibrous joint, the cartilaginous and synovial joint. So now if I talk about fibrous joint, the functional integrity of fibrous joint is that they are immobile joint, and the word which is used for immobile joint is synarthrosis. Now, why I want you to know these names? Because in the past year, FMG question, they have not exactly used the word, structural classification word, but they have given the functional classification terms for the joints. So it's very important for you to know the joints which is having no movement. They are called as synarthrosis, and the joint which is slightly mobile. What do you mean by the word amphiarthrosis? The word amphiarthrosis means slight mobility. And if I talk about diarthrosis, it means highly mobile joint. So highly mobile joint variety will be synovial joint. Slight movement joint, amphiarthrosis, will be cartilaginous joint, and no movement joint will be fibrous joint. So in this category, we have got sutures. If I talk about fibrous joint, that is synarthrosis, where no movement takes place. The variety is sutures, syndesmosis, and gomphosis. Cartilaginous joint can be categorized as symphysis and synchondrosis. So what do you mean by synchondrosis? Primary cartilaginous joint. What do you mean by symphysis? Secondary cartilaginous joint. And we have got various varieties of synovial joint, that is gliding joint, ball and socket, pivot joint, ellipsoid, saddle joint, hinge variety of joint. Okay. So let's move on to the types of joint. Okay. No students, for MBBS students we have to start with the basics. Okay, so it is enough for FMG students. Okay, but it will be beneficial for all the students. Okay, now type of joints with an example. So in this image you can see few varieties of fibrous joint. So which type of joint is the image showing? It is showing the fibrous joint. So fibrous joint examples are like, it is of various types sutures. It is of types like syndesmosis, gomphosis. Okay. So these are the joints. Then we'll come into the cartilaginous joint. Now, I want everybody to write the example. For example, if I am telling sutures, then that means skull suture. So which type of suture, like scamo, sagittal suture, lambdoid suture, coronal suture. So these are all variety of sutures of the skull. Syndesmosis means the articulation will have in between intraosseous membrane. So see here, I am outlining this with the green color. And what is this? This is the intraosseous membrane which is connecting radius and ulnar bone. So this type of joint is called syndesmosis. We have a two example of syndesmosis, the inferior tibiofibular joint and the middle radio-ulnar joint. Now talking about the third variety, that is gomphosis, which is seen in the tooth and socket joint, which is having periodontal ligament as shown in the image. So my dear students, have the example. Please write down quickly the examples of joint, which is the fibrous joint. Okay. So if I'm talking about fibrous joint, we have got following variety. This is the first variety. So the first one is sutures. Yes, yes, you are right. It is also called as diarthrosis. So you are absolutely right, my dear student. You are absolutely right. Now, let's write down few examples of sutures. So as I told you, important sutures are serrate suture, lambdoid suture, coronal suture. So I think everybody is aware of the name of suture. Wherever two bones of the skull will join, it will form sutures. And the other example, one specific name is given to the articulation between the two bones, rostrum and ala sphenoid. So we have got that called as synderesis. Synderesis. So synderesis is an articulation. If I talk about synderesis, it's an articulation which is seen between the rostrum and the vomer bone. So we have got the sphenoid and the vomer bone articulating. So that is important for you to know, that you should be knowing the name. That is highly important. So please write down. I would also like everybody to write the name of the bone, which is, so it is also actually called as wedge and groove joint. Why? Because here the joint is articulating, and this articulation is between the vomer and the rostrum of sphenoid bone. Vomer and rostrum of sphenoid bone. Okay. Done. Now coming to syndesmosis. The second so we have got the sutures. We have got the second one, that is called as syndesmosis. And as I told you, syndesmosis means the articulation is occurring via connecting ligament, that is intraosseous ligament. What is it called as? Intraosseous ligament. Okay. Yes, yes, you are right. That is the dentate and all. Yeah. Various kind of sutures are there. Very good. Yes, you are absolutely right, my dear students. Okay. So syndesmosis, the intraosseous ligament is interconnecting, my dear students. And the examples are, please write on the example, middle radio-ulnar joint, inferior tibiofibular joint, inferior tibiofibular joint. And the third variety is gomphosis. So here, as you have seen in the image, there was periodontal ligament which is connecting. And the example is tooth and socket joint. Tooth and socket joint. Yes, you are absolutely right. Now coming to the next variety. The next variety is cartilaginous joint. So for the cartilaginous joint, I told you it can be of two varieties. One is synchondrosis and other is symphysis, already shown in this image. So what is the other name of synchondrosis, my dear students? Synchondrosis is also called as primary cartilaginous joint, and symphysis is called as secondary cartilaginous joint. So actually the articulation in case of primary cartilaginous joint is interconnected as a bihyaline cartilage. So you can see the example will be this epiphyseal cartilage. So actually it is the junction of epiphysis and diaphysis of or epiphyseal plate in case of the growing long bone. And if I talk about pubic symphysis, another thing which has been shown in the pink color, the two hip bones are articulated. Actually, all the joint in our body which is lying in the midline, they are called as secondary cartilaginous joint. All the joints which is lying in the midline are secondary cartilaginous joint. And the example of secondary cartilaginous joint can be the manubrium sterni, pubic symphysis, intervertebral disc, sacrococcygeal joint. And synchondrosis example is the epiphyseal plate or cartilage. Okay, so these are most important examples. And other than that, we have got first sternocostal and chondrosternal joint, which is an example of primary cartilaginous joint. So my dear students, please quickly write down the examples. Okay, so first we will write down the example of synchondrosis. The primary cartilaginous joint articulation is via hyaline plate, and the examples are so actually it's an articulation between epiphysis and diaphysis of long bone. Other than that, it is also found in case of first sternocostal joint. That is articulation between the sternum and the costal cartilage of the first rib. First sternocostal joint. Now coming to the third variety, that is all chondrocostal joint. All chondrocostal joint. Articulation between the cartilage and the ribs. Now coming to the second one, that is the secondary cartilaginous joint, which is also called as symphysis. So my dear students, all the joints which is lying in the midline are the example of symphysis. Now the examples are intervertebral disc, manubriosternal joint, pubic symphysis, which is the articulation between the two sides of the hip bone, pubic symphysis, sacrococcygeal joint. Now, coming to the most mobile joint in our body. Now, coming to the variety of most mobile joint in our body, what is the most mobile joint? Diarthrosis, and they are, yes, thank you so much. Yes, actually, if we go, anatomy is a vast subject interconnected with various clinical subjects. So we can't just leave many important topics. And I want that in the examination, all of you get more than 50% marks, and you show that we should cover the most important topics of anatomy for the FMG exam. So if I talk about the synovial joint are the most mobile joint, diarthrosis, and the important varieties has been shown in this image. So we can definitely see the important joints has been shown, like plain joint has been shown, the other joints like hinge joint has been shown. So many of the joints. So basically in this diagram, the major example of ball and socket joint, ellipsoid joint, pivot joint. So many joints which are in our body has been demonstrated in this image, and the examples has been written also. So, but I want that individually that is asked in the examination. So, with quickly we can write the important joints. Okay, already we can see like this is the plain type of plain synovial joint. The elbow joints and all are hinge variety. Radio-ulnar joint is pivot joint, and we have got wrist joint as ellipsoid joint. So here this is showing plain joint, plain synovial joint, hinge synovial joint, the pivot synovial joint, the ellipsoid synovial joint. Though we will also have we also have in the first, if we talk about first carpo-metacarpal joint, first thumb joint is also shown as the saddle joint. And also we have got the example of ball and socket joint. So basically these are the major variety of joint, but it is important that not only this, you should be knowing the example of each variety. Okay. So let's talk about the synovial joint and the important varieties of synovial joint. So I would like to start with the plain joint. Okay. So let's start with the first variety, that is plain synovial joint. So if I talk about plain synovial joint, the important varieties of plain synovial joints are acromioclavicular joint, intercarpal and intertarsal joint. So we will have intercarpal and we will have the intertarsal joint. And also the articulation which is seen between the superior and inferior facet of the vertebrae are the example of plain synovial joint. Articulation between superior and inferior facet of vertebrae. Which facet? Articular facet of the vertebrae. Now, other like saddle joint, the saddle joint articulation like the horse saddle. The examples are sternoclavicular joint, we will also have the first carpo-metacarpal joint of the thumb. Actually, first carpo-metacarpal joint of the thumb is of saddle variety. Rest all carpo-metacarpal joint of the thumb is of variety of plain type of synovial joint. Also, we will have calcaneocuboid joint in the foot. Next, pivot joint, the pivot type of synovial joint where rotational movement takes place. So here, if I talk about the rotational movement, so actually, if I talk about superior and inferior radio-ulnar joint articulation, it's of pivot type of synovial joint, and also atlanto-axial joint, that is an articulation between the first and the second cervical vertebra in the midline. Superior and inferior radio-ulnar joint. Median atlanto-axial joint. Now coming to ellipsoid variety of synovial joint. Wrist joint, metacarpophalangeal joint and metatarsophalangeal joint. Metacarpophalangeal joint, that is articulation between the metacarpals and the phalanges. Metatarsophalangeal joint. Now coming to the hinge variety of synovial joint. Hinge joint is elbow joint, ankle joint, and interphalangeal joint. Okay. Now coming to ball and socket synovial joint. So if I talk about ball and socket synovial joint, it's a highly mobile joint. And the most important example is the hip joint, articulation between the head of femur and the acetabular cavity. The shoulder joint, which is also called as the which is also called as the glenoid joint. So that is an articulation between the glenoid cavity of scapula and the head of humerus. And the other variety is the articulation between incus and stapes. So incus and stapes joint. Actually, incus and stapes are the two ear ossicles of the middle ear. The other one is the malleus. Incido-stapedial joint is ball and socket. And so I just want to add one more joint in the saddle joint that is called as incus and malleus. That is incido-mallular joint. So these are the most important joint which you should not forget. Other than that, we will have condylar joints, which shape is like a condyle, like TM joint, knee joint. Okay. So all these are the important varieties of joint which is commonly asked in examination. So now, my dear students, are you ready for the MCQ session? Are you ready for the MCQ session? Now we have finished the important general anatomy topics. Now I want that you should solve MCQs along with me. Composite. So let's quickly solve it. Okay. All of the following are the list of composite or the hybrid muscle except. So I'm getting an answer C. So C is absolutely right answer. Rectus femoris. Rectus femoris is only receiving innervation from femoral nerve. Other than that, pectineus is having obturator and femoral nerve supply. Adductor magnus is also having innervation. Adductor part from obturator nerve and hamstring from tibial part of sciatic nerve. Biceps femoris is having short head and long head. Both receives innervation from tibial part of sciatic and the common peroneal part of the sciatic nerve. Now coming to the second one, all are composite muscle except whether it is the pectineus, flexor carpi ulnaris, biceps femoris, flexor digitorum profundus. So here many of the students again has come up with their answer, and my dear students are absolutely right. The correct answer is flexor carpi ulnaris because it is receiving innervation only from ulnar nerve. Now type of joint which is formed between the articulation between sacrum and the coccyx bone. Now type of joint. So type of joint which is formed between sacrum and that of coccygeal joint, coccyx bone. So please mark the right answer here. Yes, dear students. Yeah. So again, the students are coming up with their answers. Yeah. So again, you are right. It is symphysis. So it is it's a joint where the midline joints are secondary cartilaginous joint which has got articulation of fibrous material, fibrocartilaginous joint with hyaline cartilage. Okay, so absolutely right. Symphysis is the right answer. Which type of joint is formed between malleus and incus? So we know that there is 3 ear ossicles, and what is the articulation which is formed between the malleus and incus ear ossicles? So yes, please mark the right answer here. Oh, again, the students are coming. Yeah, it's malleus and incus. It's not incus and stapes. It's malleus and incus. So yes, I am getting answer right. Yeah, it's a saddle variety of synovial joint. Absolutely correct. Atlanto-occipital joint is of which variety? Okay, I didn't write the example, but let me check whether you are knowing it or not. So so can you guess it whether it is atlanto-occipital joint is which variety? It is condylar, saddle, trochoid, or ellipsoid? Yes, ellipsoid is definitely right answer. So in ellipsoid variety, you can add the name atlanto-occipital joint. That is the articulation between first cervical vertebra and occipital bone. So yes, this ellipsoid is the right answer. If you want to add on, you can just add on here. In the ellipsoid variety, you can add one more example, that is atlanto-occipital occipital joint. Now coming to the next question. What type of joint is growth plate? What type of joint is a growth plate of growing bone? What type of joint is the growth plate of growing bones? Here comes right answer. Yes, it is primary cartilaginous joint is absolutely right. Yes, that means it is an articulation between the epiphysis and diaphysis of the growth bone, epiphyseal cartilage. Which type of joint helps in pronation and supination of forearm? Actually, it's a previous year FMG question. So we know that supination, what is supination and pronation? This is supination, this is pronation. This is supination, this is pronation. So it is happening at which articulation between radius and ulna, and then you can come up with the right answer. Yeah. Supination and pronation happens at the which joint? So that is an hint. Yes, it is pivot type of synovial joint. It happens in the middle radio-ulnar joint. Yes, A is absolutely right answer. Very good. Now, this is an image-based question. So, this is the last MCQ of general anatomy. And this is an image-based question. Identify the type of joint. So, the arrow is here and here you have to identify. The arrow is, so we can see here, this is the R for radius bone and this is U for the ulnar bone. So here in this diagram, we can see the radius and ulnar bone is articulating. So in the middle, there is an interosseous membrane which is connecting radius and ulnar bone. So can you tell me which type of joint is it? Absolutely right. It is syndesmosis. It is syndesmosis. Okay. Yes. And this is helping in the movement of supination and pronation. Yeah. Now we will come with the upper limb category. Now coming up with the upper limb. So let's upper limb is another important topic which you have to know many important topics for your examinations. I would like to start with the first important topic in this reason, that is anatomical snuff box. So what we have seen in the previous year, anatomical snuff box has been asked multiple of times in the examination. So actually images has been made and many labelings has already been done so that it becomes easy for you to identify this area. And why multiple images? Okay. So why anatomy is full of images? Because image-based question, clinical questions are targeted for the upcoming examination. So as you can see, when you extend the thumb, hyperextend the thumb, in many of you students and many of the people, we can see that on the dorsum of the thumb, below the thumb, here dorsum area, here we can see a triangular depressed area that is called anatomical snuff box. The anatomical snuff box in this diagram, as you can see, it is bounded anterolaterally. This is bonded anterolaterally by the tendons of which two muscle? APL and EPB. What is the full form of APL, my dear students? Abductor pollicis longus. Abductor pollicis longus. And what is the full form of EPB? Extensor pollicis brevis. Pollicis means great, our thumb. Okay. Now, posteromedially, so this is the boundary anterolaterally, and PM for posteromedially. PM means posteromedially, it is bounded by the tendon of EPL. What is the full form of EPL? Extensor pollicis longus muscle. Extensor pollicis longus muscle. Now, so we are now knowing about the boundaries of anatomical snuff box. And my dear students, can you see the red color structure, that is the radial artery, which is residing between these muscle tendon, and that is the content. So radial artery is the important content of anatomical snuff box. In the next image, what you can see, there is a blue color vein. What is that? That is called as saphenous vein. So we will have the saphenous vein which is crossing the roof, and also we will have the cutaneous branch of radial nerve which is crossing the roof. So in this image, we can know the boundaries, we can know the roof structures, and we can know the content. Now there is one more cadaveric image in which you can appreciate the boundaries. Okay. So here I want everybody to practice this. So this is a very important image which has to be practiced. So we'll come with this image once again. Let's see, let's quickly revise it. So the same thing which I have shown you in the image has been written for your practice, that medial border, or you can say to be more specific, posteromedial border will be the tendon of extensor pollicis longus muscle. Anterolateral border, that is when you hold it in anatomical snub box in the anatomical position. So we will have the boundaries of these muscles. So we will have medially, we will have extensor pollicis longus, and laterally we will have the two tendons, APL, abductor pollicis longus, and EPB, extensor pollicis brevis. Proximal border is by the radius lower and stelloid process. The floor is having two. It's very important for you to note that the floor is made of two bones, that is scaphoid and trapezium. So they are carpal bone. We know that altogether there are 8 carpal bones in the proximal and that of distal row. So we have got C looks too pretty, try to catch her. This is the mnemonic to memorize the 4 carpal bones in the proximal and the 4 carpal bones in the distal row. C looks too pretty, try to catch her. Scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, and habit. The roof is having skin and superficial fascia, and as I have already shown you in the image, the roof or superficial fascia is containing two structures. What is it? The superficial branch of radial nerve and cephalic vein. Yes, Cossack, I will send. Now, I want everybody to just have a look on this cadaveric image. And as this is very, very important, I want that you should be knowing about this cadaveric image along with this boundaries. Okay, so it's very, very important. So I just want that I will slightly enlarge this image so that you can get a better idea. Okay. Okay. So after enlarging, please mark the boundaries. So as in this diagram, also we can appreciate. So I just want everybody to write the boundaries. So you can see the two tendons I have highlighted. So this is the posteromedial tendon, and I think you can mark it right. It is the tendon of EPL. What is the full form? Extensor pollicis longus. And we will also have the two tendons laterally. We will have extensor pollicis brevis and abductor pollicis longus tendon. Got it? Now, done with this. Now coming to the next topic. Okay, the clinical anatomy. Now, in the clinical anatomy, I just want you to understand that one of an important content or the floor bone is scaphoid. So basically what happens if somebody falls on the ground, if someone falls on the ground with an hyperextended hand, there is after that injury, the patient complains that he or she is having pain and tenderness in the anatomical snub box. What does that mean? It means that the scaphoid bone has been fractured and the blood supply of scaphoid bone is hampered. And the reason is that the blood supply of the scaphoid bone is towards the scaphoid bone through the dorsal aspect, and because of that there can be a quick management of the case is not done. So a complication associated with this injury will be that the patient can have avascular necrosis of the scaphoid bone because of this peculiar blood supply. Okay, now we will come on to the next topic, that is cubital fossa. So actually cubital fossa, if you will see the front of the elbow joint here, there is a triangular depressed area, that is cubital fossa. So we have to know about the boundaries of cubital fossa and we have to know about the contents of the cubital fossa. So for understanding that, I would like everybody to have a look on this image, and you have to draw an imaginary line connecting medial and lateral epicondyle. So we will just connect the medial and lateral epicondyle by an imaginary line. This imaginary line which is connecting these condyles, this is the medial epicondyle. Sorry, this is the medial epicondyle and this is the lateral epicondyle. Now, if we draw an imaginary line connecting these condyles, this is forming the base. So what is this? This is the base of the cubital fossa, and BR stands for brachioradialis. What is the full form of BR? Brachioradialis. And PT is pronator teres. So brachioradialis is forming the lateral boundary of cubital fossa and pronator teres is forming the medial boundary of cubital fossa. And an imaginary line is made passing through medial and lateral epicondyle of the humerus bone. So this is altogether the boundaries of cubital fossa. What about the apex? So if this is the base, the apex is formed by, so this is medial border, the pronator teres. Brachioradialis is the lateral border, and the brachioradialis overlapping over the pronator teres is forming the apex of the cubital fossa. Now, what about the content? There is a very good mnemonic for understanding the content of cubital fossa from medial to lateral. So, if we are talking about that, the mnemonic is MBBR or MBBS. So, this is the mnemonic. This is for medial to lateral content of cubital fossa. So, here M stands for median nerve as shown in the diagram. B stands for the brachial artery as shown in the diagram. And we have got another B as the biceps tendon, that is the third content, and the fourth content is radial nerve, which is also the superficial branch of radial nerve has been shown. So basically we have got four contents from medial to lateral in the cubital fossa, MBBR, medial nerve, the brachial artery, the biceps tendon, and the branch of radial nerve. Got it? So this is about the content. So I just want, the same thing has been written here. Also, I want everybody to know the roof is made of skin superficial fascia and the bicipital aponeurosis. What is bicipital aponeurosis? It's an extension of the biceps brachii muscle tendon extending towards the ulnar bone. If I talk about the floor structure, the floor is having two muscles. We have got brachialis muscle in the upper part of the floor, the proximal part of the floor, and lower down we have the supinator muscle. Now, one more diagram is there for you in which we can see, I have written, if you will see, the floor structure has also been shown in this image, and here we have got B and S. B here stands for, so you can just write on, B stands for brachialis muscle, S stands for supinator muscle. Okay, and the contents are median nerve, brachial artery, biceps tendon, and the radial nerve. Okay, done. So we have done with this, and also in this diagram, one important point which you can note down, ulnar nerve has been shown passing posterior to medial epicondyle. Also, a part of musculocutaneous nerve has been shown. As we know, why musculocutaneous nerve is visible in this image, because we know the biceps brachii, the brachialis and coracobrachialis muscle are innervated by musculocutaneous nerve, the nerve of anterior arm muscle. Okay, now this is a schematic diagram just to make you understand the same thing which I have already shown you. This is the red color line, that is the base passing through medial and lateral epicondyle. Pronator teres, the medial border. The brachioradialis lateral border. We have got also the important contents which I have already shown. So done with the cubital fossa. I think everybody is aware with the topic of cubital fossa. So what all things you have to know? You have to know boundaries, and you have to know content, most importantly. And if you want to know the roof, so there are few structures in the roof of cubital fossa, that is cephalic vein, basilic vein. The cephalic vein will lie laterally in the roof, in the superficial fascia of the roof. Basilic vein will lie medially in the superficial fascia of the roof, and the vein which is connecting these two veins are called median cubital vein. Median cubital vein is very commonly used for draining out blood samples in case for investigation purpose. Median cubital vein. And the other nerves are lateral cutaneous nerve of forearm, lateral cutaneous nerve of forearm, and medial cutaneous nerve of forearm. Medial cutaneous nerve of forearm. Okay, done with this? Now the next topic. So now a very important topic of the next important topic for the upper lip for your upcoming exam is the brachial plexus. So first thing which is important. So okay, I'm just going on teaching. I just want, my dear students, are you understanding or not? If any part you are not understanding, please let me know. Okay, you can tell me, ma'am, please repeat. I didn't understood. So I will repeat that topic or I will repeat that concept. Okay, so you just let me know, my dear students. So my pace is okay. I'm going very fast or I want to be slight slow. Please let me know. But as it is a fast track revision of anatomy subject for your upcoming exam, so I think I want to cover as many as topic possible before your exam. All okay, dear? Okay, thank you so much. All okay. So now the word plex means, if I talk about the word plex, what does it mean? A bunch, a group of nerves. So brachial plexus means a bunch of nerve which is giving innervation to upper limb. Okay, a bunch of nerve which is giving innervation to upper limb. So it's a network of nerve. Okay, thank you, dear. It's a network of nerve which is supplying the skin and musculatures of the upper limb. And basically, the origin ki baat kare, if I am talking about the origin of these are the nerves which arises in the neck region, and then it passes through the axilla, and then it gives branches to the upper lip. So basically, if I talk about the roots and the trunks, basically the trunks and the roots of brachial plexus, the trunks of the brachial plexus is emerging out between the two muscles of the neck. As you can see in the diagram also, I have already marked what does BP stands. BP stands for brachial plexus here. So the brachial plexus trunks are emerging out in between the two neck muscles, scalenus anterior and scalenus medius muscle. Now, if I talk about the formation of brachial plexus, and the origin of brachial plexus is from the ventral rami of C5, C6, C7, C8 and T1. C5 means the fifth cervical nerve, C6 means the sixth cervical nerve, C7 means the seventh cervical nerve, and C8 means the eighth cervical nerve along with the first thoracic spinal nerve. So basically, these are the nerves which will form, which will lead to the formation of brachial plexus. The anterior rami of these nerves will form the brachial plexus, that is the bunch of nerve. So if the question comes as the root of brachial plexus, the answer will be ventral rami of C5, C6, C7, C8 and T1. But I think in the previous year, also in the NEET PG and FMG, the question has been asked about prefixed and postfixed. So I want everybody to be clear with the concept of prefixed and postfixed. So you can see in the image, there is prefixed and postfixed brachial plexus shown. So when I am using the word prefixed, it means the formation of brachial plexus is from taking contribution from C4 is there. Actually, prefixed brachial plexus means through the usual formation of brachial plexus, one ahead, one above, that is the fourth cervical nerve. Contribution is also there, but there is no contribution from the T2. T2 means the second thoracic nerve. If I talk about the term postfixed brachial plexus, what does it mean? So when I'm using the word postfixed brachial plexus, it means that the formation of brachial plexus is from C5, C6, C7, C8 and T1 and T2. No contribution from C4. Okay. Now, there are various components of brachial plexus. We know that the brachial plexus is having the components like roots. The brachial plexus is having the components like trunk, division, cords, branches. So basically, when I'm talking about the roots, as I already told you, ventral rami of C5, C6, C7, C8 and T1. What about the trunk? So then comes the trunk, then comes the division, then comes the cords, and then comes the branches. So I will show you another image where you will understand the formation of different parts of brachial plexus. Here, the trunks and the roots of brachial plexus are located in neck region. Division. So there is anterior and posterior division, and the anterior posterior division of brachial plexus is located behind the clavicle. And if I talk about cords, so cords are present in the axilla region, of upper limb. Branches is also starts in the axilla, so that in the axilla of upper limb, and then it goes further in the upper limb for innervation. Now here, many times the question comes as the branches, which of these branches has got its origin from the supraclavicular part? Means either it is a branch from neck so that means either it is a branch from the root or the trunk part of brachial plexus. So roots and trunks are supraclavicular part of brachial plexus, and cords and its branches are infraclavicular part of brachial plexus. Why? Because cords of brachial plexus location is below the clavicle. So I just want everybody that you should be quite aware about the location of different parts or components of brachial plexus. Now, here there is another image in which you get an idea, as we know that through the intervertebral foramina, you can see the nerves are emerging out. So these are showing the nerve roots of brachial plexus. Now, few of the nerve roots joins, and then they form three trunks. The upper, they forms the middle, upper and lower trunk of brachial plexus. Then comes the division, anterior and posterior division, which is lying behind the clavicle as shown in the image. And then comes the formation of cords. We have got posterior, lateral and medial cord of brachial plex formed, and this will give further branches. Now, so the most important part about brachial plexus is the branches from each cords and each component of brachial plexus. Before that, I want everybody to have an idea how the brachial plexus is formed. Okay, so let's see this. So the first part in the image is showing you roots. So roots of brachial plexus, that means it is C5, it's C6, okay, then comes C7, then comes C8 ventral rami, then comes T1 ventral rami. So basically these are forming the parts of roots of brachial plexus. Now if you see the next part, which is showing the trunks of brachial plexus, so you can see C5 and C6 is joining to form UT. What does UT stands for? Upper trunk of brachial plexus. So what you can appreciate in this image, that C5 and C6 is joining to form the upper trunk of brachial plexus. C7 alone is forming the middle trunk of brachial plexus, and C8 and T1 is joining to form the lower trunk of brachial plexus. Okay. Now the next part will be the division of brachial plexus. So in the division part of brachial plexus, what you can appreciate, this blue color is anterior division and this yellow color is the posterior division of brachial plexus. As I told you, division part of brachial plexus is lying behind the clavicle. Now in this diagram, you can also understand the formation of cords. So please see this image. What you can appreciate, the anterior division of upper trunk and the anterior division of middle trunk will join to form the lateral cord of brachial plexus. And my dear students, what you can appreciate in the second image, the posterior division of all the three trunks. Can you see? The posterior division of all the three trunks will join to lead to the formation of posterior cord of brachial plexus. And what about the medial cord? When I am talking about the medial cord, my dear students, you can see anterior division of only of the lower trunk and anterior is forming the medial cord of brachial plexus. So this image is telling you or showing you the perfect formation of brachial plexus. Why this perfect formation of brachial plexus must be known to you, so that you are able to identify the nerves in case of image based question or in schematic diagram also. Okay, my dear students. So now I want everybody to see another image in which you can appreciate the branches of brachial plexus. Okay, so let's talk about the branches of brachial plexus. So firstly, I just want everybody to pay attention to C5, C6, C7, C8 and T1. So everybody is quite aware that C5, C6, C7, C8 and T1 is forming the root. Now in this diagram, you can see this is DS and this will be LTN. So there are two branches from the roots, as you can see, two branches, DS and LTN. So DS full form is dorsal scapular nerve, which is having the root value C5, and LTN means lateral thoracic nerve, which is also called as Bell's nerve, which is also called as nerve to serratus anterior. SA means nerve to serratus anterior, and this is formed by C5, C6 and C7 as the root value. Okay. So here we are seeing two nerves are the branches which is given from the root of brachial plexus, We have got the DS as the dorsal scapular nerve. The branch is having the root value C5 and it is a branch from the root part of the brachial plexus. The other one is the LTN, long thoracic nerve, which is C5, C6 and C7 as the root value, and this is actually emerging, which is giving innervation to serratus anterior muscle, and it is also a branch from the root of brachial plexus. Now we have finished with the branches of the roots. Can we go with the trunks? So as you know, this is UT, this is a middle trunk, and this is LT as the lower trunk. Now we can see from the upper trunk, we have got two branches, SS and NS. So here SS stands for suprascapular nerve, and my dear students, NS stands for nerve to subclavis. And both is having the root value C5 and C6. Both are having the root value C5 and C6. Okay, my dear students. So very easy to remember. There are two major branches from the root part of brachial plexus, and there are two branches from the upper trunk of brachial plexus. I think it is very easy for you to remember. Okay, it's very easy. So already we are knowing the branches from the roots. Already we are knowing the branches from the trunk. Now coming to division, no branch. Can you see here? We know there is anterior and posterior division which are formed behind the clavicle, and no branches are given from the division. But major branches are given from the cords of brachial plexus. Now, here, if I talk about the cords of brachial plexus, all of you please correctly see this image. Practice the identification of nerve because it will be asked as an image-based question also. Now, what you can see, the anterior division, as you know, this is A for anterior division of the upper and middle will join to form the lateral cord. So what is this cord? This is the lateral cord. Okay, this is posterior cord and this is the medial cord. Okay, now see here, the lateral cord is giving three branches: LPN, musculocutaneous nerve, and lateral root of median nerve. Now, my dear students, actually I will write the branches of all the three cords, and I will also explain the branches of all the three cords with an example of story. Now, what is that story is you want to meet someone special in your life, and we generally know that if you apply for medical leaves, they are not rejected by the dean, the teachers, faculties and principal of the college. So for example, you all are have studied from a good institutes, either in India or outside India. So you want to apply the leave, you're pretty sure that if you will tell that medical leave 2 means you have applied medical leave 2, that will be not rejected. So first thing is that for understanding the branches of lateral cord of brachial plexus, you have applied medical leave 2, and medical leave 2 three branches are shown in the image. I am highlighting it with green color. So the three branches from lateral cord is ML2, medical leave 2. Here M stands for musculocutaneous nerve, another L for lateral root of median nerve, another L for lateral pectoral nerve. So please write on this: branches from the lateral cord of brachial plexus. So if I am talking about branches from the lateral cord of brachial plexus, the mnemonic which I want everybody to understand is, the mnemonic is medical leave 2. In short, we can write ML2. MLL. So here M stands for musculocutaneous nerve. Musculocutaneous nerve. What is the root value of musculocutaneous nerve? C5, C6 and C7. The other one is lateral pectoral nerve. Lateral pectoral nerve. If I talk about lateral pectoral nerve, its also root value is C5, C6 and C7. The other is lateral root of median nerve. If I talk about lateral root of median nerve, its root value is also C5, C6 and C7. So, okay, perfect. This is how you can memorize the branches of lateral cord of brachial plexus. You have applied medical leave 2. Got it? We have seen the same thing in the image, and we are also written the name of these nerves along with the root value. Okay. Now, I have also given you in your notes, this is for practice branches of brachial plexus in this image. So why I have given you this? Because we will just see a schematic diagram, and you can also have a practice of important branches of brachial plexus in this image, where there is roots, trunks, division cords, and branches written. Okay, so we have finished with that of the with the lateral cord. Now coming to the posterior cord. So if I talk about the posterior cord, as you can see very nicely, you can see the posterior cord, which is formed from the posterior root of all the three trunks. So these are P, P, and P, and these are formed from the posterior cord of all the three posterior division of all the three trunks. And the posterior cord of brachial plexus is also giving 5 branches. And to memorize it, radial nerve, axillary nerve, then we have got radial nerve, axillary nerve. We have also got, this is medial. So okay, we have also got, these are T4 and 5. Okay, these are all the branches. So basically I will tell you a mnemonic for knowing the branches of posterior cord. So see here. Now the thing is that you have applied leave, and after that you want to invite the students. You want, actually, my dear students, I think minimum the class will go till 9 or 9:30. Okay, I want to complete entire anatomy, so the class will go till 9 or 9:30. Okay, 7 hours. Yeah, 7 hours. I will complete the entire anatomy. So now coming to the branches of posterior cord of brachial plexus. So if I talk about branches of posterior cord of brachial plexus, the mnemonic is rats in upper self and rats in lower self. So basically what happens, we have to know the location of rats in the upper and lower self. Actually, what is that? You have applied to leave, and your pocket money is not much, because you are still not earning, and you are in the process of earning so that you can pass this FMG exam. So basically you want to invite your special person at home. You don't want to spend money at the restaurants and hotels. So what you will do, you will clean your room, and as you have not cleaned your room from last many months, so you will find rats in the upper and lower self. So the branches of posterior cord will be rats in the upper and lower self. Write on the full form. So here R stands for radial nerve, A stands for axillary nerve, T for thoracodorsal nerve. So upper self and lower self, that means US and LS, upper subscapular and lower subscapular. And lower subscapular nerve. Okay, upper subscapular and lower subscapular nerve. Okay, now here radial nerve root value is C5, C6, C7, C8 and T1. Axillary nerve root value is C5 and C6. Thoracodorsal C6, C7 and C8. Upper subscapular is C5 and C6. Lower subscapular is again C5 and C6. Okay, so this is how you can memorize the branches of posterior cord of brachial plexus. Got it? Now coming to the branches of medial cord of brachial plexus. So we have finished the branches of posterior cord. We have finished the branches of lateral cord. Now coming to the branches of medial cord of brachial plexus. So before that, again going to this image. And in this image, so basically branches of medial cord of brachial plexus, I would like to highlight. See, this is from the lower trunk anterior division. So the branches are medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm as shown. Then we will have the ulnar nerve and medial root of median nerve. So we will also have the median nerve, medial root. So basically, this is the medial root of median nerve, which is the branch. Okay. So basically, this median nerve, as you can see, has got two parts. One is the lateral root and the other is medial root. So actually, all these three, four, five branches are from the medial 𝗘𝗶𝗁𝗃 plexus. Again, I will give you a mnemonic for practicing this branch. So actually why I have given you a one blank image here, because after studying all the branches and by hearting the name of all the branches, you can practice the branches in this image after completion of class. Now again, a third part of the story which will help you to understand the branches of brachial plexus, which called medial cord of brachial plexus. Medial cord of brachial plexus. So my dear students, the branches of medial 𝗘𝗶𝗁𝗃 plexus can be memorized like this. Me for you. Now that special person comes at your place, and when you invited after cleaning your room, after removing the rats from the upper and lower self, you have invited the special person at your place. And when that special friend is at your place, you tell meet for each other, that is me for you. So you have told meet for you. So here 4M and 1 U. The branches are medial root of median nerve, so medial root of median nerve, C8 and T1 is the root value. Another M for medial pectoral nerve. Again the root value is C8 and T1. Another is medial cutaneous nerve of arm. Another root value is C8 and T1. The another one is medial cutaneous nerve of forearm. Medial cutaneous nerve of forearm, that is C8 and T1, and U for ulnar nerve. That is C8 and T1 and in bracket C7. You can write in bracket C7. Okay. So these are the branches from medial cord of brachial plexus. These are the branches from the medial cord of brachial plexus. Okay, my dear students, so we have done with the branches of brachial plexus. So we have finished a very, very important topic for your upcoming FMG exam. And I just want to practice few MCQs with you, which is also very important for your examination. So can we do that? Everyone is ready for the MCQ session? Okay, we can start? Yes, yes. So let's start. Let's start with the first. Okay, which part of brachial plexus is not giving any branch? Which part of the brachial plexus is not giving any branch? There are the option, the roots, the trunks, the cords, and the divisions. Absolutely correct answer. It is the division part. The root value of thoracodorsal nerve is. So yes, my dear students, all of you have marked perfectly right answer. A thumbs up goes for you. Okay. Root value of thoracodorsal nerve. What is the root value of thoracodorsal nerve? Here comes the right answer. Yeah, it's C6, C7 and C8. Again, a thumbs up goes for you. Yeah, very good. Correct. Now, can you tell me the answer for the third MCQ? Posterior cord of brachial plexus is formed by taking contribution from ventral division of upper trunk, dorsal division of upper trunk or front. What they have written is trunk should be there. Ventral division of upper, middle and lower trunks, dorsal division of upper, middle and lower trunks. This is also trunk, my dear. This is also trunk. Okay, many correct answers are coming from my dear students. Dorsal division of upper, middle and lower trunk is absolutely right answer. Yeah, absolutely correct. Now coming to the next one, that is Erb's point. So actually, I just want everybody to understand what is ops point and how you are able to understand this ops point. Actually, ops point is the location of upper trunk of brachial plexus. So upper trunk of brachial plexus is the location, as we know, that the two nerve roots, the ventral rami of C5 and C6 is joining and leading to the formation of upper trunk. Now we already know that two major nerves, NS and suprascapular nerve, SS is the branch which is given from the upper trunk, and this upper trunk again divides into anterior and posterior division behind the clavicle. That means six nerves are meeting at the ops point. Oh, thank you so much, dear. So that means six nerves are meeting at the level of upper trunk. So basically, we have to know what will happen if there is injury of upper trunk or brachial plexus. Now, let's see this. If I'm talking about the upper trunk of brachial plexus, where C5 and C6 nerve root is involved and their joining will lead to the formation of upper trunk and further giving branches, there are certain mode of injuries which can be seen. Either actually the reason of upper trunk brachial plexus is there is excessive increase in the angulation between head and shoulder. So actually excessive increase in the angulation between head and shoulder is seen in cases of difficult vaginal delivery, birth injury, or if somebody, can you see the second image? So the first image is the showing you the increase of angulation between head and shoulder when the head is pulled out from the cervix part and vaginal part. So that is actually excessive straining is there, and this can lead to C5 C6 nerve root involvement. Yeah, fallen outstretched. Yeah, that is also there, but no, it's very important that you should be fallen outstretched hand was I have shown you. In that case, anatomical snuff box is involved. Now, other than that, if you will see, another mode of action will be if somebody has fallen from a height and they have landed on a ground, and when they have landed on a ground, there is excessive stretching of head and neck. So that excessive stretching of head and neck will again involve upper trunk brachial plex involved and lead to the injury of C5 and C6 nerve root. Now, so here, can you see the third image? The third image is showing you the deformity, and the name of deformity is 𝗘𝗱𝗶𝗁𝗋. What is the name of deformity, my dear students? The name of deformity is 𝗘𝗱𝗶𝗁𝗋. And in 𝗘𝗱𝗶𝗁𝗋, you can see the arm is adducted and medially rotated. As you can see, this is the position of arm, and this is the position of forearm. So when I'm talking about the arm, you can see the arm is adducted and medially rotated, and forearm is extended and pronated. This is supination, this is pronation. So forearm is in pronated state. Yeah, this is also called as, yes, my dear student, you're right. This is also called as policeman tip, waiter tip deformity. Yeah. So basically, as you can see, so if I want to summarize it, it can be either due to birth injury, as in this baby, or it can be either when the person falls on ground from a height and landed on shoulder and neck. So the arm hangs by the side, the arms as is in the adducted position, in the medial rotated position, no lateral rotation. The arm is in extended position and the forearm is actually pronated, not supinated, and this condition is called as policeman tip or waiter tip deformity. Okay, now coming to the lower trunk palsy. So when I talk about lower trunk brachial plex palsy, in lower trunk brachial plex palsy, the nerve root which is involved is C8 and T1. Site of injury is involvement of ventral rami of C8 and T1, and the involvement is of medial cord of brachial plexus, and basically medial cutaneous nerve of arm and forearm is involved. Mainly lower trunk is involved, and we know that the major contribution or the formation of lower trunk root value is C8 and T1. My dear students, if someone falls, what is the mode of injury? Either difficult breech delivery, as you can see, or if someone falls from a height, and to save himself or herself, they hold a branch of it. So while holding a branch of tree, there is excessive hyperabduction of arm, and in the case of hyperabduction of the arm, the C8 and T1 nerves are roots are involved, and this becomes a condition of �𝗀𝗃𝗃𝗃 paralysis. Now, my dear students, the other reasons of 𝗃𝗃𝗃𝗃 paralysis can be cervical rib, hyperabduction of arm, and also birth injury in a difficult breech presentation. And my dear students, what will happen? The patient will have claw hand as the classical representation of lower trunk brachial plex injury. Basically, claw hand is more pronounced in the as medial claw hand. because of paralysis of intrinsic muscles of hand. So now you can see this image. In case of lower trunk brachial plexus, the claw hand is there in which medial two fingers are more involved, and actually the nerve root being involved is C8 and T1. So we know that T1 nerve roots are involved. So when I am talking about T1 nerve roots being involved, the T1 nerve roots also carry sympathetic fibers. So there is also involvement of sympathetic fibers via T1 nerve roots, and it will lead to Horner syndrome. So the patient will have medial claw hand, which is shown in this image as you can see, and the person will have the features of Horner syndrome, that is constriction of pupil, meiosis, constriction of pupil, the ptosis means drooping of upper eyelid, and hydrosis means absence of sweating, sunken eyeball, which is called as anophthalmos. So these are the primary presentations which is seen in case of lower trunk brachial plex injury. The first and the foremost sign and the most important is medial claw hand associated with sympathetic nerve fibers being involved and causing Horner syndrome. Okay. So done with this, this is the difference feature. This is the table which is showing the different features of Klumpke's lower trunk brachial plex injury and the upper trunk brachial plex injury, the Erb's paralysis. Nerve root being involved in upper trunk will be C5 and C6. Now, other than that, 80% questions will be coming from this rapid revision session which I have taken. 20% you have to go in more details. Okay. Now, muscle paralyzed mainly in case of upper trunk brachial plexus is the supraspinatus, infraspinatus, brachialis, supinator, extensor carpi radialis. Longus mainly all the intrinsic muscles of the hand will be paralyzed in the Klumpke's paralysis. Position of hand will be in the case of waiter tip deformity or policeman tip deformity. Okay. And also there will be claw hand as in case of Klumpke. Sensory loss will be on the outer aspect of arm, as also there will be sensory loss on the medial border of forearm and the hand in case of Klumpke's paralysis. Autonomic signs will be not associated in case of upper trunk brachial plex injury, but autonomic sign will be involved in case of Horner syndrome. Okay. Now let's come up with the MCQ. So my dear students, let's come up with solving MCQs together. Lower trunk brachial plex injury leads to Klumpke's paralysis. What is the characteristic finding of that case? Horner syndrome, policeman tip deformity, wrist drop, or claw hand? Yeah, correct answer is claw hand, and it's again a correct answer given from all of you. Absolutely correct answer is given from all of you. Very good. Now, coming to the next. This is a clinical question, so I will like to read it for you. A young boy who was driving motorcycle at a high speed collided with a tree and was thrown on his right shoulder. Though there was no fracture, his right arm was medially rotated and forearm was pronated. The following facts considering the patient is correct except the option A is the injury was at Erb's point. Option B, a lesion of C5 and C6 nerve was present. The median and ulnar nerve were affected. Supraspinatus, infraspinatus, subclavius, and biceps brachii was paralyzed. Okay. Yes, it's a case of Erb's paralysis. So obviously median and ulnar nerve both will not be injured. So again a thumbs ups for all of the students, and they have given absolutely correct answer. C is the right answer. This both nerves will not be involved. Now coming to, so now I would like to start with the next topic, that is the radial nerve. Is it okay? So now before going into the next series and the last topic for the upper limb, I want to go through quickly the important nerves of upper limb. Basically, like long thoracic nerve is an important nerve. Why? Because it gives innervation to serratus anterior muscle. And serratus anterior muscle is the important protractor of the scapula boxus muscle. And if it is paralyzed, the winging of scapula is the condition, and also overhead abduction of shoulder joint is affected. Now, in case of axillary nerve, it is giving innervation to teres minor and deltoid muscle. So, musculocutaneous nerve is involved. That means it will lead to the paralysis of BBC, biceps brachii, brachialis, and coracobrachialis. Now, let's talk about most important big nerves like radial, ulnar, and medial. So in this image, you can see branches of radial nerve, which is given to following muscles. So if I talk about radial nerve, it gives branches in the arm and in the axilla. So what you can see in the axilla and arm, the radial nerve is giving branches to the three heads of the triceps muscle. Okay, now coming in the forearm. So in the forearm, that means mainly in the posterior compartment of forearm, it is giving innervation to brachioradialis and ECRL. Actually, the significance, so basically, if I talk about this important one, that if I talk about these two muscles, that is BR and ECRL. BR and ECRL means brachioradialis and extensor carpi radialis longus. These two muscles are directly receiving innervation from radial nerve. Okay, so that is if brachioradialis and extensor carpi radialis longus will get innervation from radial nerve. If I talk about brachioradialis and ECRL, extensor carpi radialis longus, it gets directly innervation from radial nerve. It is getting direct innervation from radial nerve. Now, if I talk about deep branch of radial nerve, which is called as PIN nerve. What do you mean by PIN nerve? PIN nerve means posterior introitious nerve. Posterior introitious nerve. What is the full form of PIN? Posterior introitious nerve, pin nerve, and it will give innervation to extensor carpi radialis brevis, supinator, extensor carpi ulnaris, extensor digitorum, extensor digiti minimi, abductor pollicis longus, extensor indicis, extensor pollicis longus, extensor pollicis brevis. And actually there is one more muscle that is called as anconeus muscle, which receive branch to anconeus from radial nerve. So that means all these muscles which has been shown here are receiving innervation from the branches of radial nerve. So if I talk about the dorsum of posterior compartment forearm muscle, only BR, brachioradialis, ECRL, that is extensor carpi radialis longus, is directly receiving innervation from radial nerve. Rest all muscles in this posterior forearm compartment, whether it is ECRB, supinator, extensor digiti minimi, extensor carpi ulnaris, extensor digitorum, extensor indicis, extensor pollicis brevis, extensor pollicis longus, abductor pollicis longus, supinator, extensor carpi ulnaris. Actually, all this list of muscle will receive innervation from deep branch of radial nerve, which is called as posterior introitious nerve. Okay, now I would like to show you another image. Okay, in this image, again, you can see the cutaneous distribution of radial nerve. Now you can see, I have just shown you this image with the cutaneous distribution or cutaneous nerves or branches of radial nerves. So in this diagram, you can see the lower part of the dorsum of the arm, that is inferior lateral cutaneous nerve of arm, posterior cutaneous nerve of arm, posterior cutaneous nerve of forearm, and also the superficial branch of radial nerve, which is giving innervation to the dorsum lateral part of the hand. So basically, these are cutaneous distribution of radial nerve. Surely we will come up with 100 MCQ session also, don't worry. Now, so we have done with the branches. Now, after discussing the branches, I want everybody to know about the lesions of radial nerve and the different location. So if I talk about lesions of radial nerve in the axilla, then it will be called as 𝗘𝗱𝗶𝗁𝗃. And basically what happens if there is a fracture of lower limb like tibia and fibula. After that, the person wants to walk and they want to use crutches to roam around. And actually what happens if there is compression of in the axilla, it will lead to the involvement of radial nerve, and we know that radial nerve is innervating triceps muscle, which is causing extension of elbow. We know that it is innervating all the extensors of the wrist, elbow and fingers will be paralyzed. Okay, so the patient will have wrist drop, the patient will have loss of extension of wrist, elbow and fingers, and also the patient is not able to grasp something perfectly, and there will be cutaneous sensation also lost in the distribution of radial nerve, that is the posterior cutaneous nerve of arm, lower lateral cutaneous nerve of arm, posterior cutaneous nerve of forearm, and dorsal part of the hand will also be not receiving any cutaneous innervation. So basically, and here also I want you to note down, this is a case which is shown, that is the wrist drop. This image is showing wrist drop. Yeah. Now, the second location injury will be if the radial nerve is injured in the spiral groove, which is called as radial groove. So, if the involvement of radial nerve happens in the spiral or radial groove, it can happen as a compression of radial nerve is happening in this groove. So, actually, what happens generally, it is called as generally, if I talk about this condition, it is called as Saturday night palsy. What is it called as? This condition is called as Saturday night palsy. Okay, my dear students. So when I am talking about Saturday night palsy, that means the spiral groove, the compression of radial nerve has happened in the spiral groove or radial groove, which is lying on the posterior aspect of humerus. What happens generally? There is 5 or 6 days working, and after that, Sunday is a holiday, so the party is going on, and because of being drunk, the person or the girl or the person, the him or her, anyone has been drunk, and they have compressed. They have sat on the chair and compressed their radial nerve in the spiral groove. So next morning when they wake up, the triceps is not paralyzed, but the extension of elbow is there. Extension of elbow is involved. Basically what happens, extension of elbow is not fully impaired. Okay, it will be employed, it will be affected slightly, but it is not fully impaired, and wrist drop is present. So I just want you to give the concept why this happens. So basically, where is the spiral or radial groove located? As we know, the spiral and radial groove is located on the posterior aspect of arm, in the posterior aspect of humerus. And in that case, already the two heads of the triceps has been innervated. So only what happens? Only one head is involved. And we know that triceps is not fully paralyzed. So still the extension of elbow is possible. Wrist drop will be there, and there will be also sensory loss on the back of hand, lateral part, back of forearm, and in the lateral fingers, but not involving the nail birds laterally. Why not the nail birds laterally? Because nail birds are getting innervation by the median nerve. Okay, now coming to the third part, that is called as injury only happens to the deep branch. What is the name of deep branch of the radial nerve? As I have told you, the name is posterior introitious nerve. The posterior introitious nerve pierces the supinator muscle, and it gives innervation to most of the muscles of the posterior compartment of forearm except the two, that is brachioradialis and ECRL. So brachioradialis and ECRL are the two muscles which escape the injury, and the reason why they escape the injury, because they are directly getting innervation from radial nerve. So extension possible, but with radial deviation. Actually, wrist drop will not be there, and there will be no sensory loss. So basically, if the clinical history, if you will see the clinical history in case of pin nerve injury, that is involvement of posterior introitious nerve injury, there will be loss of, there will be there will be no wrist drop, there will be loss of extension of thumbs and fingers, loss of extension of fingers, mainly index finger or thumb. So basically, finger extension is involved, no wrist drop. Why? Because brachioradialis and ECRL are unaffected. Brachioradialis is a muscle which also helps in mid-prone supination, pronation, and flexion. Residing in the extensor compartment, it is acting as a flexor group of muscle. This is the peculiarity of brachioradialis. So if I want to summarize about radial nerve injury, if the triceps is paralyzed, what is the injury? The injury is in the axilla. If brachioradialis is paralyzed with normal triceps, injury is in radial groove. If brachioradialis and triceps both are normal, the injury is beyond the level of lateral epicondyle. Okay. Now, my dear students, we before starting next nerves, I want to solve MCQs with you. Few MCQs. Is it okay? In between MCQs must be included. Okay. This is a clinical question. A patient presents to emergency department with weak wrist extension. On physical examination, sensation to the arm is intact. The affected nerve was most likely to be injured at which of the following location? Yeah, absolutely right. Head of radius is right. Why not carpal tunnel? Because in carpal tunnel, median nerve is involved. Why not hook of Hammett? Because in hook of Hammett, ulnar nerve is involved. Why not surgical neck of humerus? Because at the level of surgical neck of humerus, axillary nerve is involved. Why not 𝗘𝗱𝗶𝗁𝗃? Because 𝗘𝗱𝗃 is the group of BBC muscle, that is anterior arm, which is getting innervation from musculocutaneous nerve. Head of radius is related with radial nerve location. So it is the right answer. D is the right answer. Coming to the next question. A 25-year-old male fractured his right tibia in a motor vehicle accident. His right leg is fixed in a cast and he requires crutch to ambulate. He requires crutch to ambulate. He requires crutches to ambulate. Okay. 2 weeks later, he has difficulty in extending his wrist. Injury to which of the following nerve is involved? 𝗘𝗱𝗶𝗁𝗃 radial nerve. Yeah, dear, you're right. So the answer is radial nerve. Very good. Very good. Absolutely correct answer. Suprascapular nerve is not the right answer. Why? Because suprascapular nerve will give innervation to supraspinatus or infraspinatus muscle. Long thoracic nerve is not the right answer because it gives innervation to serratus anterior muscle. Axillary nerve will give innervation to deltoid muscle and teres minor muscle. Accessory nerve will give innervation to sternocleidomastoid and trapezius muscle. Radial nerve is the right answer. Now coming to the next clinical question. A 30-year-old man underwent excision of the right radial head. Following the surgery, the patient has developed inability to extend the fingers and the thumb. He has got no sensory deficit, which is the following presentation. So you can see the injury is involving only the thumb and the fingers, no sensory involvement. So yes, absolutely right. I already told you the involvement will be of the posterior introosseous nerve, which is the deep branch of radial nerve in this case. Absolutely correct. Now, this is a match the following kind of question. I want the students to take perfect time and mark the most correct answer. So, can you tell me which is the most correct? So, you can get confused with two options, but one answer is perfectly correct. So, you just tell me the right answer. Flexor pollicis longus is having innervation via anterior introosseous nerve. Flexor digitorum profundus by anterior introosseous nerve. Extensor carpi radialis longus by the posterior introosseous nerve. Brachioradialis by posterior introosseous nerve. Abductor pollicis by anterior introosseous nerve. Which is the most correct answer? Yes, again A is right. A is absolutely right because flexor pollicis longus receives innervation from deep branch of median nerve, that is anterior introosseous nerve. Okay. Flexor digitorum profundus, as you already know, it is not correct. It is a hybrid muscle. So it will be both AIN, branch of median nerve, anterior introosseous nerve and ulnar nerve. Extensor carpi radialis longus via radial nerve. Brachioradialis is also via radial nerve, not posterior introosseous nerve. And abductor pollicis longus is the nerve which is getting innervation from posterior introosseous nerve, not anterior introosseous nerve. Absolutely correct. Now, radial nerve innervates extensor compartment muscle, but it also innervates one of the muscle which is behaving like the flexor compartment muscle. Yes, brachioradialis is the right answer. I have explained this. Very good. Now, can you see this is showing the area of dorsum of the hand and on lateral side. So, can you see what is the nerve supply of this area? What is the nerve supply of this area? Yes, for this, C is the right answer. C is the right answer. It is C is the right answer. This is again the area of distribution of lateral aspect of hand, that is the radial nerve. Now, please wait. I just want to complete median. So there are few questions, but I will come to this question after median nerve. So I just want you to know about median nerve now. Now we have complete radial nerve. I just want to cover median and ulnar nerve, and then we will come up with the revision of important MCQs. So let's see. Median nerve. So as you know, median nerve is having two roots. Okay, median nerve. We will come to cutaneous distribution. Before that, median nerve is formed by two roots. It is formed by ventral rami of why? Because it is formed by both lateral. So it is formed by, it is the thickest nerve. It is the thickest nerve of brachial plexus. And the largest nerve of brachial plexus is radial nerve. Okay. And this nerve is thickest. Why? Because it is formed by taking contribution from the medial root and the lateral root. Medial nerve is giving no branch in arm and axilla. Okay, it gives branch in the forearm. So basically in the forearm, it gives innervation to pronator teres muscle, flexor digitorum superficialis, flexor carpi radialis, palmaris longus muscle. So basically these muscles are supplied by directly by median nerve. Now, other than that, the deeper muscles are FDP, lateral part. The other muscle is pronator quadratus and flexor pollicis longus. So these three muscles are supplied by deep branch of median nerve. And what is the name of deep branch of median nerve? AIN. What do you mean by AIN? Anterior introitious nerve. So actually anterior introitious nerve is the deep branch of median nerve which will give innervation to flexor digitorum profundus, lateral part, pronator quadratus and flexor pollicis longus. Okay, now this, if I talk about median nerve in hand, it gives innervation to thenar muscles, that is abductor pollicis brevis, flexor pollicis brevis and opponens pollicis, and it gives innervation to lateral two lumbricals, So that means in hand, it is giving innervation to lateral two lumbricals, okay, and the thenar muscle, which is made of three important muscles, that is abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. Flexor pollicis brevis and opponens pollicis. Now, after that, let's see cutaneous distribution of median nerve. So when I'm talking about cutaneous distribution of median nerve, you can appreciate in this diagram that whole of the lateral part of the palm. So whole of the lateral part of the palm in the anterior aspect and in the dorsum part of the hand, only the lateral 3.5 of the nail buds, 3.5 of the nail buds. So only lateral 3.5 of the nail buds are supplied dorsally by the cutaneous distribution of median nerve. Now, let's talk about the lesions. So when I'm talking about the lesions of median nerve, if the lesion is at the elbow, all the muscles are paralyzed except FCU and FDP medial. Now, my dear students, why the flexor carpi ulnaris is not involved, or FDP, that is flexor digitorum profundus? Actually, flexor carpi ulnaris and the medial part of flexor digitorum profundus, these are supplied by the ulnar nerve. Okay, so these two muscles escapes the injury. Osner clasping test. Actually, this is Osner clasping test. Okay, so when you want to clasp your hands or fingers, what you will see that index finger is extended, it is not flexed. Why not flexed? Because lateral part of FDP is paralyzed. Ulnar deviation on flexion of the wrist and inability to flex the thumb distal part. Terminal phalanx. Okay, why terminal phalanx? Actually, FDS, that is flexor digitorum superficialis, which receives till the level of middle phalanx, but FDP will go till the level of distal phalanx. So this is, if FDP is gone, what will happen? The inability will be there in the that means mainly the anterior introitious nerve, the deep part is involved, and it will involve the deeper group of muscles. So basically flexor pollicis longus is also involved. Now coming to another test which will help us to understand, yes, this is the involvement of median nerve. So actually we know that in thenar eminences, we have got three muscles which is forming thenar eminences. What are that? Opponens pollicis is there. There is flexor pollicis brevis, and there is abductor pollicis brevis. So when I am talking about abductor pollicis brevis, abduction of thumb is primarily done by abductor pollicis brevis. So a pen test is done, and we know that a pen is kept at slight upper position from the table and ask the patient to touch this, ask the patient to touch the pen. So for touching the pen, abduction of thumb has to be done, and that is done by abductor pollicis muscle, abductor pollicis brevis, and that is paralyzed due to injury of the median nerve. So in that case, pen test is positive. Now, lesions of median nerve, if there is, the thenar eminences is flattened. So we know that this is thenar eminences, and these are composed of three muscles, which is primarily innervated by median nerve, which is paralyzed. Long-lasting case will cause flattening of thenar eminences. Now, ape-like deformity, why? Because abduction of thumb is not possible, so it will be adducted. It will be adducted. And adduction of thumb is done by adductor pollicis and adduction, which are adductors of thumb. Adductor pollicis is supplied by ulnar nerve and it is not paralyzed. Pen test is positive. Also, abductor pollicis brevis and opponens pollicis is paralyzed. Also, flexor pollicis brevis, but we know that flexor pollicis brevis and part of opponens pollicis is also receiving innervation from ulnar nerve. Now, carpal tunnel. So actually, in the hand, we have got flexor retinaculum, which is connecting the carpal bones on lateral and medial side. So it's made of deep fascia. It's a modification of deep fascia, and median nerve is passing beneath flexor retinaculum or transverse carpal ligament, and can be compressed in case of hypothyroidism, myxedema, arthritis, fracture of lunate bone, diabetes. So actually, mainly it is seen more in females, and bilateral cases are also seen mostly in dominant hand. And you can see this is the median nerve, and median nerve can be compressed in this space, that is the space beneath the flexor retinaculum, that is called as carpal tunnel syndrome. So no, in grave cases and in few cases, either the treatment of cause should be done. In another cases, surgical incision of the transverse carpal ligament has to be done. Now, carpal tunnel can be narrowed by following this condition. It can be temporary in case of pregnancy, obesity, edema. And also it can be seen in case of acromegaly, myxedema in the Colles and lunate fractures in rheumatoid arthritis. Now you can see this is showing a cross section of the wrist, and as you can see in this cross section, that many structures has been shown, and you can clearly see that if we talk about, so we will have the median nerve. So basically we will have the median nerve, MN for median nerve. So we will have the median nerve, which is exactly lying below the green color. You can see Y-shaped green color structure is flexor retina. This is FR. What do you mean by FR? FR means flexor retinaculum, which is also called as transverse carpal ligament. So the space beneath the beneath or below flexor retinaculum is carpal tunnel. So inside the carpal tunnel, we have got the flexor tendons, the tendons of FDS, FDP, flexor pollicis longus. And in between the Y-shaped loop or space, the splitting of Y-shape is the splitting of flexor retinaculum through which flexor carpi radialis passes. Actually, this ulnar nerve and ulnar artery passes superficial to the flexor retinaculum, so they are not affected in case of carpal tunnel. Okay, also the extensor tendon muscles has been shown, because it is also showing, this transverse section is also showing the extensor compartments and the extensor group of muscle. Now, basically in carpal tunnel syndrome, we will treat the condition. We will see impairment is there, and patient complains of impairment of finer movements like knitting, picking, pen swing, and also pain and tingling in the area of distribution of median nerve. And also in cases we go with the treatment of the cause, or we can go for surgical treatment, which involves cutting of the carpal, cutting of the transverse carpal ligament, flexor retinaculum. The other test which is done for confirmation of the diagnosis. So how pregnancy affect? Yeah, dear, pregnancy weight is more. Okay, fluid accumulation is also more, and sometimes in difficult pregnancy conditions there can be more accumulation of pressure and fluid that can compress median nerve. Okay, dear. Now, carpal tunnel syndrome, on examination we can do a Tinel test. So we know already the nerve is compressed and we want to increase the pressure over flexor retinaculum. So we can go on tapping, either hammer or with hand. We tap on the flexor retina and it will increase pain and tenderness in the patient. So this will confirm median nerve compression. So hyposthesia and flattening of thenar muscles, as you can see, this is flattening of thenar eminences. Skin over thin air eminences is not affected. Only the median nerve superficial fibers are not affected. And you can see the palmar radial side is affected. Carpal tunnel, another test is Fallon test. So we will tell the patient to make a like this is namaskar position in the dorsal aspect. And this will also compress the median nerve at the level below the flexor retinaculum. And this will also be positive in case. And as I told you, in some cases we can go with the surgical treatment, endoscopic carpal tunnel release, cutting of the flexor retinaculum, which is also called as transverse carpal ligament. The other point of compression involvement can be in between when the median nerve is passing between the pronator teres muscle. It can be compressed. It can also be compressed in the area of the regions of cubital fossa. Also, median nerve, as we have completed cubital fossa, and we know that median nerve is the middlemost component of cubital fossa, so it can be also involved. So basically, let's come up with few MCQs. So let's solve it. A 45-year-old Caucasian female's presence to your office with numbness of the right palm after taking a detailed history and doing a physical examination. You suspect median nerve lesion at the wrist. Before reaching the wrist, the median nerve courses between. So actually, which two muscle in this group is supplied by median nerve? That will give you the right answer. Absolutely correct. It's the flexor digitorum superficialis and flexor digitorum profundus. Is absolutely correct. Then median nerve does not innervates which of the following? Which of the following muscle is not innervated by median nerve? Abductor pollicis brevis, adductor pollicis, flexor pollicis brevis, opponens pollicis, recurrent branch of median nerve innervates all. Which one, dear? Adductor pollicis is the right answer. Absolutely correct. Yes. So patient tries to make a fist but partially extended. The nerve involved. Absolutely correct. It's the median nerve. It's the median nerve. Absolutely correct, dear. Now, Benedict sign, actually this is showing you a Benedict sign in case of nerve being involved, median nerve, and you want to make a like this, you want to flex the fingers like this, but your index finger and also part of middle finger is not flexed, and this is called as Benedict sign positive in case of median nerve injury, and this is seen the condition. Now, what is the, so see here in this case you can see few muscle has been marked. Okay, so if you will if you want I can enlarge. So muscles are marked on the lateral side, as you can see, small muscles. So you these are the muscles, so you have to identify the muscles. So these are the muscles, as you can see, and these are the muscles. So you identify the muscle and tell the nerve supply. What is the nerve supply of this muscle? So which muscles are these? These are lateral. Which muscles are these? These are lateral lumbrical muscle. These are lateral lumbrical muscle. These are lateral lumbrical muscle, and lateral lumbrical muscles are supplied by which nerve, my dear students? Lumbrical muscles. Lateral lumbricals are supplied by median nerve. So here the right answer will be median nerve. Yeah, lateral lumbrical is right. So it should be D, not C. It should be D, not ulnar. No, ulnar is not the right answer. Ulnar nerve will give innervation to medial lumbricals, not the lateral lumbricals. Now, what is the action of this muscle pointed at metacarpophalangeal joint? Okay, that image. So now this muscle, so actually this question is telling you about the lumbrical. So basically you have identified in this image, this is the lumbrical muscle. Now this image is okay. This is lumbrical muscle. So my question, next part of this question is related with this question only. My question is lumbrical muscles. What is the action? So what is the action of lumbrical muscle at the metacarpophalangeal joint? So what is the muscle which is being asked? Lumbrical muscle action at the metacarpophalangeal joint. So what is the action of lumbrical muscle at the metacarpophalangeal joint? So I just want you to explain that there are four muscles which are called as lumbrical muscles. We have got lateral two lumbricals and we have got medial two lumbricals. Together we have got four. Now the action of lumbrical muscle is like this. You can just make a cobra. As you can see, this is like a cobra. So this action, this is lumbrical muscle. It is causing flexion at metacarpophalangeal joint and extension at interphalangeal joint. So the action of lumbrical is flexion at the metacarpophalangeal joint and extension at interphalangeal joint. What will happen in the deformity? If the lumbrical muscles are paralyzed, just the opposite will happen. Claw hand, that is extension at metacarpophalangeal joint and flexion at interphalangeal joint. So, action of lumbrical at metacarpophalangeal joint is flexion. Flexion. Action of lumbrical muscle at metacarpophalangeal joint is flexion, yes. And action of lumbrical muscle at interphalangeal joint will be extension. So that means when there is claw hand, just the reverse will happen. The reverse will be the patient will have extension at metacarpophalangeal joint and flexion at interphalangeal joint. So just the reverse will happen. Okay. Now, lesion of the marked structure. So you can see there is a white color arrow mark. So lesion of the marked structure in this image will cause which of the following deformity? Now, which nerve is this? Yes, A is absolutely right. Actually, this arrow marked nerve is. So actually this arrow mark, this is the nerve. So this arrow marked nerve is, yes, absolutely right. This is the median nerve. So medial nerve is giving innervation to nail buds on the lateral side. So obviously the right answer, yes, this is the area of cubital fossa. Here, this is MN, median nerve. This is brachial artery. This is biceps tendon. And this is radial nerve. So MBBR. So medial nerve gives innervation to the lateral part of the nail buds and is in the distal aspect. So yes, that is the right answer. Now, a 19-year-old female presents in your office with a complaint of right hand clumsiness and on examination reveals decreased sensation on the fifth finger and flattened hypothenar eminences. The nerve injured will be. Yes, 𝗘𝗱𝗶𝗁 is right. Absolutely correct, my dear students. Actually, ulnar nerve is affected and ulnar nerve is compressed below 𝗘𝗱𝗶 in the Guyon's canal. I will just now explain also Guyon's canal, not carpal tunnel because in this case medial nerve is involved. Not surgical neck of humerus because in this case axillary. Not head of radius because in this case radial nerve is injured. Not coracobrachialis because BBC is supplied by musculocutaneous nerve. Yes, you are absolutely right. Don't worry. Just now I will explain ulnar nerve also. That was the last topic for upper limb. Now one more thing, I just want to go with a few images in the previous part. I think medial nerve was, wait a minute, I'm just going. Yeah, come to this. So come to this question. We have not done this question. So one more image based question I want you to complete. Okay. Lesion of marked nerve. So lesion of marked nerve will lead to which of the following deformity? Okay. This question I didn't solve because I told that after completing medial nerve, I will. Now you can identify this nerve. Few of the structures. So in this image, median nerve, brachial artery, ulnar nerve is already marked. So what will be this nerve? What will be the question marked nerve? What is this question marked nerve? This is the reason of cubital fossa more going on the lateral aspect. Yes. Which nerve is this? Which nerve is this? Yes, I got Simran has given the right answer. Yes, radial nerve. So the answer will be yes. Yes, the answer will be wrist drop. Absolutely right. The answer is wrist drop. Absolutely right. Absolutely right. Yeah. So you can just see this image. Actually, this is a cadaveric image in which I want you to identify. So this is a cadaveric image of the cubital fossa. So this nerve which you are seeing, which I have highlighted in yellow, this is median nerve. Next to it is the artery. So this is the artery which is shown. And which artery is this? This is brachial artery. Next structure. So this is brachial artery. This is first. This is second. And what about this third? This is the biceps tendon. Yes, this is third. This is biceps tendon. And what about the fourth structure, dear students? The fourth structure which you are seeing, the fourth structure, this is the radial nerve. And deep branch is going to an S structure supinator. Okay, so this is a cadaveric image in which you can identify. This is the cadaveric image in which, so this is the cadaveric image in which you can identify the structures of the cubital fossa. Done. Obviously, this will be brachioradialis and this will be PT pronator teres. Done, my dear students. Now, last topic of the upper limb, that is the ulnar nerve. So let's come with the ulnar nerve. Okay. So first thing is the branches of ulnar nerve. So we have to know the branches of ulnar nerve. So if I talk about the branches of ulnar nerve is also called as musician nerve. So why it is called as musician nerve? Because it is primarily innervating the small intrinsic muscles of the hand. So in arm and axilla, it gives no branch. In forearm, it just gives innervation to flexor carpi ulnaris and medial part of FDP. And in hand, it gives innervation to hypothenar muscle. Hypothenar muscle, we know that hypothenar muscles are the three muscles below little finger, that is abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. So that means all the muscles will have digiti minimi attached, that is abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. It will also innervate medial two lumbricals. It will also innervate the palmaris brevis muscle, the small muscles in the superficial part of the hand. It will also innervate all the palmar interossei and dorsal interossei muscle. That means primarily most of the muscles of hand is innervated by ulnar nerve. It's a branch of medial cord having the root value C8 and T1 with few fibers of C7. Now, this is showing you the cutaneous distribution of ulnar nerve, which is mainly on the dorsum and palmar part of the hand, on the medial 1.5 part of the palm and dorsum of the hand and fingers. Now, there is a test which is called as Foreman test, which is done for integrity of one more muscle, that is adductor pollicis. Other than that, one more muscles in the hand, which is called as adductor pollicis muscle. Actually, this is lying deep to the thenar muscle region, and this is adductor pollicis muscle, which is also innervated by ulnar nerve. So there is a test which is called as Foreman test, which is done to see the integrity of adductor pollicis muscle. So basically, ulnar nerve is injury is positive and Foreman test positive. Actually, what happens, for example, if I take a block of structure and if we take a block of paper on its structure and tell the patient to hold between thumb and index finger. So generally, this will be done by adduction of thumb, and we know the adduction of thumb is done by which muscle? Adductor pollicis. Now, when the adductor pollicis muscle is paralyzed due to injury to ulnar nerve, the person will hold the structure by flexing the thumb by the action of flexor pollicis brevis. This is done primarily by the action of flexor pollicis longus, and this will lead to Foreman test positive. Okay. So this is done to see the integrity of which muscle? Adductor pollicis muscle. Test. This is done for testing the adductor pollicis muscle injury, and in ulnar nerve injury, Foreman test is positive. Yeah. In case of flexor pollicis longus, we know the deep branch AIN supply. So it take the role. So the role of holding the structure by flexing the thumb is done by flexor pollicis longus, which is active in this region because it is supplied by AIN, anterior interosseous nerve, which is a branch of median nerve. Other than that, ulnar nerve is also compressed. Ulnar nerve and ulnar artery can be compressed in Guyon's canal. What is Guyon's canal? Guyon's canal is an area which is lying between the pisiform and the hamate bone. Floor is formed by flexor retinaculum and it is covered by superficial slip of flexor retinaculum, and the superficial slip of flexor retinaculum is called as volar carpal ligament. So that area is called as Guyon's canal. Ulnar nerve and ulnar artery can be compressed in Guyon's canal. Okay, now coming to few MCQ, one MCQ. A 53-year-old female feels strange feeling in the hand and loss of sensation on fifth digit. Can you tell me which of the following nerve is affected in this condition? Absolutely, very easy question. The affected nerve is ulnar nerve. The affected nerve is ulnar nerve. Very good. Absolutely right answer. Yes, absolutely right answer, my dear students. You have given me absolutely right answer. Okay. Now, so that is absolutely correct. Yeah. So, okay, students, now we will see a few more important things which will be asked in examination. One is the hyaline cartilage. So, actually, cartilage, their features and examples should be known to you. So, basically, if I talk about cartilages, we have got three varieties. Are the students back? Let me just check. Okay, students. So we are now after finishing general anatomy part and the upper limb and the nerves and all. So we are now starting with the cartilage. So basically, I just want everybody to know about the types of the cartilage and their examples and where they are located and how it looks. So we will have few of the histological images so that you can understand the cartilages. So in this image, we are seeing the hyaline cartilage. This is showing you the hyaline cartilage part. It's not showing the entire hyaline cartilage part. As you can see, it is bluish white in color. The cartilage will be present at the ends of the bones. It will present in the tracheal cartilages, ring, C-shape hyaline cartilage, larynx, nose, and these are the chondrocytes. What are these? The cells of cartilage is called as chondrocytes, which is residing in a space. This space are called as lacunae. Now, this is another image in which the entire hyaline cartilage image has been shared. So actually hyaline cartilage is a avascular structure. So it gets its nutrition from the covering which is called as perichondrium. So what is it? This is the perichondrium. This is the perichondrium. Now, if I am talking about the outer part of the perichondrium, it is the fibrous part of the perichondrium, and this is the inner part of the perichondrium. This is the inner chondrogenic layer of perichondrium. So what does this means? This means that the hyaline cartilage is surrounded by perichondrium, which is having a fibrous layer residing on the outer part of the perichondrium, and the inner part of the perichondrium is having a chondrogenic layer which is giving rise to chondroblast, which further get formed into chondrocytes. That is the mature chondroblast, when it get matured, have got the formation of matrix. Outside matrix is formed. It is called as chondrocytes. So basically, as you can see, the chondrocytes are arranged in a group. So these are isogenic group of chondrocytes. So basically, these isogenic group of chondrocytes are also called as cell nest, which is appearing in the slight blue. Why? Because it is having the territorial matrix, and if you will see the chondrocytes group in between the space, in this space is interterritorial matrix. So this is interterritorial matrix, which is not as darker stain as the territorial matrix where the cell nest resides. So, and you can see so many groups of chondrocytes are there, and it feels like the students are studying in group. Okay, group study is going on. Now, this presence of hyaline cartilage will be in the ends of the bones. Hyaline cartilage is present in thyroid cartilage, in the cricoid cartilages. So this is the important location in the costal part of the ribs. Okay, now elastic cartilage. If I talk about elastic cartilage, and the type of collagen fibers in hyaline cartilage is type 1 collagen. Basically, it is type 2 collagen fibers. So cartilage is having type 2 collagen fibers. Only type 1 collagen fibers are present in fibrocartilage. Now, elastic cartilage is having the structure similar to hyaline cartilage, but there is more presence of elastic fibers and chondrocyte numbers are more. So the presence of elastic cartilage, it is found in the auricle of the ears. It is found in the walls of external auditory canal. It is found in auditory tube. Also in the epiglottis and the laryngeal cartilage like tip of arytenoid, and also in cuneiform cartilage and the So basically, it is small cartilages of the larynx that is present there. And also, it is actually very important. Why more elasticity is there? So more flexibility is provided to the cells. And here also there is presence of perichondrium. So here this is an image of elastic cartilage where you can see the chondrogenic layer of perichondrium and the fibrous layer of perichondrium containing fibrocytes. Also in between, as you can see, these are elastic fibers. So basically there will be more number of elastic fibers in the elastic cartilage for elasticity. Chondrocytes are dense and it is the nuclei is prominent here. As you can see, it appears slightly brightly stained pink color. Fibrocartilage is the third variety of cartilage which is having no perichondrium. The important features are it is having no perichondrium, type 1 collagen fibers. If the question comes which type of collagen fibers are present in cartilage, the answer is type 2. Why? Because hyaline and the elastic both is having type 2 collagen fibers. Only the odd man out is fibrocartilage which is having type 1 collagen fibers densely packed, and if bundles of collagen fibers are there, more of collagen fibers are in fibrocartilage, feathery appearance is there, and the number of chondrocytes are less, and small cells are present in lacunae. So these are the features of fibrocartilage. Now here, this is an image in which you can see there is no perichondrium covering. There are few chondrocytes and there is so many collagen fibers as shown in the image. Where is fibrocartilage present? So it is present in acetabular labrum. It is present in intervertebral disc. It is present in knee menisci. So these are the areas where fibrocartilage is present. Other than that, here also you can see these are chondrocytes. These small are the chondrocytes. These are all collagen fibers. So many collagen fibers are there. And as I told you, the entire appearance is feathery appearance and there is no perichondrium. No perichondrium. And collagen fibers are more in fibrocartilage. Now, after that, I just want you to share, that I would like to share this image. This is showing you the comparison table of hyaline, elastic and fibrocartilage. As in this, you can say the examples of cartilage is there. It is present in articular variety. It is present in the embryonic trachea, bronchus, primary bronchus, principal bronchus, thyroid, cricoid cartilages. The elastic is present in arytenoid. The elastic cartilage is present in arytenoid, in the apex part, epiphyseal. So actually epiphyseal plate will be for hyaline cartilage. It is present in eustachian tube, ear, epiglottis, corniculate and cuneiform. Okay. Now, if I talk about, so this is knee meniscus is the example for the fibrocartilage. Intervertebral disc. So what is this? This is intervertebral. I is also there. Intervertebral disc, articular disc of TM joint and the sternoclavicular joint. So these are certain locations where fibrocartilage is present. So these table is showing you the examples of cartilage. Okay, there is one more image where you can see the comparison of hyaline, elastic and fibrous. You can also see the comparison of collagen fibers, type 2 variety in the hyaline, elastic and type 1 in fibrous. Perichondrium is present in both elastic and hyaline but not present in fibrocartilage. It's the same thing which I have told you is tabulated. So you just go through this and also the images are there for the comparison. Now after this, let's have an MCQ session regarding these topics. This is okay. That will help you to understand more. Okay. So epiglottis, which cartilage is there? Can we have MCQs? Practice. Epiglottis is having which cartilage? Yes, dear students, epiglottis is having which type of cartilage? Epiglottis. Epiglottis is actually the part of larynx. It will have elastic cartilage. So epiglottis is actually a leaf-shaped cartilage which is lying on the posterior aspect of tongue. So it is actually it is of elastic variety. So please note down, it is of elastic variety. It is of elastic variety. See here. I think here they must have given the examples. See here. Elastic cartilage, here epiglottis. In the ear, pinna and epiglottis is an example of elastic cartilage, not the hyaline one. Not the hyaline one. Okay? Got it? Okay, now coming to the next MCQ. Type of collagen is present in hyaline cartilage. Type of collagen fibers in hyaline cartilage. In hyaline cartilage. Hyaline is type 2 collagen fibers. Yes, if I talk about hyaline, it is type 2 collagen fibers. Yeah. Now coming to the next topic, that is neck. So in the neck, in the head and neck part, actually triangles of neck is very important topic. Arteries of neck is very important topic. So I would like to emphasize on these topics. So let's start with the first posterior triangle. So in this image, we can see posterior to sternocleidomastoid. So two muscles has been shown in this image. One is SCM. What is the full form of SCM? Sternocleidomastoid muscles. Sterno means attached to the sternum. Cleido means attached to the clavicle. And M for mastoid means the mastoid process of temporal bone. So basically, let me just highlight it. So basically, the anterior border or posterior triangle of neck. So I just want to highlight this sternocleidomastoid muscle. So sternocleidomastoid muscle is forming anterior border of the posterior triangle of the neck. Okay, posterior triangle of neck. As you can see in this image. See here, I'm just highlighting it. Okay, and the posterior border of this posterior triangle is by which muscle? Trapezius muscle. I have again highlighted it with brown color. This is the trapezius muscle. So what about the boundaries? So what about the boundaries? So if I talk about the boundaries, this will be the joining of both the muscle. This will be apex at the superior nuchal line. So here this posteriorly is the trapezius muscle, anteriorly is sternocleidomastoid muscle. So this is trapezius muscle. So trapezius muscle is the posterior boundary, sternocleidomastoid muscle is the anterior boundary, and apex is formed by the joining of sternocleidomastoid muscle with the trapezius muscle at the posterior aspect of the occipital bone and the superior nuchal line. What about the base? The base is formed by middle 1/3 of the clavicle. So middle 1/3 of the clavicle is forming the base. Trapezius is forming P for posterior. Sternocleidomastoid is forming the anterior boundary. So I think everyone is quite aware of the boundaries of posterior triangle with this image. Now, my dear students, can you see the whole of the posterior triangle is again divided by another muscle which is called as omohyoid muscle. So actually omohyoid muscle has been shown in blue color in this image. So this muscle which you are seeing is the omohyoid muscle, and this omohyoid muscle is dividing the posterior triangle. So this omohyoid muscle is dividing the posterior triangle into upper and lower part. So upper part of posterior triangle is called as occipital triangle, and lower part of posterior triangle, if I talk about lower part of posterior triangle, it is called as the subclavian triangle. So this is how the entire posterior triangle is divided into two triangular area. Got it? Now, it's why I have done this, because we have to know exactly separately the content of occipital and subclavian triangle. Subclavian triangle has been shown in red color. Now, here I also want everybody to know about sternocleidomastoid muscles, a very important muscle in the neck region. Actually, sternocleidomastoid muscle, when unilaterally contract, it turn the actually what happened, it turned the head to the same side and that of the chin to the opposite side. So that means it rotate it to the opposite side. So that means it turn the chin to opposite side and tilt the head towards the same side. So such kind, so let me show you this, turning the head and rotating it to the other side. So this is the action of sternocleidomastoid muscle. So it is like sideways upward gauge. So this will be the action of sternocleidomastoid muscle, and when bilateral contraction of sternocleidomastoid muscle happens, we raise the neck from the bed, and we raise the neck in case of eating food. That is, head forward pulling is done by sternocleidomastoid muscle. Done? Now, if I talk about roof of posterior triangle, so roof of posterior triangle is having skin, superficial fascia, and we will have the muscle in the superficial fascia, which is called as platysma muscle, which is called as platysma muscle. Okay, which is called as platysma muscle. No doubt about this. This is the platysma muscle. Okay. Now this platysma muscle is covering the roof. But if I talk about roof of posterior triangle, it is formed by investing layer of deep cervical fascia. So write down roof of posterior triangle of neck is formed by investing layer of deep cervical fascia. Is formed by investing layer of deep cervical fascia. So it is formed by investing layer of deep cervical fascia. Roof of posterior triangle is formed by which layer of deep cervical fascia? Investing layer of deep cervical fascia. That means outermost layer of deep cervical fascia. Now, there is one cadaveric image. So I want everybody to concentrate on this cadaveric image. Actually, when you go with the dissection of the neck region, and in that case, you can find few structures residing in the superficial fascia of the roof, that is few nerves and vein. So basically, I would like to define once again the posterior triangle in this cadaveric area. Everyone, please concentrate on this image. So let me just enlarge this image. So I just want to slightly enlarge it more. So is it okay? So I'm just enlarging it, slight enlarging. So now I would like to highlight this muscle. Okay, so here we will have this muscle as sternocleidomastoid muscle, and this is T for trapezius muscle. This will be apex, and this will be the base, middle 1/3 of the clavicle. This is the base. So no doubt about the boundaries of posterior triangle, everyone. So this is which topic? This is posterior triangle of the neck, which is showing the roof area. So I think everybody is aware of the posterior triangle roof area. So after that, I just want that we should know about the content. So let me highlight it. I would like to highlight the vein. So this is the external jugular vein. Which vein is this? This is the external jugular vein which you are seeing. This is external jugular vein, which is the content here. And let's talk about the nerves. So we will also have nerves. So cutaneous nerves is seen here. And what are these cutaneous nerves which is shown in this image? So actually this is going down. So actually this point is called as cervical point. Which point is this? This is the cervical point from where four cutaneous branches of the cervical plexus is the content of the roof of posterior triangle, and the name of these nerves are great auricular nerve, lesser occipital nerve, transverse cervical nerve, and the one multiple branches going lower down to the clavicle. What are these? These are multiple branches which you are seeing. These are supraclavicular nerve. So my dear students, we have got an external jugular vein as the content of the roof and the four. So we can see here external jugular vein as the content. We will have the lesser occipital nerve, the great auricular nerve, the transverse cervical and supraclavicular nerve. All these are the contents of the roof of posterior triangle, which is residing in the superficial fascia of the roof. And which layer of deep cervical fascia is forming the roof is the investing layer of deep cervical fascia. Done with this. Now coming up with the floor of the posterior triangle. So when I talk about the floor of posterior triangle, the floor is formed by the prevertebral layer of deep cervical fascia. So in this diagram, again, when I want to enlarge it, I am using green color, which has been dissected out so that you can see the floor muscles, which so basically prevertebral layer of deep cervical fascia is covering the floor muscles. It is covering the floor muscles of posterior triangle of neck. Now, it's also important for you to know that which muscles are forming the floor of posterior triangle. So many labelings are there, but I want you to concentrate on the floor of posterior triangle. So well, let's see. So basically, that means actually there will be in few dissections, semi-spinalis capitis is sometimes not visible, but you will see few vertical fibers at the uppermost part of the floor muscles in the posterior triangle, that is semi-spinalis capitis. Lower to it we have got splenius capitis, lower to it we have got levator scapulae muscle, and lower to it we have got scalenus group of muscles. So actually 1 2 3 4, these are the muscles which is forming the floor of posterior triangle, and it is covered by prevertebral layer of deep cervical fascia. I also want everybody to know that in between the investing layer of deep cervical fascia and the prevertebral layer of deep cervical fascia, we have got the spinal accessory nerve running or residing. Spinal accessory nerve is the most important content of posterior triangle of the neck, which innervates sternocleidomastoid and trapezius muscle. Okay. Okay. So got it, my dear students? Now, okay. So let's now see the content of posterior triangle. So in the initial part only, I have told you there is inferior belly of omohyoid, which will divide the entire triangular area of the posterior triangle of the neck into region above and region below. The upper region, which has been shown with red color dotted line, is the occipital triangle, and the lower region, which has been shown by the green color dotted line, is the subclavian triangle. You have to know the content of occipital triangle and the subclavian triangle basically at the two important areas. Okay, so basically the important contents of occipital triangle I have already marked in this image is the occipital artery and the occipital lymph node. Okay, then we have got the four cutaneous branches, that is great auricular nerve, the transverse cervical, the supraclavicular nerves which is residing down, and that of lesser occipital nerve. Also the spinal accessory nerve, which is, okay dear, yes dear, what you didn't understand, please let me know what you didn't understand. One of the student, ma'am, I didn't, which part you didn't understand, please let me know. There is inferior belly of omohyoid, which will divide the entire posterior triangle into a triangular area above and lower. So we have to know separately the content of occipital triangle and subclavian triangle. So when I talk about occipital triangle, very easy to remember, the four cutaneous nerves that are branches of cervical nerve, which we have discussed in the roof, the occipital artery, the occipital lymph node, and spinal accessory nerve. What is spinal accessory nerve? The 11th cranial nerve spinal part, which is running in between the roof and the floor layer, that is in between investing layer and the prevertebral layer of deep cervical fascia. Also, we will have the C3, C4 nerves, dorsal scapular nerve. These are the content of occipital triangle. Other than that, in the lower triangular areas, we have got mainly the trunks of brachial plexus, the subclavian artery and vein, and the branches from the upper trunk of brachial plexus. Okay. Now, content of posterior triangle. Occipital triangle, you are already knowing. It contains occipital artery, occipital lymph nodes. It contains four cutaneous branch of cervical nerves. And I think name is known to you. Great auricular nerve, lesser occipital nerve, transverse cervical nerve, the supraclavicular. Now, other than that, we also know that it contains a most important content is spinal accessory nerve. Okay, other than that, other contents are C3, C4 nerves, dorsal scapular nerve also. Also, it contains the associated structures, occipital arteries and the lymph nodes. And these are the main contents of occipital triangle. Now coming to the subclavian triangle. So very easy to remember, the subclavian artery and subclavian vein will be the important content. So only named as subclavian triangle, the supraclavicular lymph nodes, Also the trunks of brachial plexus, and also, my dear students, it contains fourth and fifth SS and NS. So what do you mean by SS and NS? It's the branch from the upper trunk of brachial plexus. So SS stands for suprascapular nerve and NS stands for nerve to subclavius. Okay, SS stands for suprascapular nerve and NS stands for nerve to subclavius. So some other structures like transverse cervical artery is also the content. So is it okay? Have you understood till now? I would like to tell one clinical anatomy. So two clinical anatomies related to posterior triangle. One is, we know that the content in external jugular vein. So if an incision is done, sometimes air embolism happens due to cut in the external jugular vein. Other thing is, we know that the position of spinal accessory nerve is sandwiched between the roof and the floor, that is between investing and the prevertebral layer of deep cervical fascia. So if it is injured, two muscles are innervated by spinal accessory nerve, that is trapezius and sternocleidomastoid, which can be paralyzed. Now, when sternocleidomastoid muscle is paralyzed, when we are talking about sternocleidomastoid muscle, it is actually paralyzed. So it is difficult for you to turn the head to the same side and rotate it to the other side. This is upward sideways gauge, and trapezius is involved, then the shrugging of shoulder will be affected, or overhead abduction of shoulder is affected. Yeah, carotid and all triangles, I'm coming to that part, don't worry. Now we are in posterior triangle only. After this we will come to that topic. Okay, now, can we solve few MCQs? Okay, try to solve sternocleidomastoid muscle. So it arises from sternum and clavicle, inserts onto the mastoid process, motor supply spinal, tilt the head to opposite side. What is the right answer? Which is the wrong statement? Yes, tilt the head to opposite side is wrong. It tilt the head to same side, rotate the head to opposite side, rotate the head to opposite side. So it is rotating the head to the opposite side but tilting it to the same side. So this is the wrong statement. This is the wrong statement. Okay, this is the right answer. Very good. All are the contents of occipital triangle except great auricular nerve, suprascapular nerve, lesser occipital artery, which is not a content of occipital triangle. Okay, with a question mark, suprascapular, absolutely correct. Suprascapular nerve is branch of upper trunk of brachial plexus. Yes, it's a branch of upper trunk of brachial plexus. So it will be the content of subclavian triangle. It is content of subclavian triangle. It is not the content of occipital triangle. Rest all are the content of occipital triangle. Yes. Yes, my dear students. So second is the right answer. Now let's come to a clinical question. Let me read it for you and then you can mark the right answer. A 43-year-old woman came with a large abscess in the middle of the right posterior triangle of the neck. The physician incised and drained the abscess. 5 days later, the patient noticed she could not extend her right arm above the head to brush her hairs. Which of the following additional harm is seen here? Damage to scalenus, injury to suprascapular. There is a cut in the spinal accessory nerve or spread of infection to shoulders. Which is the best possible answer here? So I got many of the answers are coming up. Yes, so I'm getting the answer here. Yes, dear. So trapezius muscle involved, and what is the yes, C is absolutely right answer. Spinal accessory nerve is the nerve supply and that is affected in this case. So obviously C is the right answer. Now we have finished. Absolutely correct, dear. Now we will come to the next triangle, that is anterior triangle. So now we'll talk about anterior triangle of the neck. Okay. So yes, if I'm talking about anterior triangle of the neck, the boundaries of anterior triangle of the neck is, it's bounded posteriorly by sternocleidomastoid muscle. So when I'm talking about sternocleidomastoid muscle, which is shown in this image, this is forming the posterior boundary. This lies posteriorly. The mid-neck line, as you can see, the mid-neck line which starts from symphysis menti and ending at suprasternal notch, that is lying above manubrium sterni, this is forming the anterior border. This is forming anterior border of anterior triangle of the neck. And the base which is lying above is formed by the lower part of the mandible and also an imaginary line extending from angle of mandible towards the mastoid process, extending till the mastoid process. And apex is lower down, and here apex is formed by, if I talk about the apex of anterior triangle is formed by suprasternal notch. It's formed by suprasternal notch. Okay. Now let's see the subdivision of anterior triangle. So actually, let's see how it is subdivided into 4 smaller triangles. So actually, here is an image where four different circles and colors has been used for the subdivision of anterior triangle into following in the following areas. As you can see in the following areas of triangular area, that is green color for submandibular triangle. We have got pink color for submental triangle, blue color for carotid triangle, and yellow color for muscular triangle. Actually, the division of anterior triangle in this 4 triangular area. So if I'm talking about how it is divided in this 4 triangular area is because of, so how it is done, this is done by these muscles. So it is done by the digastric muscle. It is done by the superior belly of omohyoid. So basically, first thing is that we are quite aware. So I would like to first show you the boundary of anterior triangle. Okay, so this is the outline of anterior triangle. So superiorly, or the base, as you can see, it is the mandible, no doubt about this. And this is anterior mid-neck line. Now, here in this diagram, you can see this is the muscle. Here in this diagram, this is the stylohyoid muscle and this is the digastric muscle. Okay, this is the digastric muscle. Okay, this is anterior belly and posterior belly. So here, this is anterior belly of digastric muscle and this is posterior belly of digastric muscle. And this is actually posterior belly of digastric muscle and this is stylohyoid. So these muscles along with one more muscle, that is superior belly of omohyoid. This is superior belly of omohyoid. So basically superior belly of omohyoid and that of two bellies of digastric muscle along with stylohyoid muscle will divide the entire area of anterior triangle into 4 triangular areas. The submandibular triangle, the submental triangle, the carotid and the muscular triangle. And you have to know the boundaries of individual triangle and the content separately. Okay, dear. So that is important for you to know. So let's start one by one. So I would like to start with the submental triangle. Is it okay? Let's start with the submental triangle. So any student is finding any difficulty in not understanding, please let me know. Any students is finding any difficulty in not understanding, you can just ask me doubts and I am ready to explain you right itself when the session is going on. Okay? So let's come up with a submental triangle. So for better understanding, I am just enlarging this image. Is it okay? So I just want an enlarged view of the submental triangle. so that you can understand it nicely. So here we are focusing in just one triangle, that is submental triangle. So we have to know the boundaries. So let's see the boundaries. So it is bounded by, on either side, it is bounded by this muscle. So on either side, it is bounded by anterior belly of digastric. So on either side, it is bounded by anterior bellies of digastric muscle. So this is lying on either side. On either side, we have got anterior belly of digastric muscle, which is forming the boundary, the apex. Now, above, the apex is formed by this depressed area where the two mandibular half is meeting, that is called as symphysis menti. So what is this? This is symphysis menti. Symphysis menti. Symphysis menti is forming the apex of the submental triangle, and what lies below or the base, my dear students, the below or the base is formed by this bone, which is the hyoid bone. This is hyoid bone forming the base. So we have got the boundaries, no doubt, we have got the boundaries. And also in this diagram, you can see the muscle residing as the floor muscle. And these floor muscle is the mylohyoid muscle. Which muscle is this? This is the floor, which is formed by mylohyoid muscle. And the mylohyoid muscle, as you can see, is meeting in the midline. This is called as mylohyoid-raphe. Okay, so the floor muscle is mylohyoid, which is meeting in the midline, forming mylohyoid-raphe. Forming mylohyoid-raphe. Is it okay? So everyone understood the boundaries and the floor of submental triangle. The next important thing is to know the content. So it's also important for you to know the content of the submental triangle. So when I'm talking about the content of submental triangle, it is the submental lymph nodes and it is also the anterior jugular vein. Okay, so we will talk about that. Let's come to that. Okay. So I just want everybody to write also about the submental triangle boundaries. I just it's already there, so no need to write separately the boundaries. But for the content, you can write it. So please write on the content. Okay, here itself. So here itself, write on content. So if I talk about boundaries is marked here, content of submental triangle will be 2. The submental lymph node and anterior jugular vein. Submental lymph nodes and anterior jugular vein. Got it? Now coming to the next, that is the digastric triangle. So what is the other name of digastric triangle? Digastric triangle is also called as submandibular triangle. So why it is called as submandibular triangle? Why? Because the reason is that digastric triangle, one of the important content is submandibular gland. So it is called as submandibular triangle. And it is important for you to know the boundaries and it is important for you to know the content residing inside. So for that, I just want, okay, we will concentrate only on the boundaries of digastric triangle. So I just want to highlight. I just want to slightly enlarge this image. So that will be okay for you if we go with the enlargement of the image. Please that will be very easy for you to understand. So let me just enlarge this image. So when I'm enlarging this, you can have an idea of digastric triangle boundaries. So when I'm talking about digastric triangle boundaries, okay, it is also called a submandibular triangle. Okay, now here, so the boundaries are, so above is the body of mandible. So this is mandible. So above will be the mandible, no doubt the above that. So let me just enlarge. Above is the mandible, no doubt about that. Okay. And also we will have antero-inferiorly and we will have postero-superiorly. So antero-inferiorly we will have the belly. So this is above, or you can say base, above or base. This is antero-inferior boundary. Antero-inferior boundary. Antero-inferiorly, it is bordered by anterior belly of digastric. Okay, my dear students. Now, what lies posteriorly? So basically, more of dissection has been done, but on the posterior aspect, there will be another muscles. So there will be posterior belly of digastric and stylohyoid together. So posterior-superiorly, it will be bounded by posterior belly of digastric plus stylohyoid muscle. And below or apex is formed by digastric tendon. The two bellies, the two digastric muscles bellies are meeting, as you can see. So the two digastric bellies are meeting in between, and this is called as, which is attached to this hyoid bone. So digastric intermediate tendon, which is intermediate tendon, which is actually attached to hyoid bone. So I think it is okay that the boundaries can be seen in this image, and what lies inside. So inside, if I talk about muscles which is lying inside, so we will have the floor muscle, we will have hyoglossus and mylo. So basically there will be mylohyoid and hyoglossus muscle. So HM, so HM is the floor muscle. So in the floor we will have, okay, here as you can see, one more image is there, the floor of digastric muscle. So here you can just write the name of two muscles. So we will have posteriorly one muscle and we will have anteriorly one muscle. So we will have hyoglossus muscle and also the mylohyoid muscle. So these are the two floor muscles. These are the two floor muscles. Okay, my dear students, understanding any doubt you can ask me. If anything you are not understanding, you can ask me. So till now we have done the boundaries, we have done the floor, and now the next thing is to know the content of digastric triangle. So it's important that you should be knowing the content of the digastric triangle. As already I have told you, the most important content is submandibular gland. And in this image, the dissection has been done here. And basically, you can, the highlighted area is the digastric triangle containing SMG. What is SMG? So submandibular gland with the duct. So this is submandibular gland and duct, which is the most important content. Okay, so here we can have the anterior belly of digastric. We will have the posterior belly of digastric and stylohyoid muscle and the triangular area, and above we will have the base, and below is the apex held to the hyoid bone, and the important structure is SMG. What is submandibular gland? Submandibular gland and duct. So these are the most important content. This is the most important content of digastric triangle. Okay. Now, I'd like everybody to have see this image where we can see the content of digastric triangle as per the cadaveric dissection. So I want to show you two images. One is superficial dissection, another is deeper dissection to make you understand the important contents of digastric triangle. Okay, dear? So let's see important images and the important structures. So let's start with the first image, that is the superficial dissection image. So continuing with the content only. So here we can see the artery here. So I'm just using red color for highlighting the artery. It is tortuous facial artery is this. And close to it we have got the vein, facial vein. And we will have the SMG, submandibular gland. So these three important content is visible in this, which is most important. So we will continue this with the facial artery, facial vein. We will have SMG, submandibular gland. So I think that is already written also above. So these important contents has been visible here. Now coming to the deeper dissection, few more contents. So when I prime content, which can be also asked as an image-based question, and that is actually when you go for dissection, two important muscles, hyoglossus muscle and mylohyoid muscle is the content. Other than that, the constrictor muscle, middle constrictor muscle is also the content. And on deeper dissection, one of an important nerve is shown as the content. This important nerve, and which nerve is this? This is the which is running in front of the carotid artery. This is hypoglossal nerve, and also one more nerve which is seen is the nerve to mylohyoid. So mylohyoid muscle and nerve to mylohyoid is seen. So please write down. The content will be hypoglossal nerve and also the nerve to mylohyoid muscle as the content, nerve to mylohyoid muscle. Okay. So actually all these are content. So basically these are the most important content. Mylohyoid vessels will also be the content. So I think continuing with this, other contents also you can write down. Mylohyoid vessels. We will have mylohyoid vessels. Not only this, my dear students, we will also have posteriorly, in the posteriorly part, when that means in the posterior part of the digastric triangle, we will have also the contents as stelloid process, styloglossus and stylopharyngeus, styloglossus muscle and stylopharyngeus muscle. And also in the posterior aspect, we will have, these are carotid sheath and its content, carotid sheath and its content. So actually these are the structures which will be in the content as you move more posteriorly. As you move more posteriorly. Understanding, students, are you understanding? Let me just check. Okay. So now next triangular area is carotid triangle. So now we will talk about carotid triangle. The red color outline which you are seeing is the carotid triangle. So firstly, in the same way, we will go with the boundaries, then we will go with the contents. So this is what you are seeing is the carotid triangle. So we have to know about the boundaries of carotid triangle and then we have to know the content. So here, firstly, you can write boundaries of carotid triangle. So we can see one muscle here. I think you are able to recognize this muscle very nicely. What is this muscle? Sterno-cleidomastoid muscle. So this is forming the posterior boundary, which is forming the posterior boundary for the carotid triangle. So this muscle is sterno-cleidomastoid muscle. This is forming posterior boundary of carotid triangle. Okay. Now coming to the other important, so and basically on the superior aspect. So basically also in the superior aspect, we will have also two muscles. So we will have here stylohyoid and posterior belly of digastric. So basically we will have posterior belly of digastric and stylohyoid muscle. So posterior belly of digastric and stylohyoid muscle, these two structures will be forming its boundary superiorly. Okay. And what about the superior belly of omohyoid? So when I'm talking about superior belly of omohyoid, it is forming the boundary antero-inferiorly. So this is superior belly of omohyoid muscle, which is forming antero-inferior boundary. Antero-inferior boundary. So done. So we have done with the carotid triangle boundaries. Now we have to know the contents of carotid triangle. So next is to know the contents of carotid triangles. We have done with this. Now coming to the contents. Now here actually this is showing an area of carotid triangle. So we have to I just want you to tell that all the carotid arteries. So you can see CCA means common carotid artery, and this is dividing into internal and external carotid artery. So why this area? Why this area of anterior triangle is called as carotid triangle? Because all the carotid arteries, common carotid artery is external carotid artery, internal carotid artery. So external carotid artery give blood supply to head and neck, arterial supply to head and neck, and brain is getting blood supply from internal carotid artery branches. So all these are the contents of carotid triangle. Vagus nerve, which is located in the carotid triangle, is actually traversing in between carotid internal carotid and common carotid artery and internal jugular vein. So this is exactly, and here a note point has been written, that is vagus nerve is posteromedial to common carotid artery and it's posterolateral to common carotid artery and posteromedial to internal jugular vein. This idea of vagus nerve in the carotid sheath will help you to give a better view and dissection. Now, content of carotid triangle, the important contents are actually last three cranial nerve. When I am using the word last three cranial nerve, means the 10th, 11th and 12th. 11th which part? Spinal accessory nerve. The carotid sheath and its content internal jugular vein, the carotid arteries and that of vagus nerve. And also we will have the carotid body and the carotid sinus. And also we will have the important structures like that of branches of external carotid artery, which has been shown here, like the superior thyroid, the lingual, the facial, the ascending pharyngeal, occipital artery. So basically, I want everybody to write. So these are the images in which you can see the content of carotid content of carotid triangle, and you can write all together the content of carotid triangle. To summarize, it contains all the carotid arteries and carotid sheath and its contents, last three cranial nerves, and also branches, 5 branches of external carotid artery. Other than that, it also on the carotid sheath there is a nerve loop which is embedded, which is called as ansa cervicalis, and we have got carotid body and carotid sinus. After that, I will give you slight detail of carotid, this ansa cervicalis. I will give you slight detail. Okay. So important contents has been highlighted. Carotid triangles, it's already written here. So it's yes, okay, very good. So all the carotid so it contains last three cranial nerves. I'm just summarizing together all carotid arteries. That is ECA, ICA, common carotid artery. Last three cranial nerve is 9, 10th, 11th, spinal accessory nerve. Carotid body and sinus. Ansa cervicalis. Okay, and we can also see the branches of external carotid artery, which I have already written in this image. Now, the next topic which I want everybody to understand is ansa cervicalis loop. So, yes, it's it's 10th. Okay, yeah, it's 10th, 11th, and 12th. Okay. Yes, dear, it's 10th. Last three cranial nerves mean 10th, 11th. Yes, very good. Thanks for the correction. Yes, it will be 10th, 11th, and 12th now. Yes, dear, it will be 10th, 11th, and 12th now. Yes, yes, you are absolutely right. Okay, now let's talk about ansa cervicalis loop. So, ansa cervicalis loop, as you can see, when you go with the beautiful dissection or superficial dissection, you can appreciate ansa cervicalis loop, which is embedded in the anterior wall of carotid sheath. So, you have to know its formation. You have to know the upper and lower limb of ansa cervicalis formation and which all muscle it supplies. So basically it is supplying infrahyoid muscle. So in this diagram you can see the upper limb of ansa cervicalis is formed from C1 running along with the 12th cranial nerve. That is C1 is mainly forming the upper limb of ansa cervicalis and C2 and C3 is forming the lower limb of ansa cervicalis. Now it is important to know that which all muscle it supplies. So see here. If we talk about ansa cervicalis loop, it supplies the loop. I'm only talking about this loop. So the loop is supplying superior belly of omohyoid, sternohyoid, and inferior belly of omohyoid. Actually, what does it mean? It means the infrahyoid muscle is supplied by ansa cervicalis loop. So I just want to add on that all the infrahyoid muscle is supplied by ansa cervicalis loop except thyroid. So this thyroid is the infrahyoid muscle. So it is supplied by, it is not supplied by ansa cervicalis loop. It is supplied by C1 nerve, which is running close to which nerve? 12th cranial nerve, which is running close to the 12th cranial nerve. Okay, my dear students, so we have done with this. So we have done with the ansa cervicalis loop, but I want everybody to concentrate on this image in which I want you to show the cadaveric image. Okay, dear? So let me just enlarge this image. So when I'm enlarging this image, you can have a diagram in which you can see the dissection area of carotid triangle. So basically, let me use, so here you can see this is the nerve which I have highlighted. Which nerve is this? V for the vagus nerve. Okay. So basically this is vagus nerve. I'm just connecting this nerve together. Okay, this is the vagus nerve, and this is also in this diagram you can see internal jugular vein, part of internal jugular vein. Okay, and you can see also the carotid arteries. CC for carotid arteries. Okay, now it's clear that these are the three contents of carotid sheath. And in the explanation part, I have already told you the ansa cervicalis loop is embedded in the anterior wall of carotid sheath. Now I am showing you the loop. So see here. Here the loop SR means superior and IR means inferior root of ansa cervicalis. And can you appreciate, everyone? Can you appreciate the ansa cervicalis loop is embedded on the anterior wall of carotid sheath? Okay. So this is just showing you the loop ansa cervicalis. All the infrahyoid muscle is supplied except the thyroid muscle. So we have done with this. Now in anterior triangle, the last triangular area is the muscular triangle. And why it is called as muscular triangle, I will tell you. Because only muscles are the content and no nerves and vessels are lying in muscular triangle. So it is bounded anteriorly by mid neckline. So it is bounded anteriorly by the mid neckline. If we talk about muscular triangle, and if we talk about its posterior-inferior boundary, it is bounded by sternocleidomastoid muscle. Posterior inferior boundary. And superiorly we will have, and superior aspect or superiorly we will have the superior belly of omohyoid. So this is the superior belly of omohyoid. This is the sternocleidomastoid muscle, and this is the anterior neckline. So this is forming the muscular triangle boundary, and the content are just the muscle. The content are just the muscle. So basically the content will be sternohyoid muscle, sternothyroid muscle, and also thyroid muscle. So floor and content. So basically three muscles are there: sternothyroid muscle, sternohyoid muscle, and omohyoid muscle. And thyroid muscle. So all these muscles are the content and floor of muscular triangle. Now let's solve few MCQs, and then I will come with one more triangular space, that is occipital triangle. Okay, my dear students. Okay. So all are supplied by ansa cervicalis except. All are supplied by ansa cervicalis except. All are supplied by ansa cervicalis except. All muscles are supplied by ansa cervicalis except. Which is the right answer? A, thyroid is absolutely right, my dear students. On both the side, ansa cervicalis, on both the sides, submental triangle is bounded by which muscle bellies? Yes, absolutely right. Anterior belly of digastric. Very good. Which of the following is false statement? Sternocleidomastoid. We have already done this. Tilt the head to opposite side. It is tilting the head to same side. It is tilting the head to, it is rotating the head to opposite side. Rotating opposite. Sternocleidomastoid is rotating the opposite side, not tilting it. We have done this. Yes, D, we have already done this. Now coming to the next triangular space, that is called as suboccipital triangle. So suboccipital triangle is a small triangular area which is seen in the dissection when it is done at the back of the neck, in the nape of the neck. And its boundaries are obliquus capitis superior muscle, as you can see. If we are seeing the obliquus capitis superior muscle, it is forming supralateral boundary. So it is forming supralateral boundary. Rectus capitis posterior major is forming supromedial boundary. Supromedial boundary. And inferiorly, as you can see in this diagram, on inferior aspect, we will have obliquus capitis inferior muscle. So that means these three muscles, that is obliquus capitis superior, obliquus capitis inferior, and rectus capitis posterior major, is forming the boundary of suboccipital triangle. Is forming the boundary of suboccipital triangle. So same thing here, we can again see this image. So basically, if you will see this image, you can have the idea. So as I told you, this is obliquus capitis. So this is obliquus capitis superior muscle. Obliquus capitis, this is obliquus capitis inferior, and this is rectus capitis posterior major muscle. So these three muscles are forming the boundary of suboccipital triangle, no doubt about this. Okay, dear, no doubt about this. Now there is another image which is showing the same structures, and also in this you can see the semispinalis capitis is the muscle which has been cutted out, so that you can see the interior, the triangular area, that is the suboccipital triangle. What is asked in examination is what is the content. So what are the structures forming the floor and what are the structures lying inside? So the content is third part of vertebral artery, suboccipital nerve, which is formed by dorsal ramus of first cervical nerve, and suboccipital venous plexus. If I am talking about the floor structure, it is formed by posterior atlanto-occipital membrane. And also it is not only that, if I talk about, it is also formed by posterior arch of first cervical vertebra. So see here. So in this diagram, suboccipital triangle floor structures we will see. What we will see? We will see the floor structures. The floor structures are posterior arch of C1 means first cervical vertebra, and this is posterior atlanto-occipital membrane. Posterior atlanto-occipital membrane. Okay. So done with this. Now about the content. So now if I talk about the content, so basically again in this area, if I am enlarging it, so you can clearly see in this image, as you can see in this image, we can see the suboccipital triangle with its boundary, rectus capitis posterior major as the supromedial boundary, obliquus capitis superior as the supralateral boundary, and obliquus capitis inferior as the inferior boundary. The content residing inside is the third part of vertebral artery, suboccipital nerve. And not only this, we have got the third content that is called as suboccipital venous plexus. So my dear students, I just want everybody that you have to know this content nicely. And the suboccipital nerve is formed from the dorsal ramus of first cervical nerve. Done? Now, let's solve few MCQs. So all of the following are the content of suboccipital triangle except, which is not the content of suboccipital triangle. All of the following are the content of suboccipital triangle except. Absolutely correct. Occipital artery is the content of occipital triangle, not suboccipital triangle. Yes, very right. Absolutely right. Now, posterior triangle is divided into two parts by which of the following next structures? Posterior triangle, my dear, it's the posterior triangle, not the anterior triangle. So it will be divided into two parts by, yes, inferior belly of omohyoid. Absolutely right. Now, damage to ansa cervicalis during dissection will affect which muscle among the option given? Thyroid, cricothyroid, stylohyoid, sternothyroid. Next question, please mark the right answer. Damage to ansa cervicalis. So, damage to ansa cervicalis affect which muscle? The question is affect which muscle? Will affect which muscle? It is not telling which will not be affected. Will affect which muscle? Ansa cervicalis supplies infrahyoid muscle. So what is the name of infrahyoid muscle which is supplied? Which is supplied? Yes, now comes the right answer, dear. Yes, it is sternothyroid, sternohyoid, and two bellies of omohyoid. Now, a patient is unable to move his neck to the left, also rotating and bending of the neck onto the same side, which head is still to the left, the chin deviates to the right. So, which of the following muscle is responsible for such action? Which of the following muscle is responsible for such action? The options are sternocleidomastoid, trapezius, platysma, and scalenus muscle. So, what is the right answer? Here comes the right answer, sternocleidomastoid. Absolutely correct. Now, a patient complains of repeated episodes of dizziness, fainting. The doctor massage the neck to observe the blood collection and pressure. Which of the following triangle is involved? So, my question is, I will just a minute. This is A triangle. This is B. This is C. And this is D triangle. So, can you tell me which triangle is affected in this case? Can you tell me which triangle is affected in this case? C is absolutely right. Yes, C triangle. C triangle is right answer. Yes, dear, C triangle is the right answer. Carotid triangle is affected. Yes, the content of carotid sheath is affected and carotid triangle is affected. Now coming to the next topic, a very important topic that is called as cranial foraminas. Okay, very important topic that is cranial foraminas. Now, in this diagram, actually, why I am showing you this diagram is actually I will go simultaneously, one by one, sorry. I will go one by one with the cranial foraminas of anterior cranial fossa, cranial foraminas of middle cranial fossa, and then cranial foraminas of the posterior cranial fossa. I just want everybody that in the anterior cranial fossa, we have got cribriform plate as the very important cranial foraminas. And these all optic canal, superiorbital fissure, foramen rotundum, foramen ovale, foramen spinosum, and lacerum. These are all important foraminas of middle cranial fossa. So this is ACF, anterior cranial fossa, this is middle cranial fossa, and this is posterior cranial fossa. In case of posterior cranial fossa, we have got internal acoustic meatus, jugular foramen, foramen magnum, and hypoglossal canal. So actually, these are the most important foraminas which is repeatedly asked in the FMG entrance exam. So we will go one by one in these each of the foramens. Is it okay? And we will know about the structures passing through this foramen. Okay, dear. So let's come up with the explanation. So I would like to start with anterior cranial foramen. Anterior cranial fossa foramen. Is it okay? So you can have a look on the enlarged view of anterior cranial fossa and we will have the foramina. So basically the first foramina which you are seeing. What is this? This is cribriform plate of ethmoid bone. This is cribriform plate of ethmoid bone. And anteriorly here one more foramen will be there. And on either side there will be two small foraminas. So this is FC for foramen cecum. This is anterior ethmoidal foramen and this is posterior ethmoidal foramen. So actually these are the four foramens which is the important foramen of anterior cranial fossa and you have to know the important structures passing through these foramens. Okay, so let's start. So we will start with the structure. So I would like to first tell you about the structures, important foramens of anterior cranial fossa, then middle and then the posterior. So in the anterior cranial fossa, the first important foramina which you have to know is the cribriform plate of ethmoid bone, which is having many sieve-like perforations for the olfactory nerve rootlets. So we will have cribriform plate of ethmoid bone. The cribriform plate of ethmoid bone is having perforations and through this perforation what structure passes? Olfactory nerve rootlets. Rootlets. Now talking about the next. Foramen cecum. So if I talk about foramen cecum, through foramen cecum the structure passes as emissary vein, emissary vein connecting nasal mucosal vein with superior sagittal sinus. Okay. Now we will talk about, so these are the two foramens of anterior cranial fossa through which structures passes. Now we will talk about two more foramina, that is anterior ethmoidal foramen and posterior ethmoidal foramen. So let's see. AEF means anterior ethmoidal foramen. So when we talk about anterior ethmoidal foramen, it's very easy to memorize anterior ethmoidal foramen structures passing, that is anterior ethmoidal nerves and vessels. What passes? Anterior ethmoidal nerves and vessels. Now, talking about posterior ethmoidal foramen. So, if I talk about posterior ethmoidal foramen, the structures passing will be posterior ethmoidal nerves and vessels. So, yes, my dear students, we have finished with important foramens of anterior cranial fossa. Now, we will move on with the middle cranial fossa. So, basically, in the middle cranial fossa, important foramens I will tell you and the structures passing. So, let me just enlarge this. So, the important foramens will be one here. The one which is not visible will be somewhat below this. Then we will have these foramens. And one is the irregular foramen. Okay, now please have a labeling of it. So this is optic canal or foramen. This is superior orbital fissure. This will be foramen rotundum. This will be foramen ovale. This will be foramen spinosum. And this will be foramen lacerum. So actually these are the important foramens of the middle cranial fossa which everybody has to be known down. Every student should be knowing this and the structures passing through these foramen. Okay, my dear students, so let's see the structures passing through this individual foramen and wherever necessary, I will give you a mnemonic for by-hearting this. So let's start. So the first foramen which I want everybody to understand is optic foramen or optic canal. So the structure passing through the optic foramen or optic canal is the optic nerve and ophthalmic artery. And what is the mnemonic for it? O2. The mnemonic is O2. So we have got optic foramen or we have got the optic canal which is, and the two structures passing through it is optic nerve and ophthalmic artery. We have got optic nerve and we have got the ophthalmic artery. The second is superior orbital fissure, but we will talk separately about that after completing the next foramen. So FR here stands for foramen rotundum. Foramen rotundum. Okay, so through foramen rotundum, if I am talking about foramen rotundum, the important foramens which is passing through foramen rotundum, which is again important for you to note down, is that we will have the structures passing through foramen rotundum is the maxillary nerve. So everyone should be knowing about the maxillary nerve which is passing through it. That is very, very important for you to understand. Okay, so we will have the maxillary nerve passing through it. Okay, please write on that. So the mnemonic of structures passing is me. So here M for maxillary nerve and E for emissary vein. Okay, done. Done, my dear students. Now we will have the structures passing through the other foramina. So we have written this. The third is the foramen ovale. So if I talk about foramen ovale, the structures passing through foramen ovale, how to remember is the structure passing through it is the male. So we know foramen ovale means pertaining to ova. The name is like that, pertaining to ova, female, and what comes close to ova is the male. So M-A-L-E, the structures passing through this is M stands for mandibular nerve, A for accessory middle meningeal artery, L for lesser petrosal nerve, and E for emissary vein. And if I talk about next foramen, that is foramen spinosum. My dear, through foramen spinosum, the structures passing is middle meningeal artery. A very important one is the middle meningeal artery and the nervus spinosum. Middle meningeal artery and the nervus spinosum. So what is nervus spinosum? Actually, nervus spinosum is a meningeal branch of mandibular nerve. Okay. Now, actually, we have to know about foramen lacerum. Foramen lacerum. Actually, not much important structures are passing through foramen lacerum. Actually, foramen lacerum is located, communicates, actually when you see a carotid canal, it is not very nicely visible in the cranial fossa. In the basal aspect, carotid canal is seen, and this foramen lacerum is the anterior end of this carotid canal. Actually, it is covered by a cartilage, and basically the important structures which is formed at the anterior end or traversing is the greater petrosal nerve joins with deep petrosal nerve. Here, greater petrosal nerve is a branch of facial nerve. It joins with sympathetic plexus around the internal carotid artery, forming the nerve of pterygoid canal, which is also called as Weiden nerve. So, GPN, greater petrosal nerve, it will join with DPN. DPN means deep petrosal nerve, which is sympathetic plexus around carotid artery, and these two will form nerve to pterygoid canal. And what is the name of nerve to pterygoid canal? It is also called as Weiden nerve. This is also called as Weiden nerve. So done. Now we have to know about superior orbital fissure. Okay, my dear students. So basically for superior orbital fissure, I want you to show this image, and I slightly enlarge this image. So let me just firstly see the students are understanding or not. Let me see my mobile so that we can see the conversation. Yes. So students, are you understanding, those who are live? Okay. So here in this diagram, okay, very good. You can see the anterior view of the orbit. Here you can see we can see the optic canal, and we can see the superior orbital fissure, and which is also communicating with the inferior. This superior orbital fissure is retort shaped structure, and you have to, okay dear, okay. So that is good. Very good dear. So that is good. So superior orbital fissure, inferior orbital fissures has been shown. We have to know the structures passing the superior orbital fissure. Optic canal we have already done. Now, this is a schematic diagram. This is actually a schematic diagram, systematic or schematic diagram, which is showing you the important structures passing through superior orbital fissure, SOF. So, SOF means superior orbital fissure. So, basically from the superior orbital fissure, we will have the mnemonic is LFT. From the upper part, LFT passes. LFT. Here, L stands for LN means lacrimal nerve, F for frontal nerve, T for trochlear nerve, and superior ophthalmic vein. So the middle part, we have got both the division of the third cranial nerve and also the sixth cranial nerve and nasociliary nerve, lower part inferior ophthalmic vein. Also in this diagram, you can appreciate inferior orbital fissure through which passes infraorbital nerve, zygomatic nerve, branch of maxillary, and infraorbital vessels. Okay, so my dear structures, so my dear students, so superior orbital fissure is divided into upper lateral part, middle intermediate part, and lower part or medial part. And the structures passing through upper lateral part is L-left-T. L-left-T mainly lacrimal nerve, frontal and trochlear nerve, and superior ophthalmic vein. From middle part, both divisions of third cranial nerve, one's oculomotor nerve, and in between this passes nasociliary nerve. And through this middle part also we can see the passage of sixth cranial nerve. And through lower part, inferior ophthalmic vein. Okay, so we have done here. So we have finished with superior orbital fissure. Okay, you can just memorize this and practice the structures passing. Now coming to the posterior cranial fossa. So for posterior cranial fossa foramens, we can see four important foramens you have to know. FM means foramen magnum, hypoglossal canal, jugular foramen, and we have got internal acoustic meatus. All these four foramina has been highlighted here. And you have to know the foramen's location and you have to know the structures passing through these foramens. Okay. So if I talk about internal acoustic meatus, which is located in the petrous part of temporal bone, we have got the passage of 7th, 8th cranial nerve and labyrinthine vessel. In this, the 7th cranial nerve, both motor and sensory part passes. The sensory part of 7th cranial nerve is also called as nervus intermedius because it is sandwiched between the motor branch of facial nerve and vestibulocochlear nerve, that is 8th cranial nerve. The other name of nervus intermedius sensory part of facial nerve is nerve of Brisberg. Okay, one by one will, and hypoglossal canal, very easy, hypoglossal nerve, 12th cranial nerve. And separately we will go with jugular foramen and foramen magnum. Okay, so basically this is okay. So basically we will come with these, I think hypoglossal canal and internal acoustic meatus I would like to write here itself. So for the hypoglossal canal, you can just write 12th cranial nerve is passing, hypoglossal nerve is passing, that is the 12th cranial nerve is passing. Okay, and for the internal acoustic meatus, you can highlight and write 7th, 8th cranial nerve and labyrinthine vessel. Okay, 7th and 8th cranial nerve and labyrinthine vessel. Actually, here I just want to, in the 7th cranial nerve, I just want to write both motor branch and sensory branch of 7th cranial nerve. Now, the sensory branch of 7th cranial nerve is also called as nervus intermedius, as it is sandwiched between the vestibulocochlear 8th cranial nerve and motor branch of facial nerve. It is also called as nerve of Brisberg. So we have done with these two foramens. Now I would like to show you this image. So in this image, you can see the structures passing through jugular foramen. Actually, jugular foramen, which is again you can see irregular retorsive foramen, which is divided into three parts, and the structures passing through it is already marked. Inferior petrosal sinus, the 9th, 10th and 11th cranial nerve, also the meningeal branch of ascending pharyngeal artery and the meningeal branch of occipital artery. And also, so this is the meningeal branch of, meningeal branch of occipital artery also passes. Okay, and also emissary vein with the junction of sigmoid sinus with that of internal jugular vein. So actually this image is showing you all the structures which is passing through jugular foramen. This image is showing you all the structure which is traversing through jugular foramen. Done with this, my dear students? So it is divided in three parts and the structures passing. I want everybody to practice this, the structures passing, which is already written above. Now I would like to show you foramen magnum. So the most bigger foramen, so the most big foramen of the whole of the cranial fossa is the foramen magnum. What does FM stands for? FM stands for foramen magnum. Actually, this foramen magnum is divided into two parts by the attachment of alar ligaments close to occipital condyles, which will divide foramen magnum into anterior and posterior part. Okay, it will divide it into anterior and posterior part. So I would like to show you this ligament, alar ligament, and how it is divided into anterior and posterior part. So this will be This is alar ligament. Actually, alar ligament attached to occipital condyles divided into A and P part. So A means anterior part and P means posterior part. So A is anterior part and P is posterior part. Actually, A part of, if I'm talking about A part is called as, actually A part is called as anterior part, which is called as osteoligamentous compartment. A is osteoligamentous compartment. And B is posterior, which is neurovascular compartment. So osteoligamentous compartment means no nerves and vessels are passing through this. Only the ligaments pass. Neurovascular compartment means nerves and vessels are passing through. Okay. Now coming to the structure. So this is a schematic diagram which is showing the structures passing through it. So we can see here the narrow anterior part. Okay, we can see here narrow anterior part, as you can see. We can see here narrow anterior part, and we have following structures passing through it: apical ligament of dense, superior part of cruciform ligament, and membrana pectoria. Now rest all, here you can see P, I have written that is A for the anterior part and P for the posterior part. So if you will see here, this is A and this is P. So through posterior part, that is neurovascular part, we have got nerves and vessels. So we have got the vertebral artery passing through it. We have got the anterior and posterior spinal arteries. We have got the spinal root of accessory nerve, the cerebellum, the medulla oblongata. So actually nerves and vessels and the neurovascular structures are passing through the posterior part of foramen magnum. Now, my dear students, after that, a quick recapitulation of important foramina has been shown: cribriform plate, olfactory nerves, all the cranial nerves has been demarcated. The optic canal, the second nerve, the second cranial nerve, optic nerve, superior orbital fissure, the third, fourth, sixth, and the oculomotor nerve, foramen rotundum maxillary nerve, foramen ovale, mandibular nerve, internal acoustic, 7th and 8th cranial nerve, jugular foramen, 9th, 10th, 11th, 12th, and the hypoglossal canal, the 12th cranial nerve. So you can see the recapitulation of all the cranial nerve passing through important foramen, which you have to remember also with the foramen location. So actually in FMG examination, number of times it has been asked, and it is very important that you should know this topic. Okay. So let's have some MCQs related to this. Which of the following nerve does not passes through jugular foramen? Among the option given, which of the following is not passing through jugular foramen? Which of these are not passing through jugular foramen? Glossopharyngeal, vagus, accessory, or hypoglossal? D, hypoglossal is the right answer. It passes through hypoglossal canal. Now A, B, C, D is there. I'm just enlarging this. Can you tell me in this image, can you identify which mandibular nerve is passing through which foramen? A, B, C, D. A, B, C, D. I have enlarged this. A, B, C, D. So mandibular nerve is passing through which foramen? Either A, B, or C, D. So you already know mandibular nerve is male, M-A-L-E, male, and male passes through which foramen? I'm getting right answer from Nerissa and many others. C is the right answer. That is foramen ovale. Absolutely correct, my dear students. Now coming to the next one. A man has road accident in which the metal rod is passed through superior orbital fissure, and which nerve is damaged in this case? Only the oculomotor ophthalmic branch of trigeminal maxillary of trigeminal nerve. So most correct answer, yes, foramen ovale is right. Now I am coming up with the next one. So most correct answer, dear, here, most correct answer is, so you have to know, so this is superior orbital fissure. So you have to know all the structures passing LFT, third, sixth nerve, superior ophthalmic vein, inferior ophthalmic, then maxillary division of trigeminal. No, it can't be. Maxillary division of trigeminal nerve passes through foramen rotundum. What is the right answer? Passing through superior orbital fissure. There was an image and I have shown you all the structures passing through superior orbital fissure. Yeah, ophthalmic passes, my dear. Ophthalmic passes, but one more nerve, dear. What is that? No, B is not totally right. Upper and lower division of which nerve passes through the middle part of superior orbital fissure? Please mark the right answer, dear. Yes, oculomotor and ophthalmic branch of trigeminal nerve is perfectly right answer. Absolutely correct. C is the perfectly right answer, dear. Yes, now you come. Now, middle meningeal artery in the skull passes through which foramen? Middle meningeal artery. Middle meningeal artery passes through which foramen? Middle meningeal artery enters the skull through which foramen? Foramen ovale, foramen spinosum, foramen lacerum, foramen rotundum, which is the right answer. Yeah, here comes the right answer. Yes, it is the foramen spinosum. It's the foramen spinosum. Very good. Now, this is an image-based question. So, green color foramen is marked. Let me enlarge this. Okay, so green color foramen is marked. Green color foramen is marked here, highlighted. As you can see, this is image-based question. And you have to tell me that which of the following structure is passing through a green color highlighted foramen. So firstly, identify that foramen, give me the right answer. Which structure passes, whether it is the sensory branch of mandibular nerve, lesser petrosal nerve, motor root of the trigeminal nerve, or maxillary nerve. No, which of the following structure doesn't passes? Doesn't pass. It is asking which is not passing through this foramen. So first thing is identify the green color foramen. So which foramen is it? My dear students, firstly tell me the name of this foramen. Which foramen is this? So firstly tell me the name of this foramen. Doesn't. Yes, doesn't passes. Doesn't passes. So which? Yes, maxillary nerve is right because maxillary nerve passes through foramen rotundum. This foramen is foramen ovale. And what passes through foramen ovale? Male. MALE, that is mandibular nerve, accessory middle meningeal artery, lesser petrosal nerve, and emissary vein. So maxillary nerve is the right answer, which passes through foramen rotundum. Yes. Now, see this image. So which structure is passing through the sewn foramen? So actually this is an image-based question in which you have to see the foramen and then you have to tell me the structure passing through it. So this, I just enlarge this one. I would like to enlarge this image and you can identify this. You can identify this foramen, that is this is shown you, the arrow marked black color foramen, as you can see. As you can see, black color foramen, arrow marked foramen. Okay, so which foramen is this? This is from the basal aspect. This foramen, I'm talking about this foramen. This is from the basal aspect. Okay, now now tell me which structure is passing through this foramen. So more than one is correct. Which foramens are passing through it? More than one is correct. What? Yes, E is correct, but that is one option. More than one is correct. More than one is correct. So this foramen, what is the name of this foramen? My dear students, what is the name of this foramen? This foramen is jugular foramen. This is jugular foramen from the basal aspect of the skull. Through it passes jugular. Yeah, this is the jugular foramen. And through it passes meningeal branch of occipital artery, accessory nerve, meningeal branch of ascending pharyngeal, sigmoidal sinus. So C, D, E, F, all are right. Yes, foramen jugular is right. So basically, yes, dear. So basically, we have got sigmoid sinus. Continue with internal jugular vein, meningeal branch of ascending pharyngeal, occipital, and accessory nerve. 9th, 10th, 11th nerve passes. So all this C, D, E, F passes to jugular foramen. Now, actually, I just want everybody to see this image in which you can see the inferior view of the base of skull and you can see the inferior view of the base of skull in which you can identify important bones. Like this is the palatine process of the maxilla bone and this is the palatine bone. These two will form the palate. This is the vomer bone. This is foramen ovale spinosum. This is foramen ovale spinosum. Carotid canal. So very important is the carotid canal. Why? Because carotid canal is better view in the basal or inferior view of the skull and through this passes carotid artery. Through this passes internal carotid artery. Internal carotid artery. Jugular foramen, which was asked, foramen magnum. So it's also important that you can see the inferior view and you can visualize the important foramens. Okay. Now let's come to the next important topic of the head and neck series, that is Important branches of external carotid artery. Actually, external carotid artery is a branch from common carotid artery. Generally, bifurcation of common carotid artery into external and internal carotid artery happens at the level of C4 cervical vertebra. So external carotid artery mainly give branches in the head and neck region. So it gives branches in the head and neck region. And here you can see the superficial temporal and maxillary artery. These are the two terminal branches of external carotid artery. Posterior auricular and occipital. These two are the posterior branches of external carotid artery. Facial, lingual and superior thyroid. These three are the anterior branch of external carotid artery. And ascending pharyngeal artery is the only medial branch of external carotid artery. So this is important. This has been asked so many times in the examination. So it is very important that you should be knowing all the 8 branches of external carotid artery. Actually, my dear students, there is a mnemonic for the branches of external carotid artery. So the next topic is maxillary artery. I just want everybody to know the mnemonic for the branches of external carotid artery, and that mnemonic is some anatomist like freaking out poor medical students. S for some, A for anatomist, L for like freaking, O occipital, P for posterior auricular, M for maxillary, S for superficial temporal. So actually some anatomists, so please don't apply my dear students on me. I'm not like to freaking out poor medical students. Some anatomists like freaking out poor medical students. These are the branches of external carotid artery. According to the recent Gray's Anatomy, 42 edition Gray's Anatomy, ascending pharyngeal artery is the first branch. It is the first branch of EC. Actually, to the previous editions, superior thyroid artery was the first branch of external carotid artery, but now it has been changed. Ascending pharyngeal medial branch is the first branch of external carotid artery. So please have a look on all the branches of external carotid artery. Now next is maxillary artery. So actually maxillary artery, which itself is a branch of external carotid artery, which is a terminal branch of external carotid artery. And in this image, you can see all the branches of maxillary artery. Actually, lateral pterygoid muscle divide the maxillary artery into 3 parts. So the first part, branches of the first part. So if I talk about first part branches, there are 5 branches from the first part of maxillary artery, which is called as. So actually, I will write it systematically so that you can understand the branches. I will give you a mnemonic also. 5 branches here. I want to highlight this. These are 5 branches from the first part, that is middle meningeal, accessory middle meningeal, deep auricular, anterior tympanic and inferior alveolar. There are muscular branches from the second part like mesenteric branches, buccal branches, pterygoid branches and temporal branches. There are third part, there are 6 branches, that is sphenopalatine, artery to pterygoid canal, infraorbitals. We have got posterior superior alveolar and great palatine artery. Actually, there are so many branches from the maxillary artery. So please don't get confused, my dear students. I am giving you a good mnemonic for the branches of maxillary artery. So let's start. Okay. So here you just write the heading. Just write on the heading branches of maxillary artery. Branches of maxillary artery. So first, from first part. So from first part, if I talk about the first part of the branches, so there are 2 mnemonics for you. One is damia and the other is mada. So whichever you like. Okay, whichever you like. There are 2 mnemonics for the branches of maxillary artery. Either you can go for damia or you can go for mada. I am going for damia. So D for deep auricular artery, A for anterior tympanic artery, M for middle meningeal artery, I for inferior alveolar artery, and A for accessory middle meningeal artery. Accessory middle meningeal artery. Accessory middle meningeal artery. So how many branches from the first part? 5 branches. And these are the mnemonic. Now coming to the branches from the second part and the third part. So continuing with this, branches from the second part. So branches from the second part can be memorized as all the muscular branch or make dinner before party. Mnemonic is make dinner before party. Make dinner before party. M, D, B. Yeah. So the branches are masseteric branch to masseter muscle, deep temporal branches, anterior and posterior deep temporal branches for temporalis muscle, B for buccal branches going in the buccinator muscles, and pterygoid branches to the pterygoid muscles. Now coming to the third part. Branches from the third part. Branches from the third part of maxillary artery. The mnemonic is PICPAS. PICPAS. Some students also remember like Peppa Pigs. PICPAS. Six branches. What are they? P for pharyngeal artery, I for infraorbital artery, G for greater palatine artery, which is arising from descending palatine artery. Another P for posterior superior alveolar artery, posterior superior alveolar artery. And A for artery to pterygoid canal. Artery to pterygoid canal. And what this S stands for? Sphenopalatine artery. Sphenopalatine artery. So by dear, these are 6 branches. These are 6 branches from the third part of maxillary artery. These are 6 branches from the third part of maxillary artery. Okay, my dear students? These are 6 branches from the third part of maxillary artery. So done with this. Now we have finished with the head and neck part. Let's solve the MCQs. Okay. So let's start. Which artery can be palpated anterior to the masseter? I just want you to show this one. Then we will come to this. Actually, this is about the facial artery. So basically, it's A. Yes, you are right. It's the facial artery which can be palpated on the anterior border of masseter muscle. And you can see there, we know that facial artery itself is a branch of external carotid artery, and it is sheltered by the ramus of mandible. Okay. Course is, it passes beneath the digastric stylohyoid muscle, and it passes on the posterior surface of submandibular gland. It gives branches in the face and it gives branches in the neck region. So actually, it is actually having a terminal branch, also angular artery. So basically, it is giving branches on the face. It gives branch to in the neck region. It gives in the cervical branch. It gives branch to tonsil, and it gives glandular branches. And other than that, it also gives branches. So facial is is actually a tortuous artery which is actually to accommodate itself in the movement of different part of facial movements. And the important branches, 4 important branches of facial artery on the face, above or to the upper and lower part of the lips, that is superior, inferior labile artery, lateral nasal, and angular artery. So these are 4 branches. These are 4 branches which are the branch from facial artery. Now let's come to the MCQs. Is it okay? Let's come to the MCQs. Okay. Not a branch of third part of axillary artery, which is not a branch of third part of axillary artery. Absolutely correct. Supraorbital is a branch of ophthalmic artery. Now, termination of external carotid artery is via which artery? So, external carotid artery terminates by becoming which artery? Absolutely right. It's superficial temporal. Very good. Now, which of the following is not a branch of external carotid artery? Which of the following is not a branch of external carotid artery? D, yes, D is right. Ophthalmic. It is a branch of internal carotid artery. It is not a branch of external, but it's a branch of internal carotid artery. Yes. Now, which of the following artery passes between the roots of auriculotemporal nerve? Actually, please try to mark it right. Otherwise, I will show you an image in which you can see there is one artery which is passing in between the roots of auriculotemporal nerve. The one artery which is traversing between the roots of auriculotemporal nerve. Please mark the right answer, dear. Yes, middle meningeal artery is absolutely right. Yes, middle meningeal artery is absolutely right. Now, in this diagram, you can see this is the middle meningeal artery. This is the middle meningeal artery, and you can see here that this middle meningeal artery is lying inside the loop of, it is lying inside the loop of this nerve, that is auriculotemporal nerve. This is lying inside the loop of nerve, that is auriculotemporal nerve. Okay. Now, the branches of, so actually here I want you to show the branch of arch of aorta, which is showing left subclavian artery, the left common carotid artery, and brachiocephalic trunk. In this diagram, you can see branches of the subclavian artery first part, that is VIT. So actually branches, if I talk, I will write that branches of subclavian artery can be memorized by the mnemonic vitamin with VITCD. What is that? Vitamin C and D. So VIT stands for vertebral artery, I for internal thoracic, and T for 𝗘𝗱𝗶𝗁 trunk. So you can write on branches of subclavian artery. Branches of subclavian. Actually, this subclavian artery again is divided into, if I talk about subclavian artery, it is divided into 3 parts by scalenus anterior muscle. So from the first part, the mnemonic of branches are VITCD. Okay. So from first part, the branches are VIT. From the second part, the branches is C, and from the third part, the branches is D. So VIT, V for vertebral artery, my dear students, I for internal thoracic artery, and T for thyrocervical trunk, thyrocervical trunk. And if I talk about the second part branches is costocervical trunk. If I talk about the branches from the third part, it is the dorsal scapular artery. Okay? Done? Now coming to the lower limb. Important topics of lower limb. Done? Okay, now coming to the lower limb. So in the lower limb, the topic which I want everybody to know here is the femoral triangle. So if I talk about most important topics for the lower limb, we will go with femoral triangle, adductor regions, and the nerves. Okay. Then we will see the important topic of thorax, that is the diaphragm. We will study diaphragm and mediastinum, most important, which is asked in the FMGE exam. Okay, then we are just left with the neuro and embryology. So don't worry, till 9 or 9:30 I will end the session today. Till 9:30 I think I will take the session because let's start with the femoral triangle. So what are the boundaries? The boundaries are inguinal ligament is forming the base of the femoral triangle. Adductor longus muscle is forming the medial boundary. And sartorius is forming the lateral boundary. And this is the meeting of sartorius with the adductor longus muscle is forming the apex of femoral triangle. It is forming the apex of femoral triangle. Now, If we talk about the muscles of femoral triangle, so basically this is showing the floor muscle. So the mnemonic of floor muscles of femoral triangle is AP. So here A for adductor longus muscle, P for pectineus, another P for psoas major tendon, and I for iliacus. So the floor muscle of femoral triangle can be memorized by the mnemonic AP, APPI. Is it okay? Okay. Now, if I talk about femoral triangle, it is located in the anterior part of the upper aspect of the thigh, and actually this triangular area is containing femoral vessels and nerve. So most important content is always the femoral nerve, femoral artery, and femoral vein. But medial most part, if you go, we will also have the femoral canal containing the femoral, we will have the deep inguinal lymph node. So basically, if we talk about femoral triangle roof, so we will have content in the roof and we will have the content inside. So it is important that separately you should know the content because it will help you to understand. So let's talk about that. So femoral triangle content. So basically, I will also, so before writing the content, actually, I just want everybody to first write the content in the roof. So basically, when I am talking about roof, it will have skin and superficial fascia. So in the roof, we will have great saphenous vein. In the roof, we will have superficial inguinal lymph node. And we will have superficial branches of femoral artery. That is 3 superficial branches. And we will have ilioinguinal nerve, and femoral branch of genitofemoral nerve. Okay, so this all comes in the roof, and also few of this will be coming from inside content. Now, if we talk about branches, so we'll write in this, I will write the contents separately because I will write all the important contents of femoral triangle, which is lying inside. Now here I want you to show this image in which important branches of femoral artery you can see. When I am talking about, as we know, if I am talking about femoral artery, it is the continuation of external iliac artery, which is a branch of common iliac artery. And this external iliac artery below, so can you see the green color structure? That green color line is inguinal ligament, and below inguinal ligament, it forms femoral artery. The important branches, so it gives 3 superficial branches, that is superficial, external pudendal, superficial epigastric, and superficial circumflex iliac. It gives 3 deep branches, that is deep external pudendal, muscular branches, and profunda femoris artery. So these are the 6 branches which is given in the femoral triangle. Other branches like muscular and muscular and descending genicular artery, these are also the branches of femoral artery. Also, profunda femoris artery gives medial lateral circumflex femoral artery. So this is lateral circumflex and this is medial circumflex artery, which will again give transverse ascending and descending branches. So see here, in this diagram, we can see external iliac artery changing its name to femoral artery below inguinal ligament, and this profunda femoris artery is giving medial and lateral circumflex femoral artery, which is again giving 3 branches, ascending, descending, and transverse branches. Okay, my dear students. Now, let's write the content of femoral triangle. Actually, for the content of femoral triangle, there is a mnemonic that is called as navel. This is from lateral to medial. This is the content from lateral to medial. So here N-A-V-E-L. N-A-V-L. So here N stands for femoral nerve. I will also like to write the contents other nerves. Other nerves are lateral cutaneous nerve of thigh. Actually, this lateral cutaneous nerve of thigh is a very important nerve, and actually it can be compressed and it can cause pain on the outer aspect of thigh, which is called as myalgia paresthetica. It also gives branch to pectineus muscle. branch to pectineus muscle. So here in this femoral triangle itself, it gives branch to pectineus muscle via femoral nerve. Arteries, we have got 3 superficial branches. And we have got, so we will have femoral artery, and in the femoral artery, we will have 3 superficial and we will have 3 deep branches. So what is the name of superficial branches? Superficial circumflex iliac artery, superficial external pudendal, superficial epigastric artery, and deep branches. So we have got say 3 deep branches, that is deep external pudendal, profunda femoris artery, and muscular branches. We will have femoral vein as the content. E here stands for empty space. And then medial most content is the lymphatics. The medial most content is the lymphatics, that is deep inguinal lymph node. My dear students, deep inguinal lymph node is also called as lymph node of Cloquet or Rosenmuller. So it is also called as lymph node of Cloquet or Rosenmuller. So done with the content of femoral triangle? Now, please identify the structures of the femoral triangle. This is a cadaveric image for you to understand femoral triangle. Okay, so what is this muscle, my dear students? This is adductor longus muscle. This is pectineus muscle. And this is I for iliacus. Actually, the psoas major tendon is hidden by this nerves and vessels. So here, these are nerves. This is the artery, the femoral artery, and this is the vein, femoral vein. This is femoral nerve, femoral artery, and femoral vein. The medial most content of femoral artery will be the deep inguinal lymph node. What will it? Deep inguinal lymph node. Okay. Now, here is actually, I just want you to show this image. Why? Because here you can see the femoral sheath. Now, if I talk about femoral sheath, it is a modification of deep fascia. So here in this diagram, I just want to highlight this green color structure, that is the sheath. So basically this sheath, if you will see this is the femoral sheath. And this femoral sheath is covering which structure? In this diagram itself, you can appreciate it is covering femoral artery and femoral vein. What you can appreciate in this diagram, that femoral nerve is lying outside the femoral sheath. Femoral sheath is not covering femoral nerve. It is just covering the upper proximal part of femoral artery and femoral vein. Done? Now, for your examination, it's very important for you to understand that what does these sheath contains. Actually, for examination, it is very, very important that you should be quite aware of femoral sheath, how it is divided into 3 compartments and what all structures are there in the sheath. So, femoral sheath is divided into 3 compartments. So my dear students, please don't get afraid that I will not give you a break. So just femoral triangle and adductor region. This will take another 15 minutes, 15 minutes or some, and then I will give you a break. And then we are just left with a few important topics. So that is very, very important. So then I will take another 2-hour session to complete the anatomy part. Okay, the most important. So this is the femoral sheath. Okay, this is femoral sheath. And this is the compartment. So here, actually, this is the medial compartment of femoral sheath. This is the middle or this is the middle part or middle compartment, and this is the lateral part or lateral compartment. Now, here, this is the middle compartment, medial most compartment. So what is this? This contains deep inguinal lymph node. So basically, deep inguinal lymph node. So basically, the medial most compartment of femoral sheath is called as it contains deep inguinal lymph node, which is also called as lymph node of Cloquet or Rosenmuller. The intermediate compartment contains femoral vein. What is this? This is FV, femoral vein, and this is femoral artery. And the lateral most compartment contains, yes, very good. The lateral most compartment contains two structures, and the lateral most compartment contains femoral artery and femoral branch of genitofemoral nerve. Actually, this femoral branch of genitofemoral nerve is giving sensation over the skin of femoral triangle, and also in the content I have shown you lateral cutaneous nerve of thigh, which is commonly involved in the laparoscopic surgery of inguinal hernias, and it is compressed, causing the case of meralgia paresthetica, in which the patient will have pain on the outer lateral aspect of thigh. Now, femoral canal. What is femoral canal? It is the medial most compartment. It is the medial most compartment of femoral sheath. And what it contains? It contains the deep inguinal lymph node. Now, femoral canal, upper margin is called as femoral ring. And if there is weakness of femoral canal or ring, so if there is weakness of femoral canal or ring, it can lead to femoral hernia. Actually, femoral hernia is more common in females because of wider pelvis and low caliber of femoral vessels. Actually, this upper part of femoral, so basically if I am talking about, see here, so basically if I am talking about medial most compartment, so I just want to highlight. So this is the medial most compartment. This is the medial most compartment of femoral sheath. This medial most compartment of femoral sheath is femoral canal, and upper margin is femoral ring, which is bounded anteriorly with the inguinal ligament. Medially is the pecten pubis, and lateral to it is femoral vein, as you can see in this diagram. So basically, if you want to go for the treatment of femoral hernia or strangulated femoral hernia, you will like to cut medially, that is lacunar ligament. So medially the femoral ring has got lacunar ligament which will cut. Why not laterally it will cut? Because there lies femoral vein. But I just want you, so this you can see the femoral hernia through femoral ring, and basically I just want you to show this diagram. Actually in this diagram you can see sometimes there is location of abnormal obturator artery. So abnormal obturator artery is actually a branch of inferior epigastric artery. So as you can, it is a branch from inferior epigastric artery, which is shown to you, inferior epigastric artery. And it is located, as you can see, this triangular area is lacunar ligament. So this triangular area is lacunar ligament. So basically, as I told you, that femoral ring medially is having lacunar ligament and laterally is having femoral vein. So if you want to cut and enlarge the femoral ring or canal for pushing for the repair of hernial sac, so you will cut obviously medially, but please don't go cutting blindly. Why? Because at times there can be a location of abnormal obturator artery which is lying close to lacunar ligament, and there will be enormous bleeding. Normal obturator artery is a branch of internal iliac artery. Got it? The next topic is adductor canal. Or do you want me to complete lower limb? Just after adductor canal, few nerves are there and we are finished with lower limb also. Okay, I think after adductor canal. So adductor canal is a very small, easy topic. What is it? Adductor canal is a continuation of, actually femoral triangle contents, femoral vessel will pass through big opening, fifth osteoaponeurotic opening of adductor magnus muscle. Okay, adductor magnus muscle, and then this forms a root of femoral vessel reaching to the popliteal area. So here this is a diagram in which you can appreciate the boundaries and content of adductor canal. Okay. This is a diagram which is showing you the boundaries and content of adductor canal. Okay, so here what you can see, posteriorly, if you will see the posterior boundary of adductor canal, if I am talking about posterior boundary of adductor canal, it is by adductor longus and adductor magnus muscle. Both transverse section and superior and anterior view is there. Anterolaterally, it is bounded by vastus medialis muscle, and on the medial side or roof is formed by sartorius muscle. Okay, now beneath the sartorius muscle, you can see we have got nerve plexus. So this is the called as subsartorial nerve plexus, and it contains femoral vessels and nerves like nerve to vastus medialis and saphenous nerve as the content. Okay, now subsartorial nerve plexus is lying on the roof underneath which muscle? Underneath sartorius muscle. The plexus are formed by, if I talk about subsartorial nerve plexus, it is formed by three important nerves: saphenous nerve, anterior division of obturator nerve, and medial cutaneous nerve of thigh. Medial cutaneous nerve of thigh. So these three nerves which is residing beneath sartorius muscle is forming subsartorial nerve plexus. Okay. Now, this is an image where you can see the important adductor canal region which is containing femoral vessels and that of saphenous nerve. And as in this diagram, you can see vastus medialis is forming anterolateral and roof is formed by which muscle? Sartorius muscle. Okay, this is showing you the adductor canal region. Now, you can just write on the content. So, if I talk about the content of adductor canal, the important content of adductor canal is it contains femoral artery, femoral vein, it contains saphenous nerve, it contains the nerve to vastus medialis, it also contains both anterior and posterior division of obturator nerve. It also contains descending genicular artery. Okay, so these are important contents of adductor canal. Now coming to the nerves. So as I told you in the lower limb, nerves are important. So basically, but the nerves of lower limb is very easy. Okay, I just want you to explain. If I am talking about nerves of lower limb, it is very easy. So the nerve of anterior part of thigh, when I am talking about nerves of anterior part of thigh, it is the femoral nerve. Okay, nerve of anterior compartment of thigh is femoral nerve. Nerve of medial compartment of thigh is obturator nerve. Nerve of posterior compartment of thigh, which is also called as hamstring part of the thigh, is the sciatic nerve. Now, firstly, in this diagram, we are seeing the femoral nerve. Now, in this, if I am talking about the femoral nerve is formed by, if I am talking about femoral nerve is formed by posterior dorsal division of ventral rami of L2, L3 and L4. Okay. L2, L3 and L4. Now, in this diagram, we can see that from the trunk, femoral nerve is giving innervation to which two muscles? So, in this diagram, we can see from the, just a minute, it is giving innervation to, this is posterior division and this is anterior division. Okay, now see here. So femoral nerve, which is a nerve of anterior compartment of thigh, from the trunk, it gives innervation to pectineus muscle and iliacus muscle. And from anterior division of femoral nerve, it gives innervation to just one muscle, that is S. What does S stands for? S is sartorius muscle. So S is sartorius muscle. So only one motor branch, that is sartorius muscle, and it gives two cutaneous nerve. Intermediate cutaneous nerve of thigh, medial anterior cutaneous nerve of thigh. From the posterior division, it gives innervation to rectus femoris muscle, vastus lateralis, vastus intermedius, and vastus medialis, and innervation to knee joint. So basically hip and knee joint both receives innervation from the femoral nerve. And it also gives one cutaneous nerve from the posterior division of femoral nerve. What is that nerve called as? It is a very important nerve, and this nerve is called as saphenous nerve, which will give innervation to medial side of leg till the level of great toe. That is the medial aspect of the foot, great toe. So that means femoral nerve is the nerve which is giving innervation to all the muscles of anterior compartment of thigh. It gives innervation from the trunk to two muscles, that is iliacus and pectineus muscle. From anterior division, it gives innervation to just one muscle, that is the sartorius muscle, two cutaneous nerve. And from the posterior division, it gives one cutaneous nerve, saphenous nerve, which is going towards the medial side of leg till the level of great toe, and it gives innervation to quadriceps femoris muscle, which is made of four muscles: vastus medialis, vastus lateralis, vastus intermedius, and rectus femoris. This image is showing you cutaneous distribution of femoral nerve. Okay, now femoral nerve is the nerve of anterior compartment of thigh. Is the nerve of anterior compartment of thigh. That means all the major muscles of anterior compartment of thigh are causing knee extension and hip flexion. So major muscle. So if I talk about quadriceps femoris muscle, they are causing knee extension of knee and flexion of hip. And if I talk about sartorius muscle, this is causing both flexion of hip, knee, and they are lateral rotators of thigh or hip. So actually sartorius muscle is the talus muscle. That is the palti position. That is the action of sartorius muscle. Now coming to the next one, the nerve of medial compartment, that is the obturator nerve. So basically this is the nerve of medial compartment formed by L2, L3 and L4. So basically obturator nerve is root value. If I talk about root value, this is formed by anterior division ventral rami of L2, L3 and L4. It is the nerve of medial compartment of thigh, giving innervation to hip joint, adductor longus, adductor brevis, pectineus, gracilis, OE for obturator externus muscle. It also gives innervation to hip joint and knee joint. And it gives cutaneous distribution in the small medial most part of the thigh, which is shown by yellow color in this image, Okay. Obturator nerve is the nerve of medial compartment of thigh. It's the nerve of medial compartment of thigh. Okay. Now, it is if I talk about obturator nerve, basically all the muscle, adductor longus, adductor brevis, adductor magnus, adductor part, obturator externus, pectineus, gracilis. If I talk about entire of this muscle, one common action is that these all muscles are adductors of hip. Okay, now coming to sciatic nerve. If I talk about sciatic nerve, it is the thickest nerve of the body, 2 centimeter thick nerve. It is the nerve of posterior compartment of thigh. That means it is giving innervation to hamstring group of muscle. So sciatic nerve is having two components. So sciatic nerve is having a tibial component. So sciatic nerve tibial component is the nerve for its tibial part. Is the nerve of hamstring group of muscles innervation. It gives innervation to semimembranosus, semitendinosus, long head of biceps femoris and hamstring part of AM means adductor magnus muscle. So only the odd man out is short head of biceps femoris. It is actually innervated by common peroneal nerve component or part of sciatic nerve. Okay, now the sciatic nerve. If I talk about sciatic nerve, it divides into two nerves. One is the tibial and other is common peroneal nerve. The tibial nerve will straight down go into the posterior part of the leg and posterior leg. So basically tibial nerve is the larger terminal branch of sciatic nerve. And if I talk about common peroneal, it is the smaller terminal branch of sciatic nerve. Okay, so this larger terminal branch is going straight down in the leg and will go, and via its medial and lateral plantar nerve, it will supply the sole muscle also. And the common peroneal nerve will wind around neck of fibula and again divides into superficial and deep peroneal nerve. So basically, if I talk about the larger terminal branch, that is tibial nerve. So tibial nerve is formed by the root division, that is ventral division or anterior division of ventral rami of L4, L5, S1, S2 and S3. And it is giving innervation to all posterior leg muscles. So basically all the posterior leg muscles, if I talk about all the posterior leg muscles, they are plantar flexures of foot. Only tibialis posterior is the muscle which is also causing inversion of. Now, if I talk about common peroneal nerve, which is winding around neck of fibula, it will give deep peroneal nerve as the nerve of anterior leg. It will give superficial peroneal nerve as the nerve of lateral leg compartment. So superficial peroneal nerve give innervation to peroneus longus and peroneus brevis, because these are the two muscles of lateral compartment of the leg. And deep peroneal nerve will give innervation to extensor hallucis longus, tibialis anterior, extensor digitorum longus, and that of peroneus tertius. PT for peroneus tertius. PT for peroneus tertius. Okay. Now, common peroneal nerve, and it's a few of this, we know that this is showing you the cutaneous innervation. Laterally, we have sural nerve is formed by the branch from both tibial and common peroneal nerve. Sural nerve is giving innervation to lateral part of the leg and lateral side of the foot. Superficial peroneal nerve is showing you the distribution of dorsum of the leg and the foot. Sural nerve is going laterally in the foot, and DPN is deep peroneal nerve. Actually, first interdigital cleft. First interdigital cleft. That means the area between great toe and adjacent toe, sensory innervation. This triangular area is getting sensory innervation from deep peroneal nerve. This is again showing you deep peroneal nerve and saphenous nerve, which is going medially towards the great toe. And this is showing you that LPN, MPN and calcaneal branches. These are the branches of tibial nerve which will give innervation into the sole of foot. And we have got SU as the sural nerve, which is giving innervation to the lateral part of the foot, and SA as the saphenous nerve, which is giving innervation to the lateral part. SA is giving innervation to medial part till the level of great toe. SU for sural nerve, SPN for superficial peroneal nerve, DPN for deep peroneal nerve, MPN for medial, and LPN for lateral plantar nerve, and calcaneal branches of the tibia, which is going into the sole. So this image is showing you that these are cutaneous distribution on dorsum of the foot and the sole of. Now the last topic of lower limb is popliteal fossa, a very easy topic. You can see popliteal fossa is a diamond-shaped depressed area in the posterior part of knee joint. This is the popliteal fossa, as you can see. And what is its boundary? So suprolaterally, it is bounded by which muscle? Suprolaterally, it is bounded by bíceps femoris. Supromedially, it is bounded by semitendinosus and semimembranosus muscle. This tendon-like structure which you are seeing here is the semitendinosus. And infromedially, it is bounded by medial head of gastrocnemius, and infrolaterally, it is bounded by lateral head of gastrocnemius muscle. Okay, so this is the boundary of popliteal fossa, as you can see. And what is important for you is to know the important content inside the popliteal fossa. Inside popliteal fossa, the sciatic nerve. At the apex of the popliteal fossa, the sciatic nerve divides into tibial and common peroneal nerve. So both tibial and common peroneal nerve is the content. Also, we have got the content as the popliteal artery and the popliteal vein, and also we will have the popliteal fat, we will have the popliteal lymph nodes as the content, and we will have the 5 genicular branches. We will have 5 genicular branches as the content of popliteal fossa. Okay. So here also you can see all the structures as the content. So in the lower limb itself, I just want you to know about lumbar plexus. We know that lumbar plexus is formed mainly from the ventral rami of the first lumbar, second, third and fourth lumbar. Here T12 thoracic vertebra, thoracic nerve is not contributing in the formation of lumbar plexus, but can communicate will form communication, but it is not taking part in the formation. Lumbar plexus L1, L2, L3 and L4 is the root value for the lumbar plexus. Important branches of lumbar plexus is iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, lateral femoral cutaneous nerve, directly branches given to iliacus and psoas major muscle, obturator nerve and accessory obturator nerve and femoral nerve. And from the fifth lumbar nerve, it communicate and form lumbosacral tract. Okay, my dear students, so these are the branches of lumbar plexus. Now, one more question which has been asked number of times in the examination is, if I talk about this, is the structures which is passing through greater sciatic and the lesser sciatic foramen. This is very, very important for you to know. So the structure exiting through greater sciatic foramen, actually this is P. This is the piriformis muscle, which is P. This is the key muscle of gluteal region. And exactly from the greater sciatic foramen, we have got following structures passing. Piriformis muscle, superior inferior gluteal nerve, sciatic nerve, nerve to quadratus femoris, and that of posterior cutaneous nerve of thigh. So many times this MCQ has been come. Also, the structure which is just exiting through a lesser sciatic foramen is the tendon of obturator internus. What does OI stands for? Obturator internus muscle. If I talk about the structure which is exiting through greater sciatic foramen and then entering into the lesser sciatic foramen, is the pin structure. And what is the full form of PIN? Here P stands for pudendal nerve, I for internal pudendal vessels, and N for nerve to obturator internus. Now, my dear students, just have a look on the superior aspect of tibia. So on the superior aspect of tibia, as you see from anterior to that of posterior part, we have got following 6 structures. Most anteriorly, we have got anterior end of medial meniscus. Then we have got anterior cruciate ligament. ACL is anterior cruciate ligament. Then we have got anterior end of lateral meniscus. Then we have got posterior end of lateral meniscus and posterior end of medial meniscus. And most posteriorly, we have got PCL, that is posterior cruciate ligament. So in this image, we can see the superior part of intercondylar area of tibia, the anterior and posterior part of intercondylar area, and we can see the structures passing from anterior to posterior. So the mnemonic is Medical College Lucknow, Lucknow Medical College. So this is how you can memorize the structures passing or located in the anterior and posterior intercondylar area. I also want you to solve few MCQs with me, which will help you to target your FMGE examination. So we have ended with the lower limb, few MCQs which can help you to proceed. So please mark the correct answer. If you are not knowing, I will help you to understand. Superior gluteal nerve, which is a nerve which is injured in Trendelenburg sign, is giving innervation to all the muscles except anyone knows, otherwise I will tell. Actually, there is superior gluteal nerve which will give innervation to gluteus medius minimus and tensor fascia lata, not gluteus. Yes, very correct, because gluteus maximus is innervated by inferior gluteal nerve. Very good. Now, if I talk about sartorius muscle, the action of sartorius muscle is all except, which is not the action of sartorius muscle. Absolutely correct. Extension of leg is not the action of sartorius muscle. Absolutely correct. Now, which is the medial most content of femoral triangle? Navel. The hint. Which is the medial most content of femoral triangle? Here comes the right answer. Lymphatics, deep inguinal lymph node, the lymph node of Cloquet or Rasenmuller. Absolutely correct. This is the medial most content. Yes, this is the medial most content. All are contents of femoral triangle except All are the contents of femoral triangle except. All are the contents of femoral triangle except. Actually, C is absolutely right. Superficial inguinal lymph node is the content of roof, not the content inside. No, D, nerve to pectineus is a branch of femoral nerve. It is also the content. Okay. It's the nerve to pectineus is a branch. So it is also the content. Now, all of the following pairing of adductor canal is correct except. All of the following pairing for the adductor canal is correct except. Roof by sartorius muscle. Content femoral nerve, floor. Adductor longus magnus anterolateral is vastus medialis. B is absolutely femoral nerve is not the content of adductor canal, only femoral vessels. Absolutely right. Okay. Now, while playing football, a blow on the lateral aspect of knee is done. So, medial meniscus is damaged. This is also orthopedic question. So, medial meniscus is damaged and along with it, one more structure is damaged. Can you guess which structure is that? So, actually, 3 ligaments are most commonly injured in knee joint. That will give you the hint. So, I will give you the hint. Terrible triad of the knee joint. ACL is absolute. Yes, ACL, medial meniscus and medial collateral ligament. This is called as terrible knee triad, which is O'Donoghue triad, which is commonly injured. Yes, absolutely correct. Now, pex uncerine is actually common insertion of 3 muscle is occurring in the proximal tibial part. Can you tell me which is not the part of pex uncerine? Which is not the part of, yes, unhappy triad is also right. Yes, semimembranosus, semitendinosus, gracilis and sartorius. These are inserted in the proximal upper medial part of tibia. Clergyman knee is inflammation of which bursa? Clergyman knee is the inflammation of which bursa? Infrapatellar, suprapatellar, prepatellar, uncerine. Can you tell me the answer? Clergyman knee is the inflammation of, don't worry, I will tell you. Clergyman knee is the inflammation of subcutaneous infrapatellar bursa. Yes, D is the right answer. Subcutaneous infrapatellar bursa. Absolutely right. Now, oblique popliteal ligament is pierced by which structure? Yes, middle genicular. Oblique popliteal ligament is formed by expansion of, it is formed by expansion of semimembranosus muscle. Semimembranosus muscle, and it is pierced by middle genicular nerves and vessels. Middle genicular nerves and vessels. Okay. Now, anterior cruciate ligament prevents which action? Anterior cruciate ligament of knee. Actually, anterior cruciate ligament does 2 actions, but you have to choose one. Anterior cruciate ligament prevents anterior dislocation of tibia and posterior dislocation of femur. So, if we have to go with one correct answer, it is anterior dislocation of tibia. O'Donoghue triad is consist of. O'Donoghue triad is consist of. Terrible triad or O'Donoghue triad is comprised of. It is consist of injury of which 3 ligaments? Which 3? A, yes, anterior cruciate ligament, medial meniscus and medial collateral ligament. Absolutely correct. Hip flexion is done by all of the following except hip flexion is done by all the following. Which one muscle is not causing hip flexion? Just the opposite of it. It's a hamstring muscle. Yeah, semitendinosus. This is causing hip extension. It is causing hip extension, not hip flexion. So done with this. Now we have to start with thorax. So yes, now thorax, 1 or 2 topics. Now we have got, I will take another 2 hours, 2 hours or 2 hour 15, 20 minutes and we will finish today. So if I talk about the most important topic for the thorax part, and if I just target about the FMG exam, so it is the diaphragm which is asked and the mediastinum which is asked. So I would like to explain that. So in the diaphragm part, it is very important. So in the diaphragm part, it is very important that you should be knowing about the origin of the diaphragm and the insertion of the diaphragm. So if I just tell you about the origin of the diaphragm, it is having the 3 source of origin. So the 3 source of origin is from the ribs, costal cartilages of the ribs, the lower 5 and 6 ribs, the sternal origin from the xiphoid process of the sternum and the lumbar origin. So that is very, very important for you to understand. So see this is the, and you can also appreciate in this diagram that there is central tendon of diaphragm. So yes, if I talk about the central tendon of the diaphragm part, the central tendon of diaphragm part, this is the insertion part of the diaphragm, which is actually trifoliate in the shape, and it merges with the fibrous pericardium of the heart. So it merges with the fibrous pericardium of the heart, that is the insertion part. And if I talk about the origin part, the origin is from the sternum, sternal origin. When I am using the word sternal origin, that is from the posterior aspect of the xiphoid process of the sternum, and from the lower 5 ribs costal cartilages, and from the lumbar origin, it is from the lumbar vertebrae. Okay. And I would like to show you this diagram. So basically, in this diagram, again, what you can appreciate that if I talk about the vertebral origin, it is in the form of right and left crux. So this is the right crux and this is the left crux. See here. So when I'm talking about right and left crux, the right crux is originating, as you can see, from the lumbar vertebra, that is L1, L2 and L3, that is first, second and third lumbar vertebra. When I'm talking of the left crux, it is from L1 and L2 lumbar vertebrae. And the superior aspect of right and left crux is joined by. So when I'm talking about superior aspect of right and left crux, it is joined by median arcuate ligament. So it is also giving origin to the diaphragm vertebral part. And then we will have the medial and then we have the lateral arcuate ligaments. So all these structures, the right and the left crux, the medial and lateral arcuate ligament, are giving origin to the vertebral origin of the lumbar origin of the diaphragm. So we have seen the sternal origin. The lower 5 and 6 ribs costal cartilage is giving origin, and the xiphoid process of the sternum. So this is the xiphoid process of the sternum, the lower 5 and 6 ribs, lower one. So basically, it is originating from the whole circumference, and then inserting into the fibrous pericardium. So you can see this part is the fibrous pericardium of the. This is the trifoliate structure, which is the central tendon of diaphragm, which is the insertion part, and this will merge with the fibrous pericardium of the heart. So in this, we can see the opening. So we can see the vena cava openings, as you can see in this diagram. So there is vena cava opening. So this is at the level of T8. The vena cava opening is at the level of, it is at the level of central tendon T8, and we will have the esophageal opening at the level of T10, and the aortic opening at the level of T12. So T8, T10 and T12 is the level, vertebral level of this opening. And the vena cava passes through vena cava opening, and the esophagus passes through the esophageal hiatus, and the aortic opening, the aorta thoracic duct passes. So basically, it's important for you to know the structures traversing and major opening. So basically, I want everybody, so this is just showing you the 3 openings which I have already told you, but I want everybody to note the major openings of the diaphragm and the structure passing through this opening. So that is highly important for you. So please note down, this is highly important. The first is vena cava opening. You have seen the vena cava opening is in the central tendon of diaphragm, and through it passes inferior vena cava and right phrenic nerve. Now, if I talk about the esophageal opening or hiatus, so esophageal or opening, the structures passing is the esophagus, the anterior and posterior vagal trunk. And other than that, we will also have the esophageal branch of left gastric artery, esophageal branch of left gastric artery and the corresponding vein. So these are the structures which is passing through esophageal opening, and the third is aortic opening. The aortic opening, through this passes the abdominal aorta, means the descending thoracic aorta, and then forms the aorta. Then we have got the thoracic duct. The structure passing is the thoracic duct, and we have got azygous veins. Azygous veins. Now, okay, so basically, these are the major openings, and sometimes I just want, so before proceeding to the next topic, that is mediastinum, I just want you to tell one important point, that if I talk about the major openings of the diaphragm, I just want you to know that there is anteriorly and gap between the seventh costal cartilage and that of the xiphoid process. That gap is called as the space of Morgagni or Larrey, and actually through this there is the anteromedial diaphragmatic hernia occurring, that is also called retrosternal hernia, and the other is posterolaterally, which is on the left side, that is Blogdolic hernia, which is more common, and that is through the pleuroperitoneal membrane weakness. Okay, so now the next topic is mediastinum. So if I talk about the mediastinum, it is again a very important topic. And the content of mediastinum, it's a very easy topic, but so many structures are traversing through mediastinum, and you have to know all these structures which is passing through the mediastinum, which is highly important. So for understanding mediastinum, we can divide the entire mediastinum into following part. So basically an imaginary line. So we will have an imaginary line. This imaginary line is passing through posteriorly in between T4 and T5 thoracic vertebra, and anteriorly it passes through angle of Lewis. That is sternal angle. So the part of medias, if I talk about just mediastinum, it is the middle area of the thoracic cavity. So basically it is the area between the mediastinal pleura, and superiorly lies the superior thoracic aperture. So this is the superior thoracic aperture, which will lie superiorly. Okay, this is just to make you understand. Inferiorly, lower down will be D for the diaphragm. This is also to make you understand. Posteriorly is the all thoracic vertebra. So this whole and anteriorly with the sternum. So if an imaginary line which is passing through sternal angle anteriorly and posteriorly in between T4 and T5 thoracic vertebra. So above to it lies the mediastinum part. This is called as superior mediastinum. What is it? This area is called as superior mediastinum. So what is it? This is SM, superior mediastinum. Now lower part is inferior mediastinum. This inferior mediastinum again in the middle area is having pericardium and the great vessels. This is the heart, and its great vessel covered by the pericardium is forming the part of middle mediastinum. Actually it is divided into three parts. So this is the middle mediastinum. And posterior to the mediastinum, we have got the posterior to middle mediastinum, we have got the posterior mediastinum, which is lying anterior to thoracic vertebra. And anterior to it, we will have anterior mediastinum. This is AM, this is anterior mediastinum, which is lying just posterior to the sternum. Now, this is a radiological image in which you can see this is an imaginary line, which we have already discussed. This is superior mediastinum, this is anterior, middle, and posterior mediastinum. Now, I just want, so actually the next important point is, I just want the enumeration point which must be known to you. Actually, this enumeration is very important. Why? Because multiple of times, if you see the previous year examination FMG questions, they have asked about the contents of superior mediastinum, they have asked about the contents of posterior mediastinum, they have asked about the content of anterior and the middle mediastinum. So one by one, you have to know about this. So let's talk about the content of superior mediastinum. So if I talk about the content of superior mediastinum, it is like important arteries. So first is the important arteries. So the arteries are arch of aorta and its branches. Arch of aorta and its branches. So that is subclavian artery, that is left subclavian artery, left common carotid artery, and brachiocephalic trunk. Now, veins. So it's also important to know the important veins, which is the content. So the veins are superior vena cava, left superior intercostal vein, and brachiocephalic vein. Okay. Now also we have to know the contents, that is the nerves. The important nerves, actually, when I talk about superior mediastinum, there are so many structures residing in the superior mediastinum. The important nerves will be the sympathetic chain, the phrenic nerves, the left recurrent laryngeal nerve, and the vagus nerve. So we will have the sympathetic trunk and chain. We will have the vagus nerve of both the side. We will have the phrenic nerve of both the side, and we will have only left recurrent laryngeal nerve. So these are of both sides. Only we have got left recurrent laryngeal nerve. So these are of both sides, but we have got left recurrent laryngeal nerve of left side. The muscles. The muscles are, so we will have sternohyoid and sternothyroid attached to the sternum, and also we will have posteriorly the longus colli muscle. Sternohyoid muscle. We will have sternothyroid, and we will have longus colli muscle. We will have the tubes. We will have two tubes as the content. We will have the esophagus and trachea. Okay. We will have the lymphatics. The important lymphatics as the content are the thoracic duct, the thymus gland, and the lymph nodes. So, my dear students, all these are the content of superior mediastinum. What I have written is all these are the contents of superior mediastinum, which was a great list. But all other mediastinum is having a few important structures which you have to know. Okay. So let's see. So we have done with this. Now we are left with the so we have done with the superior mediastinum. Now I want everybody to know about the contents of anterior, posterior, and middle mediastinum. So let's talk about the content of anterior mediastinum. Okay, so let's talk about the content of anterior mediastinum. So anterior mediastinum is a small area which is lying posterior to the sternum. So it will have thymus gland lower part. So upper part of the thymus gland will be a content of superior mediastinum, but lower part of the thymus gland. But the lower part of the thymus gland, which will be a content of anterior mediastinum. So it contains lower part of thymus gland. And my dear students, it also contains anterior mediastinal lymph node. It also contains internal thoracic artery mediastinal branch. Mediastinal branch of ITA. What is ITA? Internal thoracic artery and sternopericardial ligament. Okay, my dear students. And one more that is not very specific content, but it is the loose areolar tissues. So we have done with the anterior mediastinum. Now coming to the content of middle mediastinum. If I talk about the middle mediastinum, the contents are, so it's easy to know about the content of middle mediastinum. It will be the heart and the great vessels. So the heart is covered by which layer? It is covered by pericardium. So you can write heart and the pericardium, heart and the pericardium. We will have also the lower part of superior vena cava. Please note down, actually superior vena cava is also the content of superior mediastinum, but when I am talking about lower part, it is the content of middle mediastinum. Other than that, we will have the contents as pulmonary veins. We will have the pulmonary trunk dividing into arteries, pulmonary trunk dividing into pulmonary arteries. Then we will have trachea bifurcating bifurcation into principal bronchus. PB means principal bronchus, deep cardiac plexus, ascending aorta. So done. So we have done with the content of middle mediastinum. What remains is the content of posterior mediastinum. Posterior mediastinum. So if I talk about the content of posterior mediastinum, the contents are following. So the content of posterior mediastinum. Actually, it is very, very important for you to know the content of posterior mediastinum. Why? I will tell you, because it has been asked several times in the examination. The contents are thoracic duct. Thoracic duct was also the content of superior mediastinum. And it is having the content as DTA, descending thoracic aorta. It is having the content of azygous venous system. It is having the content as the vagus nerves. It is having the content as posterior mediastinal lymph node. And it has the contents of sympathetic trunks and splanchnic nerves and esophagus. Splanchnic nerves and the esophagus. Okay, my dear students, so we have finished with the thorax also, important part, which is important for FMG exam. But let's start with the abdomen now. Okay, so in the abdomen part, what we have seen in the recent trends of examination, so many times the plane has been asked. In the recent examination, so many times planes has been asked. So that is the transverse planes. What is the location of transpyloric plane? What all the structures lies in the transpyloric plane? What are the structures lying? What is the level of subcostal plane? What is the level of supracristal plane? What is the level of intertubercular plane? So I want everybody to know that. So actually the major planes is the mid, so we will have the vertical lines, that is the mid-clavicular line. And here we can see the mid-clavicular line, and we can see the true transverse plane, that is transverse pyloric and the intertubercular, transtubercular or transpyloric plane. And this is how the 9 quadrants in the abdomen is formed. Now the important abdominal plane which you should know is the subcostal, transpyloric and intertubercular plane. So I want quickly you have to know about the level, because if we see the previous year, means recent 2 to 3 year question papers of FMG, you will have these planes and you will have the structures residing on this plane. So you can't leave this topic. It is very important. So it is very important that you should be knowing about these planes. So let's start about these planes. So I would like to start with the important planes, which is, so start with the transpyloric plane. So the first plane is transpyloric plane. Any idea about the level of this plane and what is the other name? It is also called as Adamson's plane. And any idea what level this plane is lying? Anyone knowing what is the level of this plane? What is the level? That means what is the lumbar level? So it is at the level of L1 lumbar vertebra. It is the level of L1 lumbar vertebra. Now, important structures, actually many important structures are lying at this level, and that is important for you to know. Okay, so many important structures. So if I talk about transpyloric plane, by the name only it is clear, pyloric. So the pylorus of the stomach. Then comes also the fundus of gallbladder is lying here. Also we will have the tip of ninth costal cartilage. Okay, my dear. Also we will have the hilum of kidney, the neck of pancreas, the formation of portal vein, the superior mesenteric vessels, the lower end of spinal cord called as conus medullaris, the cisterna chyli, the initial part of duodenum. So we will have initial part of duodenum. We will have the cisterna chyli. Then we will have conus medullaris. What is conus medullaris? The lower end of the spinal cord. We will have, at this location, we will have neck of pancreas. formation of portal vein is also occurring at this plane. We will have superior mesenteric vessel at this level. So I think all the important structures we have done. Okay, so these all structures which I have written are the important structures residing at the level of pylorus, transpylorus plane. Now the second important plane is, the second important plane is subcostal plane. Subcostal plane, which is at the level of L3 lumbar vertebra. Then we will have the intertubercular plane, which is also called as L5 lumbar vertebra, and we have the supracristal plane. Supracristal plane is corresponding to the highest point of iliac crest. So it is corresponding to iliac crest highest point. And this corresponds to L4 lumbar vertebra. What is the level? It corresponds to 4th lumbar vertebra. Now, if I talk about the supracristal plane, as you can see in this diagram also, the supracristal plane. So this is the uppermost part of the pelvis, which is corresponding to the highest point of iliac crest. This is an important landmark which is utilized while doing lumbar puncture for the spinal anesthesia. And you can see the two planes, the supra and transpyloric plane here. It is corresponding to L4 lumbar vertebra. Okay. Now coming to the umbilicus. Now, it is also important for you to know the location of umbilicus and the remnants which is lying at the level of umbilicus. So, embryologically, remnants of these structures has been asked so many times in the examination. So, first thing which is important for you is to know the location of umbilicus. So, when I'm talking about location of umbilicus, it corresponds to L3, L4 lumbar vertebra. Okay, L3, L4 lumbar vertebra. And basically, many important remnants are lying there. If I talk about ligamentum teres, it contains the remnant of left umbilical vein. Anyone knows what does ligamentum teres is the remnant? So it contains the remnant of left. It is actually containing the remnant of left umbilical vein. Left umbilical vein. If I talk of medial umbilical ligament, it contains, medial is containing umbilical arteries remnant, and median one is containing urachus remnant. What is urachus? It connects the urinary bladder apex to the umbilicus. It is also called as Allen twice, which it contains, which is connecting the urinary bladder and that of umbilicus. Now, there is one lateral fold which is called as lateral umbilical fold. So basically here, no doubt about this, this is the falciform ligament lower part. So basically this sickle-shaped fold is the falciform ligament. This sickle-shaped fold of is called falciform, and this lower part is ligamentum teres. What is its lower part? Its lower part is ligamentum teres. So this is ligamentum teres, which contains the left umbilical ligament, and here, so this is medial umbilical ligament. These are the two medial umbilical ligament, and laterally also there is this fold. So see here, this is median umbilical ligament. These two are medial umbilical ligament, and this is a fold. These two are lateral umbilical fold. These two are lateral umbilical fold. And in this diagram, you can appreciate that lateral umbilical fold is running over vessel. Which vessels are these? These are inferior epigastric vessels. So it is running over inferior epigastric vessels. So these remnants and location has been asked in examination. What is the level of umbilicus? L3 and L4 lumbar vertebra. L3 and L4 lumbar vertebra. Okay, now. Actually, inguinal hernia is again a favorite topic which has to be known to you. So I just want everybody to be well aware of this topic. That is the different kinds of inguinal hernia. So basically in lower limb, we have already done the femoral hernia. So yes, my dear students, are you understanding? Any doubt, please ask me. Any doubt, please ask me. Now, this is actually the table is already with your notes. I just want you to have a differentiation between direct and indirect inguinal hernia and femoral hernia. So basically, if we talk about the herniated, the loop which is herniating through femoral canal or femoral ring is the site of femoral hernia, and it is lower to inguinal ligament. So this structure is the inguinal ligament. And we know that inguinal ligament is formed by the lower arched fibers of external oblique muscle aponeurosis. So it is extending from anterior superior iliac spine to that of pubic tubercle. Okay. Now, if I talk to that of pubic tubercle, now if I talk about this triangular area is the Hazelback triangle. So this triangular area is called as Hazel triangle, H triangle. What is the full form? This is called as Hazelback's triangle. Actually, Hazelback triangle is also called as inguinal triangle. And in this diagram, you can see it is bounded by. So what is this muscle which I am highlighting? It is the rectus abdominis muscle. So this is RA for rectus abdominis muscle. Lower down, you can see this is inguinal ligament. This is inguinal ligament, and this is inferior epigastric vessel. Inferior epigastric vessels. So what will be the boundary of Hazelback triangle? So if you want, I can just highlight this Hazelback triangle in the form of blue color. So see here, this is the blue color highlighted area is Hazelback triangle. So this is the site for direct inguinal hernia. This is the site for direct inguinal hernia through Hazelback triangle. So Hazelback triangle is bounded by rectus abdominis medially, laterally by inferior epigastric vessel, and lower down by inguinal ligament. Now, lateral to inferior epigastric vessel, this is lateral to inferior epigastric vessel. There is deep inguinal ring and inguinal canal, which is the site of indirect inguinal hernia herniation. So in relation to, if I talk about the herniation, so if I talk about this hernia, indirect inguinal hernia herniation is occurring lateral to the inferior epigastric vessel. So anatomical differentiation or location of direct and indirect inguinal hernia can be done in respect to inferior epigastric vessel. The herniated loop which is emerging lateral to that of inferior epigastric vessel is indirect inguinal hernia, and if it is medial to the inferior epigastric vessel, it is direct inguinal hernia. Now lower to inguinal ligament, we have got femoral canal and ring. We have got femoral canal and ring, and this femoral canal and ring is the site of femoral hernia, which we have already talked in the lower lip. So done. So we have done with the site of 3 inguinal and femoral hernias. Now, the differentiation between direct and indirect inguinal hernia has been shown, and anatomically, actually clinical differences, surgical differences has been done. For anatomically, the relation of with the inferior epigastric vessel is very important. Lateral to inferior epigastric vessel is indirect, and medial to it is the direct inguinal hernia. Okay. So this is features, this is direct, and this should be direct here. So this should be direct inguinal hernia. Okay. So that is very important. The relation is very important. Now we will talk about a few most important things also. That is important for an examination. So we have got peritoneum covering in the abdominal viscera structures and all. So basically, few structures in our body is having peritoneum covering on one side only. These are called retroperitoneal structures. So you have to know the list of all retroperitoneal structures in our body. So the mnemonic for the retroperitoneal structures in the body is the 𝗘𝗱𝗶𝗁. What is the mnemonic? The mnemonic is 𝗘𝗱𝗶𝗁. So here S for suprarenal gland, A for aorta and inferior vena cava, D for duodenum except the duodenal cap, pancreas except the tail, ureter, C for colon, kidneys, esophagus, and rectum. These are the structures which are retroperitoneal structures in our body. Now, derivatives. If I talk about embryological part and the question being asked are the derivatives of ventral mesogastrium and dorsal mesogastrium has been asked so many times. So the mnemonic is lesser fat. So if I talk about derivatives of ventral mesogastrium, it's the mnemonic is lesser fats. Lesser means lesser omentum, which is having lesser omentum, F for falciform ligament, and FC for falciform ligament, T for triangular, and C for coronary ligaments. If I talk about derivatives of dorsal mesogastrium, most of it is having G3L, that is gastrosplenic, gastrophrenic, greater omentum, and lino-renal ligament. Lino-renal means connecting the spleen and left kidney. Now, stomach. So let's talk about the stomach part. So when I'm talking about the stomach part, you in the stomach case, you have to know about the parts and the relations and the arterial supply. It's very important that you should be knowing about arterial supply of the stomach. So let's talk about the relations. So this is showing the cardiac end of esophagus and cardiac orifice, the fundus, the body and pylorus part of the stomach. And in relation, basically important structures of viscera related in the stomach is posteriorly. So the viscera on which stomach is resting is called as stomach bed. Posterior relation of stomach is called as stomach bed. So you can write down the heading, posterior relation of stomach, which is called as stomach bed. And it is important for you that you should be knowing the structures which is forming stomach bed, because it has been asked so many times in the examination. And this important structures which is lying in the posterior relation is lesser sac, the pancreas, the transverse colon and mesocolon. We will also have the left kidney and suprarenal gland. Left kidney and suprarenal gland, that is also of left side. The spleen and splenic artery. The spleen and splenic artery. So all these structures are forming stomach bed. Anteriorly, if I talk about the relation, so anteriorly stomach is related with anterior abdominal wall, also with the diaphragm part, and also with the left costal margin. Left lobe of liver is a small part, and we will have left costal margin. Okay, so these are in the anterior relation of stomach. And superiorly, we will have the left dome of diaphragm. So these are the structures which is in the relation of stomach. Now talking about the important arterial supply. So the most important arterial supply of the stomach, if I talk about most important arterial supply of the stomach, that is from the left gastric artery. Okay, that is from the left gastric artery. And basically, it is important that you should be aware of important arteries and its source of arteries, which has been asked about in the examination. So that is very, very important for you. Actually, that is very important. Okay, so let's see here. The important arteries are the following artery. Left gastric artery is a direct branch of. It's a direct branch of CT. What do you mean by direct branch of CT? Celiac trunk. Right gastric artery is a branch mainly from the proper hepatic artery. Proper HA means hepatic artery. Now, right gastroepiploic artery is a branch of gastroduodenal artery. Left gastroepiploic artery is a branch of splenic artery. Short gastric artery is a branch of splenic artery. So these are the 5 arteries which is giving arterial supply of the stomach, and the source of the arterial branch is also known. Now ligaments, important ligaments of the important ligaments of the stomach is shown here, not the. So here important ligaments of the stomach is only shown. So actually gastrosplenic ligament is also concerned with the spleen. So only there it is like that. Okay. So stomach and spleen. So ligaments of stomach and spleen also. So gastrosplenic ligament. If I talk about gastrosplenic ligament, it's a very important ligament, and it is actually it contains short gastric artery, short gastric arteries, and accessory spleen. Okay. Now, so one more is there which is not shown here. That is so this will be the first ligament. The second one is rhinorenal ligament. So by the word rhinorenal ligament, because it connects the spleen and the left kidney, and it contains two important structures as a content: tail of pancreas and splenic artery. The pharyngeal ligament. In this diagram, you can see the pharyngeal ligament, which is giving indirect support to the spleen lower part. It is preventing the descent of spleen down in the left side, and lower down there is also a gastrocolic ligament for supporting the stomach. Now, relations of the kidney, anterior and posterior, is again a very important topic which you can't leave it. So it's very important that you should be knowing about relations. Let me see your messages also in between. So if my dear student is having any doubt, they can know me. They can ask me. So when I talk about the relations of kidney has come as an image-based question. So the first thing is that you should be knowing how to identify which is right and left kidney. So this is inferior vena cava, no doubt. This is abdominal aorta. So inferior vena cava will be close to the right kidney as shown in the diagram, and abdominal aorta will be close to the left kidney. Other than that, there can be also the suprarenal arteries, suprarenal areas, suprarenal structures. So suprarenal gland of right side is a triangular cap shape, and left side it is of the cogged, it is like semilunar shape. And actually, if I talk about anterior relation, in the right side, we will have the liver area of relation. We will have the D for duodenum, and also colic and jejunal area. Suprarenal area of right side, obviously it will be on the right side, and suprarenal area on the left side will be on the left kidney. Other than that, left kidney will have the relation of stomach, spleen, pancreas, colon, and jejunum. So these are relation of kidney on the anterior side, on right and left side. The posterior side. The important point about the posterior relation is that the posterior kidneys have relation of ribs, diaphragm, and muscles. So one of the important point is that the right kidney is slightly lower as in respect to the left kidney. The reason is that right kidney is lower because liver is a heavy organ lying above. So it is related just to 12th rib, but left kidney is related to 11th and 12th rib. Now muscles, so it is related to diaphragm, psoas major, quadratus lumborum, and transverse abdomen. This is similar for right and left kidney. Nerves and vessels, so we will have the ribs we have done about the muscles. The third relation is nerves and vessels. So in nerves and vessels, we have got the relation of subcostal nerves and vessels. And also we will have the relation of iliohypogastric nerve and ilioinguinal nerve. So we will have the relation of subcostal nerves and vessel, iliohypogastric and ilioinguinal nerves and vessels. Okay. Now coming to mesentery. If I talk about the mesentery, it is a fold of peritoneum which is holding the small intestinal loop, which part? Jejunum and ileum. So what question is asked from the mesentery part? Actually, mesentery has got an attached border which is extending from left to right side, from the duodenojejunal junction to that of ileocecal junction. And it is crossing many important structures. The root of mesentery is the attached border, and the free border is about approximate of 6 meters, containing jejunum and ileum loop. The attached border is 15 to 20 centimeters. So the structures crossed by root of mesentery, what does that mean? That means it is crossing the structures by attached border, which is extending from duodenojejunal fissures on the left side to the ileocecal junction on the right side. The structure being crossed is the inferior vena cava, the abdominal aorta, the right psoas major, the right gonadal vessel, and horizontal part of duodenum and the right ureter. So all these structures which I have numbered is the structures crossed by the attached border or root of mesentery. Now, in the end of the abdominal part of the abdomen, I want everybody to know about the important branches of great vessels, like important branches of abdominal aorta, the important branches of superior mesenteric artery, the important branches of inferior mesenteric artery, and the celiac trunk. So, if I talk about the abdominal aorta, as you can see, abdominal aorta bifurcate into common iliac artery and then into external and internal. Internal iliac artery will give arterial supply to the pelvic structures. External will go into the lower limb. Here we can see the terminal, median or middle sacral artery and the anterior branches, celiac trunk, superior mesenteric and internal, superior and inferior mesenteric arteries. Now, actually, this is a schematic diagram in which you can see all the branches of the abdominal aorta. I want you to know all these branches. So, we are having following branches from abdominal aorta. That is the inferior phrenic artery. We will have the three anterior branches, celiac trunk, superior mesenteric artery, inferior mesenteric arteries, celiac trunk, CT for celiac trunk. We also have the renal arteries, the gonadal arteries. When the gonadal artery, it means gonads, like ovarian arteries in case of females and testicular artery in case of males. That means ovarian arteries and testicular arteries. We will have the four pairs of lumbar arteries. We will have the middle suprarenal arteries. We will have the common iliac arteries of right and left side. We will have the middle sacral arteries. So all these are the branches of abdominal aorta. Now coming to the branches of celiac trunk. So celiac trunk itself is given, it's an anterior branch of abdominal aorta which is given at the level of T12. Now celiac trunk direct three branches are, the largest is the splenic artery, then we have got the left gastric artery, then we have got the common hepatic artery. The common hepatic artery divides into the proper hepatic artery, right and the left hepatic artery. It also gives further branches at gastroduodenal artery, which will further divide into right gastroepiploic and superior pancreatico-duodenal artery. The splenic artery will give various good important branches like left gastroepiploic artery and that of short gastric arteries. Now, here the important branches, so abdominal aorta giving CT, which is given at the level of T12, the largest branch splenic artery, the left gastric artery, and then we will have the common hepatic artery. The common hepatic artery is giving the gastroduodenal artery, which is again further dividing into right gastroepiploic and superior pancreatico-duodenal arteries. The common hepatic artery divides into proper hepatic artery, which gives right gastric artery. The proper hepatic artery divides into right hepatic and the left hepatic artery, and the right one is giving branch to gallbladder, that is cystic artery. Superior mesenteric artery, which is given at the level of L1 lumbar vertebra, another anterior or the ventral branch. It's another anterior or the ventral branch of abdominal aorta. Important branches of the superior mesenteric artery will be jejunal and ileal branches, middle colic, right colic, ileocolic. Other than that, superior mesenteric artery also gives inferior pancreatico-duodenal artery. So SMA given at the level of L1, its important branches are inferior pancreatico-duodenal artery, it also gives jejunal and ileal branches. It also gives middle colic arteries, right colic arteries, ileocolic arteries. Now, the last is the inferior mesenteric artery. Now, if I talk about the inferior mesenteric artery, the inferior mesenteric artery is a ventral branch which is given at the level of L3. It's a ventral branch of abdominal aorta which is given at the level of L3. And this, if I talk about the inferior mesenteric artery, it is giving a very important branch. It gives three important branches, and that is, it gives branch to the sigmoid colon, its terminal branch is superior rectal artery, and it gives left colic artery. So what about the branches? So write down the branches of inferior mesenteric artery is it gives sigmoidal arteries. It gives left colic artery. And it gives superior rectal artery. Okay, so we have done with the abdomen thorax part also completed. Now what remains is the neuroanatomy and embryology. So yes, so let's go with this. So till now, is it okay, my dear students? You're fine with this? Can we start with the neuro and embryology, the last part? So it will take another 1 hour and we will be able to complete this. Everyone, is it fine? Can we start with the neuroanatomy part? Okay. So actually in the neuroanatomy part, one very important point is the meninges of the brain. Okay. So if I just want to summarize the most important part of neuroanatomy, which will be asked in the examination from you, is the dural venous sinuses, the meninges of the brain, the arteries, the circle of Willis will be asked. So it's and also the syndromes, lateral medullary syndrome, medial medullary syndrome, few syndromes which will be asked. So let's start with this. So I would like to start with this meninges of the brain. So this is again a schematic diagram to help you understand the layers. So we can see here the scalp, and then we can see the skull, and then we can see the three meningeal layers. So we know that the meninges of brain is made of three layers. So the outermost, this is actually, if I talk about the outermost layer, this is the dura mater. So if I talk about the meninges of brain, the meninges of the brain is having two layers. So this is the outermost layer, that is dura mater, which is made of two layers. The outer is the perosteal, endosteal, and the inner is the meningeal layer. Then we have got the arachnoid matter, and then the third layer is the pia mater. So this is the first layer, this is the second, and this is the third layer on the, and the pia mater is actually covering, it is very much adherent to the cerebral cortex or the brain surface. And below the arachnoid matter, we have got the subarachnoid space. And what does the subarachnoid space contains? The subarachnoid space contains the CSF, the cerebrospinal fluid, which is a very important fluid, which is very important fluid for the buoyancy of central nervous systems. So this space is the subarachnoid space containing CSF. Now, if I talk about the meninges of the brain and its dural folds, we have got four dural folds which everybody should know. What is it? So that four dural folds are flux cerebri, flux cerebelli, tentorium cerebelli, and diaphragma ocella. So for your examination, it's very important that you should have the concept of all the images showing this dural fold, what does it contains, and what dural venous sinus contains, and where it is located. That is very, very important. So I would like to start with the so four dural folds are. So we are talking about which fold? Dural folds. So how many dural folds are there? Four. So you can write also this. There are four dural folds. So four dural folds are there, and one by one. So first one is flux cerebri. Flux cerebri. So when I talk about flux cerebri, you can see this image and you can appreciate the flux cerebri. So basically for the appreciation of flux cerebri, I'm just enlarging this image. So once I enlarge it, it becomes clear for you that this large sickle-shaped fold of dura mater is lying in the longitudinal fissure of the brain. So we have got right and left cerebral hemisphere, and in between we have got a deep longitudinal fissure in which the sickle-shaped fold of dura mater. So basically this sickle-shaped fold of dura mater is the flux cerebri, which is dipping in the longitudinal fissure of the brain. So this is flux cerebri. Okay. Now, what dural venous sinus it contains? So dural venous sinuses contains. So that means flux cerebri is containing which dural venous sinus? So it's very important for you to note down that it contains 3 dural venous. I will also show you the image, don't worry. So the 3 dural venous sinuses, which is the content of flux cerebri, is superior sagittal sinus, the inferior sagittal sinus, and the straight sinus. Okay. Now, the next one which I want you to explain is tentorium cerebelli. Before that, you just have a look. So this is the dural venous sinus. This is flux cerebri, no doubt about this. This is the sickle shaped fold of dura, which is flux cerebri. And it is containing superior sagittal sinus, superiorly inferior sagittal sinus, and ST for straight sinus. That we have already written. Okay, now coming to the next image, that is the flux cerebri and tentorium cerebelli. So actually, we have opened the cranial cavity posteriorly, where we can see two folds. There is flux cerebri, which is resting over tentorium cerebelli. So here you can see, okay, so this is flux cerebri, and you can see it is resting over tent-like fold of dura mater, that is tentorium cerebelli. So what is the function of tentorium cerebelli, which is clear from this image? As you can see, this is one side cerebral hemisphere. So this is right and left cerebral hemisphere, and this is the cerebellum. So basically, cerebellum is having the weight approximately, it is having very less weight as compared to that of heavy weighted occipital lobe of cerebral hemisphere. So actually, this will be the occipital. This is the right and left side occipital lobe of cerebral hemisphere. So basically, okay, so to protect the heavy weighted occipital lobe of cerebral hemisphere onto the cerebellum, so that the small brain cerebellum is not crushed by the weight of occipital lobe of cerebral hemisphere, in between we have got a tent-like fold of dura mater, which is called as tentorium cerebelli. This is the function of tentorium cerebelli, located in the posterior cranial fossa, separating occipital lobe of cerebral hemisphere with the cerebellum. Now, it is also important for you to know the dural venous sinus it contains. So I would like to show you another image, which is called as tentorium cerebelli superior. So actually this image is showing you the interior of the cranial cavity in which the brain has been removed, and you can see the cranial cavity. So this tent-like fold which you are seeing, this tent-like fold is the tentorium cerebelli. No doubt about that. Now coming to the fact here, this is actually dural venous sinus it contains. Okay, so it contains dural venous sinuses, and it contains 2 dural venous sinuses. It contains TS as the transverse sinus and superior petrosal sinus anteriorly. Okay, anterolaterally it contains superior petrosal sinus, and posterolaterally it contains transverse sinus of right and left side. So it's very important. So you can just write down here, tentorium cerebelli contains following dural venous sinus. So it is containing transverse sinus, and it is containing superior petrosal sinus. Superior petrosal sinus. Now, so yeah, this is the image showing tentorium cerebelli, which we have discussed. Now the third one. So that third dural fold is flux cerebri, which is a very small fold of dural fold, which is very small dural fold. This one. So it is like this. This is a small dural fold. Actually, this dural fold, if I talk about this small dural fold, that is the flux cerebri, which will be lying in between the two cerebellum, and it contains occipital sinus. So it is flux cerebelli is located in between cerebellum lobes. it contains occipital sinus. This is the third dural fold. It is the second dural fold, tentorium cerebelli, and this was the first, that is the flux cerebri, which we have already discussed, I think. Yeah. So what remains, my dear students? The fourth one. What is the fourth one? The fourth one is diaphragma sella. The fourth dural fold is diaphragma sella. So if I talk about diaphragma sella, it is actually located in the middle cranial fossa, body of sphenoid. So this is the diaphragma sella, which is located in the body of sphenoid. And in the center, it is actually diaphragma sella contains pituitary gland. And it is having an aperture in the center for the passage of stalk of pituitary gland. So this is a cadaveric image in which you can clearly see this is the diaphragma sella, which is located at the body of sphenoid, as you can see in this diagram. And what you can see, it is having the stalk of pituitary gland. So this is having a round aperture here in the center for the stalk of pituitary gland. Now, I would also like to talk about the clinical anatomy related with the dura mater. One is the extradural hematoma. So normally what happens in case of spinal cord covering dura mater, there is epidural space. Okay. If I am talking about the brain, there is no epidural space. Okay. But in case of spinal dura, there is epidural space. But in abnormal condition, if there is a hemorrhage or bleeding from the injury on the level of terion. What is terion? It is seen on the lateral aspect of the skull when four bones are meeting at the level of terion. And there can be a bleeding from middle meningeal artery, which is a branch of maxillary artery first part. And that collection of the blood, which is shown in red color, is the arterial blood collection leading to epidural or extradural hematoma. The most severe condition is subdural hematoma, in which the veins, bridging vein is damaged. So this is showing you the difference between extradural and epidural hematoma. So actually in case of extradural hematoma, the middle meningeal artery is involved. In case of a subdural hematoma, the bridging veins are involved, and lucid interval is there in case of extradural. Prognosis is more bad in the subdural hematoma as compared to epidural hematoma. If quick management of the case is done, we can save the patient from extradural or epidural hematoma. The safe and all the differences medically and surgically has been demonstrated here. Now coming to the arterial supply. So if I talk about the arterial supply of the dura mater, it is from the branches of following artery. It is from the branches of branches of ethmoidal arteries. That is from the source of internal carotid artery, ophthalmic branch. It is also from the middle meningeal arteries, and it is also from the branches of maxillary artery, accessory middle meningeal artery. Also, the dura is getting blood supply from vertebral and occipital artery. Okay, so it is also from the ascending pharyngeal arteries, also from the occipital arteries and vertebral arteries. Yes, dear, you are right. That I will show you that image. Don't worry, I will show you the lateral aspect of the skull and the bone forming the H-shaped suture. Okay, I will show you. Don't worry. Also, the nerve supply is important. So when we are talking about the nerve supply of dura mater, that is also very important. So basically, when we are talking about the nerve supply, its innervation is by V1, V2, V3. What do you mean by the three divisions of the trigeminal nerve, the ophthalmic, the maxillary, and mandibular nerve? So we will have the ophthalmic, maxillary, and mandibular nerve. These are the three divisions of trigeminal nerve. And also it is from the meningeal branches of vagus nerve, the 12th cranial nerve, and the C1, C2, and C3. Cervical nerves, it is from the cervical nerves, that is C1, C3, and C2, also from the 10th cranial nerve, also from the hypoglossal 12th cranial nerve. These are the sources of innervation of dura mater. Now, after that, we will have the arachnoid matter. So, the arachnoid matter is the inner layer below the dura mater, and below arachnoid we have got subarachnoid space. We have got arachnoid granulations for the absorption of CSF. So its extent is from the, so exactly brain arachnoid matter lower down continue with the spinal arachnoid matter ending at the second sacral vertebra. And in this diagram, you can see the section, coronal section, where you can see the dura mater of the first layer, the arachnoid matter. Below it, we have the subarachnoid space, which is containing CSF. We can also see the arachnoid villi, which is for the absorption of CSF. No, 12th nerve supply. Sometimes. Yes, dear. 12th nerve, hypoglossal nerve supplies meningeal. Hypoglossal nerve is 12th cranial nerve. It also gives innervation. So hypoglossal nerve is the 12th cranial nerve. It also gives innervation to the dura mater of the posterior cranial fossa. Okay? It also gives innervation. Now in this diagram, you can see the pia mater, which is just adherent to the brain surface. It is very difficult to separate the brain from the pia mater covering. And as you can see in this image. Now, epidural hemorrhage is via involvement of anterior division of middle meningeal artery. And I would also like to show you the image. Don't worry, there is an image which I will show you further. Now, let's solve few MCQs. Dura mater is supplied by all the cranial nerves except. Dura mater of the brain is supplied by all the cranial nerves except. So, my dear students, there is hypoglossal, 10th, 5th, trigeminal and 4th. No, hypoglossal nerve, just now I have written, that is giving innervation. Trochlear nerve, what do you mean by 4th cranial nerve? 4th cranial nerve means trochlear nerve, and trochlear nerve doesn't supply, it supplies SO4. What is the full form? SO4. Trochlear nerve supplies superior oblique muscle. It doesn't supply the dura mater. So the right answer will be 4th cranial nerve. Now, a 23-year-old female clinical question, comes to emergency room unconscious after a motor vehicle accident. A linear fracture of 4 bones meeting, the frontal, parietal, the temporal and the sphenoid bone is meeting on the X-ray. Can you tell me which artery will be involved in this case? Which artery will be involved in this case and leading to the case of extradural or epidural hematoma? So the artery involved is middle meningeal artery, and you know it is a branch of maxillary artery. So absolutely correct answer, my dear students. A thumbs up goes for you. Absolutely correct answer. Very good. So it's a correct answer is absolutely right. This is the maxillary artery. Now, as I told you, please see this enlarged view. As I told you, I will definitely show you an image so that you have an idea. So that you have an idea of, see here, this is an enlarged view. So I just want you to show the lateral aspect of the skull. So when you see the lateral aspect of the skull, you can appreciate the pterion. So let me just show you the pterion. So this is the H-shaped suture. This is the H-shaped suture. So that means this is the H-shaped suture, which is the pterion. And here the meeting point, F for the frontal bone, P for the parietal bone, T for the temporal, and S for the sphenoid bone. Okay. So we can see 4 bones are meeting, and this is called as pterion. What is it called as? 4 bones are meeting, and this is called as the pterion, where we have got the location of. So if I am talking about these bones, that we have got the location of. This H-shaped suture is pterion. H-shaped suture, we have got the location of pterion where 4 bones are meeting, and the artery located is middle meningeal artery, which is the branch of maxillary artery first part, and that is leading to the bleeding and leading to the extradural or epidural hematoma. Okay, my dear students. Now, the other important point about this important anatomy, neuroanatomy part is that you should be knowing about intracranial dural venous sinuses. Intracranial dural venous sinuses, you have to know the paired and the unpaired one. So basically, we will study the cavernous sinus is much more detailed. Okay. If I'm talking about cavernous sinus, this is a topic which I will tell you in detail because it's very important topic. Other than that, in this image, you can see so many dural venous sinuses has been shown. So important dural venous sinuses has been shown location. We can see superior, inferior sagittal sinus, the 2 sides of cavernous sinus. So this is also the cavernous sinus of the other side. So the 2 dural venous sinuses is connected by that of anterior and posterior intercavernous sinus. We have got straight sinus, sigmoid sinus, we have got inferior superior sagittal sinus. So you have to know the name of paired and unpaired dural venous sinuses. And actually the meeting point of dural venous sinus is called as the confluences of sinuses, which is located at the level of external occipital protuberance. So please write down. So you should be knowing about the paired dural venous sinuses. So the paired dural venous sinuses are cavernous sinuses, superior petrosal sinus, inferior petrosal sinus, sigmoid sinuses, transverse sinuses, sphenoparietal sinuses. Right and left transverse sinus. Now coming to the list of paired, and then we can tell you the list of unpaired dural venous sinuses. So the unpaired one is superior sagittal sinus, the inferior sagittal sinus, the straight sinus, ST in short we can write straight sinus, the anterior and posterior intercavernous sinus, which is connecting the cavernous sinus anteriorly and posteriorly, the occipital sinus, anterior, posterior, intercavernous sinus. And that of occipital sinus. Now, I want everybody to also know about cavernous sinus. So, basically, actually, these sinuses are very important. Why? Because these dural venous sinuses is having connection with emissary vein. They have got no smooth muscles in their wall. They are devoid of valves, so the blood can flow in either direction, and ultimately, all the blood will flow in internal jugular vein. So basically, cavernous sinus, we have got two cavernous sinus in the middle cranial fossa on either side of body of sphenoid, which is connected by intercavernous communications anterior and posteriorly. And cavernous sinus is very important clinically. Why? Because it is having important structures related to it, and when it is infected or when it is involved, it leads to the clinical condition cavernous sinus thrombosis, leading to involvement of many important nerves and vessels. So cavernous sinus is located in middle cranial fossa on either side of body of sphenoid bone. Now, so this is exactly the location of cavernous sinus. You can see this is cavernous sinus. This will be one on either side, and this is body of sphenoid, and this is the middle cranial fossa. So on either side of body of sphenoid it is located. Now extent. So basically, if you talk about cavernous sinus extent, it is extending from the superorbital fissure to that of apex of petrous temporal bone. Apex of petrous temporal bone. This is the extent and location. Now, other than that, it is related. So if I talk about important relations, so I just want you to show, then we will talk about the relations. So basically, if I talk about the relation, so you see in the diagram, it is related medially to pituitary gland and sphenoidal air sinus, and in the lateral wall it is having third nerve, oculomotor, fourth trochlear and ophthalmic branch of trigeminal nerve. Actually, maxillary nerve is now not considered as the relation in the lateral wall, and two structures which is passing to and fro in the cavernous sinus is internal carotid artery and sixth cranial nerve. Superiorly, it is related with internal carotid artery and that of optic chiasma. So, let's write the relations. So, first thing is lateral wall of cavernous sinus have nerves from above to down. From above to down. So, the important nerves related from above to down is oculomotor nerve, the third cranial nerve, the trochlear nerve, that is the fourth cranial nerve, the ophthalmic branch of trigeminal nerve, and not the maxillary nerve, not the maxillary nerve. Now, other than that, superiorly cavernous sinus, superior relation will be of optic chiasma, internal carotid artery. Medially, it is related to pituitary gland and sphenoidal ear sinus. Other than that, if I talk about to and fro structures. So to and fro structures, which that means inside. What structures lies inside cavernous sinus? CS means cavernous sinus. So two structures are located inside. One is internal carotid artery and the other is sixth cranial nerve. Sixth cranial nerve. What is this sixth cranial nerve? That means abducens cranial nerves. That is abducens cranial nerves. Now, my dear students, the next important topic, which is also very, very important for you, is to know about the tributaries of cavernous sinus. It's very important that you should be aware of all the important tributaries of cavernous sinus. What do you mean by the word tributaries? Tributaries means they are directly draining blood to the cavernous sinus. So directly the blood is reaching via these in the cavernous sinus. Why it is very important, I will tell you. Actually, this tributaries is quite important part because infection from these tributaries will quickly reach in the cavernous sinus. So it is very, very important for you to know the name of these tributaries. Actually, a few of the veins are very important for carrying infections, like superior ophthalmic vein. So there are three tributaries reaching the cavernous sinus from the orbit, is two from the meninges and two from the brain. So, like from the orbit, we have got superior ophthalmic vein, inferior ophthalmic vein, and central vein of retina. Now, from the meninges, we have got sphenoparietal sinus, and middle meningeal vein. Now, from the brain, we have got, if I talk that is superficial middle cerebral vein, and that of inferior cerebral vein. Done? Now, let's talk about the clinical anatomy. Actually, clinical anatomy of the cavernous sinus is very important because when it is infected, it leads to a condition of cavernous sinus thrombosis. So, can you see this image? This is a case of cavernous sinus thrombosis. It's a very grave condition. And actually, you must have heard in the COVID time also that black eye case fungus infection is involving. And when infection reaches via direct tributary superior ophthalmic vein and all or other veins or some communication via facial vein, defacial vein, pterygoid venous plexus emissary vein, then it got infected. And why it is a very grave condition? It's a very dangerous and grave condition because the infection can reach in the brain. And what happens? Actually, we know that lateral wall is containing oculomotor nerve, trochlear nerve, and ophthalmic nerve, and also inside we have got abducens nerve. That means third, fourth, and sixth cranial nerve is affected. That means all the cranial nerves which is innervating extraocular muscles can be affected, and this can lead to the condition of internal ophthalmoplegia. There is pain around the eye and in the forehead because of involvement of ophthalmic nerve. And the eyes are feeling like it is coming out, exophthalmos. So these are the features of cavernous sinus thrombosis. So yes, my dear students, you can write down the features of cavernous sinus thrombosis. Internal ophthalmoplegia, exophthalmos, pain around eyes and forehead. Pain around eye and forehead. Now, let's solve few MCQs. Okay, my dear students, let's solve few MCQs together. So, septic emboli in the facial vein can lead to cavernous sinus. So, this is the clinical question, can lead to cavernous sinus. Thrombosis, facial vein connections is there. The most involved communicating vein or the involved vein will be among this. All are having a source of infection, but can you tell me the most common one which is involved in carrying infection to cavernous sinus and causing cavernous sinus thrombosis? So waiting for the right answer. Please mark the right answer, dear. I got the right answer. That is superior ophthalmic vein. Very good. All are the features of cavernous sinus thrombosis except which of the following is not a feature of cavernous sinus thrombosis? Papilloedema, proptosis, sensory deficit on the face due to the involvement of all the three branches of trigeminal nerve, external ophthalmoplegia due to compression of three motor supplies to the eye muscles. Yes, sensory deficit to the involvement of all the three branches of trigeminal nerve is the correct answer because it's only the ophthalmic nerve which is involved in the case of cavernous sinus. It's not the maxillary one and it's not the mandibular one. Now, which is not a tributary of cavernous sinus? So, which is not a direct tributary of cavernous sinus? Please mark the right answer. The options are sphenoparietal sinus, the superior petrosal sinus, the superficial middle cerebral vein, and that of inferior ophthalmic vein. Which is not a tributary? B. Superior petrosal sinus is absolutely the right answer, my dear students. It's a communication. It is not a direct tributary. All are tributaries and except one more same kind of question. Central vein, great cerebral vein, inferior ophthalmic vein, superior ophthalmic vein. Yes. Yes, you are right. That drains. C is the great cerebral vein of Galen is the right answer. It's not a direct tributary. It's not a direct. Great cerebral vein of Galen will drain into straight sinus. Now, actually, this is the sagittal section of the brain. Now, the image which I'm showing you is the sagittal section of the brain. And I want you to go through this image and know the important location of the ventricles of the brain. So, basically, I want to enlarge this image. And my dear students, I just want to highlight this. So, this is the corpus callosum. What is corpus callosum? It is the largest commissural fibers which is connecting the right brain with the left brain. Okay, so we are able to perform the action with the communication of both the side, right and the left. And this happens via communication between the right side of the brain with that of the left side of the brain. And this connecting fibers is the commissural fibers. The largest commissural fibers in a brain is the corpus callosum. So this green color structure which is shown here is what is it, my dear student? It is the corpus callosum. It is the corpus callosum. If you want to more, it is S for the splenium. This is B for the body and also T for trunk. This is G for genu and this is R for rostrum. Now below it, we can also see, below it, we have got the fornix. This is the fornix. So this is, again, this is the fornix. And also here you can see this is the septum pellucidum which is covering. So this is septum pellucidum. Covering lateral ventricle of the brain. Lateral ventricle of brain. So this is HT for hypothalamus and this is T for thalamus. This is pons. This is medulla. This is the cerebellum, the small brain. My dear students, here I just want you to note down that lateral ventricle will communicate via interventricular foramen of Monro. So here somewhere there will be interventricular foramen, IV for the interventricular foramen of Monro. Interventricular foramen of Monro. And then we will have the third ventricle. Then here, this is the location of fourth ventricle, and this communication will be via cerebral aqueduct. This is third ventricle communicating via cerebral aqueduct of Sylvius. So actually, it is very important for you to know all the ventricles of the brain. Why? Because it contains the cerebrospinal fluid. So the maximum amount of cerebrospinal fluid in which the brain and the spinal cord is floating. So basically, maximum amount of CSF is produced by the lateral ventricles, ependyma of the lateral ventricles of the brain, which is located each in the right and left brain cerebral hemisphere below corpus callosum. The corpus callosum from anterior to posterior has got four parts. R stands for rostrum, G for genu, B for body or T for trunk, and S for splenium. Now, the lateral ventricle will communicate with the third ventricle with interventricular foramen of Monroe. Third ventricle is the cavity of Dan-Keflon, that is thalamus and hypothalamus cavity. The third ventricle CSF will flow in the fourth ventricle via cerebral aqueduct of Sylvius. Fourth ventricle is anteriorly bordered by lower part of pons and upper part of medulla, and posteriorly there lies cerebellum. Now I want everybody to know about circle of Willis. So circle of Willis formation. So what is circle of Willis? It is an anastomosis which is formed between the branches of vertebral artery, vertebrobasilar artery, and internal carotid artery. So the yellow color outline is the circle of Willis. Circle of Willis is located in the interpeduncular cistern. It is located in interpeduncular cistern. So its boundary is, it is bounded anteriorly by anterior communicating artery. So anterior communicating artery is connecting two sides anterior cerebral artery. So as you can see in this diagram, the two side anterior cerebral arteries are connected by anterior communicating artery. So anterior communicating artery is forming anterior boundary, anterior cerebral artery is forming anterolateral boundary, AL for anterolateral. What is this? This is ICA, internal carotid artery, which is forming lateral boundary. We have got posterior communicating artery. Now, my dear students, posterior communicating arteries are forming posterolateral boundary, and posteriorly we have got posterior cerebral artery, which is forming the posterior boundary. So basically, this is how the circle of Willis is formed, which is located in interpeduncular cistern. And this is MCA, middle cerebral artery, which is not contributing in the formation of circle of Willis. Now we are finished with this. I would like to discuss few of the brain syndrome, and then we will just cover the embryology part, and that this is how we will end the anatomy part. Okay. So in case of brain syndrome, we have got Brown's brain syndrome and spinal cord syndrome, hemisection of the spinal cord, which is called as Brown-Sequard syndrome. Actually, in Brown-Sequard syndrome, if there is a injury like railway track accident, or someone has given a whip slash or means knife at the posterior part of the vertebral column, and the half of the spinal cord has been injured. So this can have a three features. Person will have a spastic paralysis. This is due to the involvement of pyramid containing corticospinal tract, the person below the level of lesion. The patient will also have ipsilateral loss of proprioceptive sensation because of the involvement of posterior column tract, and the person will have contralateral loss of pain and temperature sensation due to involvement of lateral spinothalamic tract. So this is showing you the image in which three clinical features you have to know about Brown-Sequard syndrome, hemisection of the spinal cord. Same side spastic paralysis below the level of lesion, loss of proprioceptive sensation due to involvement of posterior column tract, and contralateral side loss of pain and temperature due to involvement of lateral spinothalamic tract. Now coming to the brainstem syndrome. In case of brainstem syndrome, two syndromes are important. One is medial medullary syndrome, which is also called as bulbar Digerine syndrome, and actually this is very important. These two, lateral and medial medullary syndromes, are very important. So basically, if I'm talking about the medial medullary syndrome, that is Digerine anterior bulbar syndrome, it is mainly occurring due to the involvement of medial part of the medulla. Three important structures are involved: the hypoglossal nerve nucleus, the medial lemniscus, and pyramid. That means sign and features. Okay. So that means if we are talking about medial medullary syndrome, so here clinical features, I have to know about these three structures. So three structures, mainly the branches of vertebral arteries involved, and there will be contralateral paralysis due to involvement of pyramid, corticospinal tract, hypoglossal nerve. We know that 12th cranial nerve gives innervation to all the muscles of tongue. So there will be paralysis of ipsilateral half of the tongue, and medial lemniscus is involved. So loss of or contralateral loss of the position and vibration sense will happen. Lateral medullary syndrome, it's very important syndrome again for FMG exam. Dorsolateral part of the medulla is involved, and because of the involvement of dorsolateral part of the medulla, many important structures are involved in this area, and this will lead to the involvement of posterior inferior cerebral artery or the branch of vertebral artery. So actually in the dorsolateral part of medulla, we have got sympathetic fibers, Horner tracts. In ICP means inferior cerebral peduncles, vestibular nuclei, the part of vestibulocochlear part, the spinal tracts and trigeminal nerve, lateral spinothalamic tract. NA, what do you mean by NA? NA means nucleus ambiguous. So all these structures are involved. So the features will be, so it is also called as Pica syndrome because of involvement of Pica arteries or vertebral artery syndrome. It is also called as lateral medullary syndrome, is also called as Wallenberg syndrome. Now, my dear students, so in case of lateral medullary syndrome, we have got following features. So I have already told you about the structures being involved. So sign and symptoms will be according to the dorsolateral part, nucleus and tracts being involved. So thrombosis of the dorsolateral part of the medulla is involved due to involvement of the part of cerebellum, inferior cerebral peduncle, due to the ischemia of vertebral artery, the Pica arteries, and the sign and symptoms is lateral spinothalamic tract is involved, so pain and temperature sensation will be lost on the contralateral side. The trigeminal nerve and tracts has been involved, nucleus and tracts. So there will be same side loss of pain sensation, temperature sensation of the face, ipsilateral paralysis of all the muscles supplied by nucleus ambiguous, that is paralysis of soft palate muscle, larynx and pharynx because of involvement of 9th, 10th and 11th cranial nerve nucleus, that is called as nucleus ambiguous. Also, there will be involvement of inferior cerebral peduncle, that is cerebellum is involved, so the person will have ataxia, imbalance. Giddiness, so giddiness due to involvement of vestibular nuclei, and Horner syndrome due to involvement of sympathetic fibers which are running in the medulla. So my dear students, we have finished with the medulla syndrome, two important syndromes. So many times in examination it has been asked. Now coming to the syndromes of the pons. Two syndromes in the pons are commonly asked. One is the Ramond syndrome and the other is Maillard-Guilbert syndrome. So when I am talking about Ramond syndrome, you can see only two structures are involved as shown in the transverse section of the pons. That is the that is the sixth cranial nerve, and we know that sixth cranial nerve gives innervation to LR6. It gives innervation to lateral rectus muscle, causing internal squint because abduction of eye is not possible. So the eye will move inward. Internal squint and contralateral hemiplegia because of the pyramidal tract being involved. In Maillard-Guilbert syndrome, sixth cranial nerve is involved. Also the seventh cranial nerve is involved, and also the pyramid is involved. So what will happen? The sign and features will be similar to that of the Ramond syndrome, and here also the facial muscles will be paralyzed. Now coming to the syndromes of midbrain. If I talk about the syndromes of midbrain, two important syndromes in midbrain is asked. One is Weber and another is Benedict syndrome. So Weber syndrome is the vascular lesion in the basal regions of the cerebral peduncle. Mainly the artery which is involved in this case is posterior cerebral artery. The lesion is mainly involving crux cerebri and the third cranial nerve, the oculomotor nerve. Now my dear students, what does that mean? That means all the muscles of eyeball. So that means all the extraocular muscles is involved. So there is paralysis of all the extraocular muscles of eyeball except LR6 and SO4. That is except lateral rectus and superior oblique muscle. So see here. So ipsilateral lateral squint. Why lateral squint? Because third cranial nerve is involved. So abducer nerve is safe and lateral rectus is functioning. So obviously the patient will have lateral squint. Contralateral hemiplegia, the corticospinal tract involved. the involvement of 𝗘𝗱𝗶𝗁𝗃 tracts also, and also the patient will have drooping of upper eyelid. Why? Because oculomotor nerve is involved. So the part of levator palpebral superioris muscle of the eye is also involved. And we know that close to oculomotor nerve there is Edinger-Westphal nucleus. So we know that Edinger-Westphal nucleus is lying close to third cranial nerve, oculomotor nerve, and it is related with accommodation reflex, and that, and because of that pupil is dilated and accommodation reflex is lost. Now, if I talk about the next midbrain syndrome, this is again another midbrain syndrome which is more or less similar to Weber syndrome. But other than Weber syndrome, it is also leading to involvement of some other structures. So, third cranial nerve is involved. So, obviously, lateral squint and ptosis will be there. Other than that, there is also involvement of trigeminal and spinal lemniscus. So, that means also the patient will have involvement of medial lemniscus, and also the patient will have the involvement of red nucleus. So, the patient will have tremors. Okay, red nucleus involvement is there. So the patient will also have tremors. The patient will also have vibration and joint sensation gone. Trigeminal and spinal lemniscus involved. So the sensation of face and the body is gone. In case of paranoid syndrome, it's also a syndrome of midbrain, but it is rarely asked, and it is why I will tell you, because here only one important structure is compressed. Basically, it is due to the tumors of pineal gland, and because of the tumors of pineal gland, the patient is not having any feature except the upward gauge is affected. So that is just one feature which is seen in the case of paranoid syndrome, and the clinical basis is at not established, but it was just one line you should know about paranoid syndrome also, because I want to complete entire brainstem syndrome. So done. Now we will talk about the last part, the embryology part. So let's talk about the most important tables of embryology which will be asked. So if I talk about the embryology part, pharyngeal arch derivative is the most important part. So already in the head and neck part, you have correlated this pharyngeal arch, like muscles of mastication is derived from first pharyngeal arch. The maxilla, the premaxilla, the malleus and incus, the Michel's cartilage, all are derivative of first pharyngeal arch. The trigeminal nerve and the coda tympanic nerve, these are the nerves of the first pharyngeal arch. The second pharyngeal arch derivative muscles are the muscles of facial expression, the stylohyoid muscle, the posterior belly of digastric. We know the digastric is a hybrid muscle. Its anterior belly will be derived from trigeminal nerve and the first arch muscle, but posterior belly is second arch. Stapedius muscle is also the muscle of middle ear, which is derived from second pharyngeal arch. The stylohyoid ligament, the richest cartilage, the hyoid bone, the stapes, the styloid process, the upper part of the body of hyoid bone, and lesser corona, all these are derived from second pharyngeal arch. The facial nerve is the nerve of second pharyngeal arch. The glossopharyngeal is just one nerve, which is the nerve of third pharyngeal arch, which is giving innervation to one muscle, that is stylopharyngeus muscle. The greater corona and the lower part of hyoid bone derived from third pharyngeal arch, and fourth and sixth pharyngeal arch nerves are vagus recurrent laryngeal nerve, and it is giving rise to the muscles of larynx and the pharynx, and also the larynx cartilage. So pharyngeal arch artery derivative is also very, very important, my dear students. Now I just want everybody to know about pharyngeal arch arteries. So when I'm talking about pharyngeal arch arteries, why it is very important for you to know. Actually, you have to just go through this table and know about all the derivatives of pharyngeal arch, the first, second, third, fourth, sixth. But I will give you an understanding concept how you are how you are memorizing it. So first pharyngeal arch, what is this bone? This is the maxilla containing upper teeth. This is maxilla. So this is upper, this is above. So maxillary artery from first pharyngeal arch. Here somewhere we have got hyoid bone, and we have got in the ear stapedial artery. So stapedial and hyoid is slightly lower to maxilla. So it is second pharyngeal arch artery. Lower to it, we have got common carotid and internal carotid artery. So they are derived from third pharyngeal arch artery. And lower to it, we have got the fourth pharyngeal arteries, that is arch of aorta and subclavian artery. Sixth pharyngeal arch artery will go lower down, that is ductus arteriosus and pulmonary artery. Pharyngeal pouches derivative so many times. First pharyngeal pouch, it is the tympanic ear cavities, pharyngotympanic tube. Second pouch, the tonsil, palatine tonsil. So many times this pouch derivative has been asked in previous year FMGE exam. Third and fourth pouch. So third pouch is inferior parathyroid gland and thymus gland. Fourth is the superior parathyroid gland. Okay. So these are very important for FMGE exam. Now component of face and its okay. This is very important. Forehead is developing from frontonasal process. Nose also from frontonasal process. Upper part of the cheek is from maxillary process. Lower part of cheek is from the fusion of mandibular process. Upper lip is from the fusion of maxillary and mandibular process, and lower lip from the fusion of two-side mandibular process. So these all you have to know. And if I talk about entire innervation of the face, it is from the three branches of trigeminal nerve, that is ophthalmic, maxillary and mandibular, except the area around angle of mandible, that is from great auricular nerve. Now talking about the various component of adult palate. So hard palate. So actually, if I talk about the development of palate, it occurs in two process. Firstly, there is formation of primitive palate, that is fusion of medial nasal process. Very, very important for examination MCQs. From the medial nasal process of frontonasal process. Many times the question has asked, and frontonasal process is also in the option and medial nasal process is also in the option. The hard palate pre-maxillar part develops from medial nasal process part of frontonasal process. And then the definitive palate developed from the fusion of palatine cells of the maxillary process. Okay, so this is how the formation of palates takes place. Now, here actually I want you to know the developmental stage of the formation of entire diaphragm. So if I talk about diaphragm has got four parts, so basically gross anatomy we have already done. So this is showing you the successive stage of development. So this is A, this figure is B, this is C, and this is D. So how the adult diaphragm is formed? Diaphragm is a muscular partition which is located between thorax above and abdomen below. So basically what happens, the parts of diaphragm we know, we have already done. The insertion part is the central tendon of diaphragm. We know the crudas of the diaphragm, we know the peripheral part and the large peripheral part. So if I talk about the crudas of the diaphragm, they are developing from the dorsal mesentery of esophagus. The central part or the diaphragm, the central tendon of the diaphragm, which is the insertion part of the diaphragm, merging with the fibrous pericardium, that is actually derived from septum transversum. If I'm talking about the component, that is the small peripheral part of the diaphragm. The small peripheral part of the diaphragm developed from pleuroperitoneal membrane. The large peripheral part developed from the mesoderm of the body wall. So again, this part is very, very important for your examination. And if there is a defect in this developmental process of diaphragm, if the defect is enteromedially, it is leading to retrosternal diaphragmatic hernia. And if it is posterolaterally on the left side, which is more common, it is Bogdalek hernia, which is due to defect in the pleuroperitoneal membrane. More common is defect in the pleuroperitoneal membrane, leading to left side posterolateral diaphragmatic hernia. Okay, now in this diagram, we can see the three brain vesicles and how it is forming the 5 secondary brain vesicles and ultimately leading to the formation of ventricles of the brain. Now, initially what happens, there is formation of 3 primary brain vesicles. So basically there are 3 primary brain vesicles. What are they called as? Forebrain, midbrain and hindbrain. So forebrain is also called as prosencephalon, midbrain is called as mesencephalon, and hindbrain is called as rhombencephalon. With further development, the forebrain or the prosencephalon divides into 𝗘𝗏 and diencephalon. The 𝗘𝗏 will lead to the formation of cerebral hemisphere. The diencephalon will form the thalamus, hypothalamus, subthalamus. The cavity of the cerebral hemisphere will lead to the formation of LV, that is lateral ventricle. The cavity of diencephalon is the third ventricle. Now, mesencephalon doesn't form any of the, it doesn't divide in the secondary brain vesicle. It is just the mesencephalon, which will lead to the formation of midbrain, and the cavity of it is called as cerebral aqueduct. Rhombencephalon, which was the primary brain vesicle, will further divide into 2 secondary brain vesicles, the mitten and myencephalon. This will lead to the formation of cerebellum, pons and medulla oblongata, and the cavity of these rhombencephalon is the fourth ventricle. So this is how the 3 primary brain vesicles form, the 5 secondary brain vesicles form, and ultimately the ventricular system of brain is formed. Actually, if you want to have a more detailed of this, the table is also shared with you. The 3 brain vesicle leading to the formation of prosencephalon dividing into 𝗘𝗏 and 𝗏𝗏. 𝗘𝗏𝗏 will form the cerebral hemisphere. 𝗏𝗏𝗏 will form the thalamus, hypothalamus, metathalamus, subthalamus, epithalamus. Mesencephalon will lead to the formation of midbrain. It is not dividing as forming any secondary brain vesicle. The rhomben will form mittencephalon, the pons, the cerebellum medulla oblongata, and the cavity of dancephalon is third ventricle. The cavity of the telencephalon is lateral ventricle. The cavity of midbrain is cerebral aqueduct, and the cavity of mitten and man is fourth ventricle. So what is the function of these ventricle? Large amount of lateral ventricle ependyma forms the cerebrospinal fluid, will pass in the third ventricle via interventricular foramen of Monro, will further pass via cerebral aqueduct into the fourth ventricle, and this is how the CSF moves. And from fourth ventricle via opening in the roof of fourth ventricle, that is foramen of Mazendae and Luschka, it will communicate and will reach the subarachnoid space. Now, another important point, which is another important questions as we consider about the derivatives which is asked, is the derivatives of 3 germ layers. Okay, so 3 germ layers primarily are ectoderm, mesoderm, and endoderm. So you have to know about the derivatives of ectoderm, meso, and endo. So actually, if I talk about mesoderm, it will further divide into lateral mesoderm, intermediate mesoderm, and paraaxial mesoderm. Endoderm, we have to know the derivative. So here actually endoderm, basically in this diagram, yellow color is for endoderm, red color is for mesoderm, and blue color is for ectoderm. This is ectoderm layer, and this is mesoderm, and this is endoderm. Okay, now also I want everybody to know, so basically many important things has been asked. So one of an important question which is asked is NCC derivative. So actually during the formation of these germ layer and formation of neural tube, there was migration of migratory cell forming neural crest cells which lead to the formation of important structures. So for your examination, neural crest cells derivative, what is the full form of NCC? Neural crest cells. NCC full form is neural crest cells. So neural crest cells will lead to the formation of many important structures. So there is a mnemonic for you to know the derivatives of neural crest cells. What is it? It is CA motile as. This is CA motile as. So when I am talking about CA motile as, here C stands for craniofacial structure, A stands for arachnoid and pia mater, the leptomeninges of the brain. Together, arachnoid and pia is called as leptomeninges of the brain. M for melanocytes. Okay, here M stands for melanocytes, my dear students. And O for odontoblasts, T for tracheal cartilages, E for enterochromaffin cell, adrenal medulla. Actually, it is very important for you to note down that adrenal medulla is derived from neural crest cells and not the adrenal cortex. Laryngeal cartilage, L, A for all types of ganglia, parasympathetic ganglia, all other ganglias, Swan cells for S, and another S for spiral septum, which is also called as the spiral septum, which is actually the septum in relation to the heart development. Okay, which is dividing the aorta and the pulmonary trunk. Okay, conotruncal septum. Spiral septum is also called as conotruncal septum. So actually, I just want everybody that you should be remembering NCC, that is neural crest derivatives, that is CA motile as. Now, surface ectoderm. So ectoderm, mesoderm, and endoderm, these are the derivatives which you have to know. For surface ectoderm, you just remember the important structures, outer aspect like the epidermis, the hairs, the mammary glands, the nails, the anterior pituitary, the enamel of the teeth, the internal ear, the lens of the eye, and the corneal epithelium. These are most important derivatives of surface ectoderm. Neural tube will form the brain and the spinal cord. Now, as I told you, the paraaxial mesoderm. So if I talk about the paraaxial mesoderm, it will further divide into three parts. So you can see this in the center, there is neural tube. So in the center, there will be the neural tube formation. Okay, there will be. So basically what happens, there will be actually division of mesoderm into three parts. That is called as paraaxial mesoderm, which is lying very near to the neural tube and the developing part of the central nervous system parts. And then we will have the lateral part, that is called lateral mesoderm, and then the part of mesoderm which is lying between the paraaxial and that of lateral mesoderm, which is called intermediate mesoderm. Now it is very important that you should be knowing the derivatives of intermediate mesoderm. You should be knowing the derivatives of lateral mesoderm. You should be knowing the derivatives of paraaxial mesoderm. Now, if I talk about intermediate mesoderm, it is giving rise to the urogenital system and adrenal cortex. I told you adrenal medulla is derived from neural crest cells, NCC, but if I talk about adrenal cortex, it is derived from mesoderm. Which part of mesoderm? Intermediate mesoderm. Paraaxial mesoderm. Actually, the paraaxial mesoderm will further divide into dermatome, myotome, and sclerotome. So it will form skeleton muscles of trunks and the limbs. It will form muscles of trunks and the limbs. Dermis, dermatome will form dermis of the skin, and the vertebrae will develop. So basically, these are the derivatives of paraaxial mesoderm. If I talk about lateral mesoderm, it will form layers, coverings. It will form connective tissues, muscles, viscera. It will form serous membrane covering of pleura, pericardium, and peritoneum. It gives rise to the development of central nervous system and spleen. Now, my dear students, we are left with the derivatives of endoderm. So, to remember the endoderm, it is giving rise to derivatives of the structures like epithelium lining of RT means respiratory tract, GIT means gastrointestinal tract, urinary tract. Epithelium, also not only the epithelium lining of this tracts, that is gastrointestinal, urinary, and respiratory, it also gives derives the epithelial parts of the thyroid gland, the tympanic cavity, also the AT for auditory tube, the tonsils, the parathyroid gland, liver, and pancreas. So all these are the structures which are derived from endoderm. I want everybody to know the derivatives of endoderm, the derivatives of mesoderm, the three parts of the mesoderm, the lateral mesoderm, the paraaxial and intermediate mesoderm, the derivatives of neural crest cells, the derivatives of surface ectoderm. This is repeatedly asked in your examination. Okay. Now, my dear students, it's also important for you to know about adult derivatives of two important structures. So, I would like to tell about the mesonephric duct and paramesonephric duct. Actually, if I talk about about these two important things, mesonephric duct is actually also called as Wolffian ducts. Why it is called as Wolffian duct? It is giving rise to mainly the male structures like duct of epididymis, vas deferens, which is also called as ductus deferens, seminal vesicle, and also the ejaculatory duct. So mesonephric duct, which is also called as the Wolffian duct, is majorly giving rise to the structures, male structures. And in case of female, it is forming just one structure, which is called as Gartner's duct. So many times this has been asked in examination that Gartner's duct is derived from which embryonic structure? The answer is Gartner's duct is derived from mesonephric duct. If I talk about paramesonephric duct, it is mainly giving rise to the structures of female like fallopian tube, uterine tube, the uterus, the cervix, and the upper part of vagina. And so many times in the previous year of examination, it has been asked about the derivatives of paramesonephric duct in terms of male. So in terms of male, it gives rise to two important structures, the appendix of testis and prostatic utricle. So these 2 points are very important for your derivatives of mesonephric duct and paramesonephric duct. The other name of paramesonephric duct, it is also called as Mullerian duct. Okay. So please write down most important topics of anatomy considering FMGE examination. Okay, my dear students, so have a look of most important topic at the end. Yeah, so most important topic, ma'am, is very important for you. So most important topic is very, very important for you, and you can't leave this topic. So I just don't want you to leave it. Yes, dear. Notochord derivative is nucleus pulposus of intervertebral disc. So notochord derivative you want to write. Please write down notochord derivative is the nucleus pulposus of intervertebral disc. So please write down notochord derivative is nucleus pulposus of intervertebral disc. Okay, nucleus pulposus of intervertebral disc. Okay, dear students. Now, important topics of anatomy. So, general anatomy, all joints with example. All joints with example. Okay, my dear students. Upper limb will be brachial plexus, radial nerve, ulnar nerve, median nerve. Anatomical snuff box, carpal tunnel, brachial plex injuries, cubital fossa. Okay, these are the most important. Actually, all these nerves and clinical anatomy. So, brachial plexus, radial. So, the RA, this is radial nerve, my dear. I have written in short form. I think you can understand, and the clinical anatomy. So, I have given you so many cases of wrist drop, so many cases of clasper Benedict's defect. So, ape thumb deformity, policeman tip deformity, Orb's Duchenne paralysis, Klumpke's paralysis. So many clinical aspects, Foreman test, pen test. So all these are very, very important. Okay. Other than that, lower limb. Lower limb topics, which is very important, is femoral triangle, femoral hernia, adductor canal, also the popliteal fossa, also the nerves of lower limb. Okay, so you should be knowing about femoral nerve, you should be knowing obturator nerve, sciatic nerve, tibial nerve, and common peroneal nerve. Also, I want you to know the branches of lumbar plexus. And I want you to see the images where I have shown you about branches of lumbar plexus and the images which is showing cutaneous distribution of all the nerves of upper limb and cutaneous distribution of all the nerves of the lower limb. Okay, thorax. You should be knowing about the mediastinum in detail. You should be also knowing about constrictions of esophagus. Constriction of esophagus. Diaphragm is a very important topic. Diaphragm openings. Coronary arteries and branches. Coronary arteries and branches like right and left coronary artery. What are these branches? What are important arteries? Like Ladd artery is the most important artery involved in myocardial infarction. Abdomen. Actually, in the few years, the question is being asked by the abdominal planes. Abdominal planes. Level and the structures located. Inguinal hernia. Stomach, blood supplies. Stomach, blood supply. spleen ligaments, inguinal hernia. Also, you should be knowing about branches of celiac trunk, abdominal aorta, superior mesenteric artery, inferior mesenteric arteries. For the head and neck part, I want you to know all the triangles of neck. Okay, tongue. So head and neck part, tongue is also very important topic. Tongue. All the muscles of the tongue, for example, all the muscles of the tongue is supplied by 12th cranial nerve except palatoglossus muscle, which is supplied by vagus nerve carrying the fibers of cranial part of accessory. Safety muscle of the tongue. Can anybody tell me safety muscle of tongue? Which is the safety muscle of the tongue, my dear? Genioglossus. Okay. Then branches of ECA, maxillary artery, facial artery, subclavian artery. Okay. Also it is neuroanatomy part also. All the cranial foramens, cranial nerves passing. For the neuro part, neuroanatomy, syndromes, brain stem syndromes, spinal cord syndromes, circle of Willis, is the most important. Actually, many things are important. Cranial nerves also you have to know here. Cranial nerves, cerebellum nuclei, meninges of brain, cavernous sinus, meninges of brain, dural venous sinuses, and one of the sinus very important is the cavernous sinus. For the embryology part, germ layers derivatives. Actually, few things like derivatives, also the derivatives of ventral and mesogastrium, ventral and dorsal mesogastrium. And also you should be knowing about omphalocele and gastrochichis. Omphalocele. So omphalocele is the condition which is, so basically if I talk about omphalocele and gastrochichis, that is also very important for you to know. Actually, omphalocele is due to non-return of, if I talk about omphalocele, it is due to non-return of physiological herniated loop inside the abdominal cavity. So that is the case. Also correlated with the gastrochichis and neural tube defects. Like if it is also important that anterior, this has been asked, anterior neuropore closes and posterior neuropore closes by 25th and 28th day of intrauterine life. Neural tube defects, anencephaly and spina bifida. Then we will have the pharyngeal arch derivatives, pharyngeal apparatus, cleft lip and cleft palate, cleft lip and palate. This you will also see in the pediatrics part. And also the derivatives of mesonephric and paramesonephric duct. That's all. So that's all. Yeah, muscles of mastication is also important here. Muscles of mastication, we know that muscles of mastications are like masseter, temporalis, medial and lateral pterygoid, which is all derived from first pharyngeal arch, having the innervation from mandibular nerve. Only lateral pterygoid is the depressor of TM joint. All other is elevation of TM joint. It is causing depression of the TM joint. So basically, these are important points and these are the important topics. So please go through this. I have tried my level best to cover entire anatomy important topics, and I will tell you 80% questions are coming from this. My blessings are with you and you are sure going to crack the examination. All the best. Thank you so much.